Good morning. I am Victor Assay, and on behalf of our program director, Dr. Mark Gabriel, and our co-director, Dr. Howard Wong, and the Houston Methodist COVID Transplant Task Force, I would want to welcome all of you to this special virtual conference on COVID-19 and transplant. It's entitled Emerging Concepts, Transplantation in the Era of COVID-19 Pandemic. Needless to say, COVID-19 has had a tremendous impact on all our lives in so many ways, from the impact of our clinical practices in transplant and how we conduct research, as well as on our patients and how we are learning to care for these COVID transplant patients during this new pandemic. We have assembled a star-studded cast of speakers who have national and international reputation in this rapidly evolving field. This promises to be a wonderful virtual conference on COVID, and I would want to take this opportunity again to welcome everyone to this program. A lot of work goes into putting together such a program, and I wish to thank our project specialist, Ms. J.D. Pantoya, and the CME office, including the CME director, Chris Rawls, Juanita Young, and Cicely, for all their hard work in putting together this conference. We also want to thank our corporate sponsors who are displayed on the conference website. CME credits for the conference will be emailed to all participants. A few housekeeping tips. Throughout the program, you could submit questions through Poll Everywhere. This will be addressed by the moderators at the end of each session during the Q&A section. Needless to say, we have a great program, and without further ado, I'll turn it over to our co-director, Dr. Howard Wong, to give introductory remarks. Thank you.
Thank you, Victor. I want to thank our organization, the Transplant Center, and everybody involved in organizing this the meeting to put this together. As we all know, COVID-19 has had a dramatic impact on every aspect of our lives. And so today we're here to kind of focus on a lot of the lessons that we've learned over the past year and a half, and to kind of chart a new way forward, taking those lessons into consideration. And again, I want to echo Dr. Nkomasei's comments. Welcome to the conference, and I hope you take away a lot of great knowledge from this meeting. And so without further ado, I'd like to introduce our first speaker. Dr. Mark Boom is the president and CEO of the Houston Methodist System. He has been a fantastic leader throughout this pandemic, leading our organization through the ups and downs of this past year and a half. He is also a practicing internal medicine physician and actively seeing patients. And so he without further ado, I'm going to pass the baton to him.
Thank you, Drs. Nkomasei and Wong. It's great to be here today, and let me pull up sharing on my screen, and it is a pleasure to talk about what our team and wonderful people like these two gentlemen, as well as so many others who work at Houston Methodist, have accomplished this year. I'd like to talk a little bit about who we are, just to lay the stage of some of how we responded and the philosophy of how we responded. Some of the principles we put in place, some of the learnings we had along the way, and then really just some of the sort of things that happened throughout the year that I think were very positive in our institution. So we've been around for 102 years. We were actually founded during the Spanish flu pandemic. So we many times this year talked about the fact that we kind of have pandemics in our DNA and responding them to it in our DNA. And that really informed much of the culture, much of what we started with here early on throughout the pandemic. We're a very large institution, over 26,000 employees now. It's actually more like 900 employed physicians, about 8,000 affiliated physicians. A flagship academic institution, of course, that's where we're broadcasting from today. 6 community hospitals, an LTAC, a research institute, academic institute, et cetera. But what you note here, very importantly, is patients at the center of everything we do. And our culture really informed very much of our response throughout COVID. So to look at this slide, I pulled together a number of images to talk about really the important aspects of our culture. We are a faith-based institution. What you see at the top there is a beautiful mosaic that's actually used to be outdoors. It was installed in 1963. About 4 years ago, we moved it indoors into a new building. So that faith basis, we are values-based: integrity, compassion, accountability, respect, and excellence. That spell I care, of course. We very much are focused on the patient at the center of everything. And on the left, you see what we would call our vision for the second century: 6 simple words, but words that came into play every single moment of this pandemic, which is we were always going to be unparalleled. And it would be in those fundamentals: safety always first, but quality, service, and innovation as well. And then finally, our tagline, leading medicine, which is an important piece of this as well, because many times that has informed really where we felt like we should be vis-a-vis the nation and the world as we did the planning. This is kind of the graph we've lived by, for this last 15 months or so. What you see is in the greater Houston region, we had not that big a surge, honestly, that first time. We had a huge shutdown that had all the impacts, but not that big a surge. But then had a very massive and extremely rapid surge that happened this summer, really tested everybody. Came back down and then had a very large, actually not as rapid an increase. Ultimately, obviously, the area under that curve is way bigger, so way more patients. We were peaking at about 35 to 40% of the beds that were operational in the system filled with a patient with COVID in a given time. And now you see we're sort of in this steady state in our community with a slight decline, still not quite at the levels we got to in the fall, and not anywhere near the dip that we had last May. One of my favorite quotes comes from Louis Pasteur, and of course, who better to quote from during a pandemic? It actually ties together with how I was raised. My father, one of his favorite quotes was "Luck beats brains any day." And as I got older, I liked that quote, and then I started thinking about it and investigating a little, and said, I don't think it's quite right, because it's not that luck just happens. Luck happens because you're prepared. So this is Louis Pasteur's quote. And I think what happened to institutions like Houston Methodist, what happened to many other great institutions, is many of the things that have been done for years, sometimes decades, even centuries, really came to play during this pandemic. And I'll reference back to this a couple times along the way. So when I roll back to last, early March, late February, early March, as we were really, gearing up, for the communication part of this, we'd been preparing for quite a bit before that. We really came up with a few guiding principles, and those have served us well. And most of these, our guiding principles, we put down on paper day one. Some of these, couple of these, kind of over time, we realized, hey, we need to add something, or as we watched what we did or recognized what we did, we realized they needed to be added. So of course, I mentioned our unparalleled safety, quality, service, innovation. We would put those first and foremost every single time. But very importantly, people need to understand what the vision is. People need to understand what the goals are. People need to see in a crisis situation that you're transparent, that you talk about the good things, you talk about the bad things, you acknowledge mistakes or decisions sometimes that are made that seemed right at the time, that 5 days later you realize were the wrong decision, which is, it's happened in every disaster I've ever been part of. We recognize that you could never over communicate. And so we really set about a very diligent strategy to communicate. We've been a very successful institution. We have a strong balance sheet. And, what I worked on with the board very early was to say, the reason we have a strong balance sheet as a not-for-profit is exactly for a time like this last year. And I'll talk about some of the things we achieved with that. But one of the things I'm proudest of is not one single furlough, layoff, pay cut in our institution this year. And not many institutions can say that. It also meant that when, I got a call from the head of the laboratory saying, hey, actually, I was usually calling him saying, how are we going to do more tests? And he'd say, well, this is what I need. I'd say, buy it. When we'd say, well, we can get a shipment of this PPE, we'd say, buy it. And on like that. And that has served us very well. Also, had we had a very weak balance sheet, it's much more difficult as a leader to do that. We obviously dedicated significant resources in the research realm, and we're focused on doing that and being a leading institution in answering some of the questions and hopefully some solutions for COVID. We recognized we needed to stay data-driven every step of the way and stay apolitical. Right at the beginning, that wasn't as big an issue, but as we all saw in the spring and all the way to now, that has unfortunately been one of the themes of the pandemic that no question has resulted in, I think, much worse results for our country and the world than if we had been able to stay, not we Methodists, but we as a society had been able to stay out of the politics. And that we would need to take a stand when it matters, and we would stand up and do the right thing. So give you a little more detail on a couple of those. At several times during this pandemic, we would try to be as crystal clear as we possibly could with the goal setting. So an example, you see two examples here. One of those on the left was in kind of the mid-May timeframe of last year, mid-April timeframe last year, going into May as things were opening back up after the first surge. And we set these 5, starting, of course, with being the safest system anywhere, but also setting some pretty significant goals, like getting volumes back to normal, recognizing that people were being harmed by delaying care and avoiding care. What I later wrote about and we'll talk about as what I considered a sacred and, that we needed to focus on both patients with COVID and patients without COVID, which was a tough message sometimes for some of the politicians to understand, who were kind of in that lockdown mode at many times. And very importantly, as I said, keep figuring out how, we're not going to shut down, how we will keep full operations during another surge. And we set another set of goals after we came through the surge, the next time. And we've been very clear, I think, with our goal setting throughout. I can't overemphasize the importance of transparency. And that is both internal transparency, as I mentioned, talking about what's working, what's not working, discussing things, explaining when things change, explaining why we make decisions, and communicating and over communicating, but also from an external perspective. So very early on, we decided, look, the public wants to know, they deserve to know. And so, of course, tons and tons of transparency, as you would see on the left there, around the educational side and the science. And we continue to do that. And obviously use our website, social media, many other realms for that. But you can go to our website every single day during this pandemic. Once we put this up in the first week or so, and you can pull up the curves, there's 4 main curves. I'm only showing 3 of them here, data points of what's going on within our hospital system. And then we applied that later to things like vaccines. And actually, it's interesting. I have tried to find many sites that do this, and very few institutions have done this around the country. But from day one, we said we're putting up the number of vaccines we administer. We believe in the vaccines. These are the answer for getting out of the pandemic. And people need to know how things are going. And of course, around this, we would communicate the various ways to get vaccinated, et cetera. Communicate. I can't overemphasize this as a leader. And it's one of those lessons, I think, that, we all know, but sometimes it's easy to fall out of. And it's critically important in a pandemic, but it's frankly important anytime. And anytime you want to work with a group of people, making sure that, honestly, what I tell people in a leadership role oftentimes is, by the time you're absolutely sick of hearing yourself say something, that's right about when it's probably starting to get through an organization as large as ours, and you're getting to a lot of people hearing it and understanding it. We were very purposeful in our communication strategy. So we very early on created that strategy. We knew when it was something like X, it would be me talking about it. When it was a more detailed employee communication, HR issues, et cetera, it would be the incident commander, it would be human resources. When it was physician communications or clinical communications, it would be a chief physician executive. And that has served us well through this. The other piece we did very early on is we said, look, we're never going to say no to the press. I mean, I can't tell you we always, are happy with the press, or that every story angle they want to do is something we would support. But getting our voice out there, being a voice of reason, being data-driven and apolitical, you can't do that unless you're speaking to the community. And of course, education is so critically important during a crisis like this. And so all of us, I mean, the senior team, senior physicians, senior clinicians, scientists, I mean, we had a cadre probably of about 40 people that have all been, in the media far more this last 12 months than they, probably have cumulatively throughout their careers. And through this all, we learned some difficult things as well. In the greater Houston area, just to put in context, remember the curve I showed. So we got through a pretty, not that bad surge, but lots of shutdown and all the other pieces, with a society that was afraid to come back to work initially in early May, but then, a communication about that reopening that really did not put enough emphasis on the fact that, yes, we're reopening, but there are, trade-offs to reopening. And by Memorial Day, we saw society just sort of, acting like there'd never been a pandemic, and paid the price for that, obviously, this summer. And so the month of June was a month of political fighting, from the city, county, state, everybody else, the arguments about masks, everything else. And at a certain point, when I kind of about had it, because I'm in a lot of those and having a lot of those conversations on both ends of that with people, I put together kind of what I saw as the 5 key things we all needed to just recognize, as difficult as they might be. First and foremost, and this has proven itself out now, obviously 10 months later, which is that science, especially biological science, is really, really messy in real time, right? Physicians, scientists, clinicians, nurses, we know this. We all follow the science, and we know that sometimes it bounces around as we're trying to figure things out, but the public was watching this in real time and really struggling with that. And very importantly, and I talked about this already a little bit, I wrote an entire president's letter, went out to the whole community talking about what I called a sacred and, which was the politicians and others were forgetting the fact that there were people who needed care who weren't COVID patients. And they also were not acknowledging that we needed to protect our staff and physicians. And I mean from PPE to the financial protection that I've already talked about. And then very pointedly that our political leaders had their own sacred and, which is they were all positing this as an or. And it wasn't. It never has been. You have to control COVID-19. You have to do everything you can do to protect the economy. And you need to educate our children. And we need to try to educate our children as safely and effectively as possible, which ultimately means obviously in person at some point. To society, our social lives need to take a back seat. And this has been a hard one for people to hear and acknowledge and recognize, and always been a challenge. And then, of course, that masks would be a means to accomplish. And so this was that taking a stand that I talked about, and that we as an institution really pushed these issues. So I want to move quickly now through a bunch of points where I think we've been very successful and where those cultural aspects have really led to success of our institution. So back in January, when you think about the chance favors the prepared mind, an institution that has been through a tropical storm that flooded the entire main institution, that's been through multiple hurricanes over the last 20 years, we understand disaster preparedness. And so we were ready, and we were getting ready from early January when this first became apparent this would probably hit. And did our first PCR in January. Actually, we're one of the first 19 in the country that were hospital-connected labs. We were the first in the city of Houston, followed by Texas Children's, and a couple of the others followed, months later in terms of their abilities because they were outsourcing. And this served us extremely well. In fact, our main issue was we couldn't use the test because we couldn't get approved. We had it way before we could get it approved, and we're using it, right off the get-go with this. We were also the first in the country right about the end of March to utilize convalescent plasma. And the study we put together, an observational study, basically found by May that you needed early infusion with high titer antibody as an inpatient, and you actually could make a big difference. And then, of course, we saw lots of kind of back and forth over the next 6-8 months. Unfortunately, even this became politicized. And then in January, we saw the randomized controlled trial that confirmed exactly what we had seen back in April. And so we've been a major user of convalescent plasma throughout. In fact, that work led to a visit this summer of both the Surgeon General and the Deputy Secretary of Health and Human Services to visit our team and find out how our team had done that throughout. We participated in dozens and dozens and dozens of major trials. Really, our attitude was, if we could pull it off, we would do it. As I said, we put tons of resources into this. And in fact, we actually mobilized the community as well. We've ended up with dozens of very important papers in very impactful journals as a result of this. And we mobilized the community around an infectious disease research fund, which was a philanthropic fund that helped really catalyze a lot of this as well. And this will ultimately lead to infectious diseases being our 7th complete center of excellence at Houston Methodist. Dr. Jim Musser, who heads up our Department of Pathology and Genomic Medicine, who really has done so much of the work I've already been featuring, is leading that up. And we're very actively and hopefully very soon closing an important recruitment for the development of that as well. One of the other things that we've done and many other hospital systems around the country have done is we've really had to step in and oftentimes fulfill a public health typical responsibility. And so we have done more genomic sequencing at Houston Methodist than pretty much anywhere in the United States. Essentially every genome of COVID that's come through our doors has been sequenced at this point in time. And it's led to very important work because we found in early January, the first UK, the first Brazil, the first South African variants in Houston. And then by early March, really we're the only data source to be able to publish where that was going. And so in mid-March, what you see here is that the UK or the B117 variant really was taking over Houston. We were already at 70-ish%, as you see there, and projecting out that it would come up within about 30 to 60 days into the 90 to 100% range. And sure enough, last week, we had 90% UK variant in the greater Houston area. And this is critically important as we've now found the variant coming from India in the community for the first time. And again, the best surveillance that is happening in our region. We also put the foot on the accelerator big time when monoclonal antibodies came out, recognizing what a key answer they were to this issue. You can see the infusion, of course, rapidly and grew, and then of course now for demand reasons, which is good, of course, that the volume of patients is down. But I think this is probably about as many as have been done anywhere in the U.S. We've ended up being visited and ended up working now with the Biden administration as one of three institutions in the country on best practices around this in case it's really needed in big ways in the future. Actually, have been published in the New England Journal of Medicine Catalyst if you're interested in reading about the details of how we rapidly stood up those complex clinics to do that. We've created a big database of every patient with COVID linked to clinical data. So for example, when you look at that data around the B117, it's not just, oh, hey, it's interesting we have B117 here, but we're actually able to link that to the clinical outcomes of every patient. And so you'll see continued significant research from that. And then finally, in terms of things we've really propelled fast, we've really pushed on the vaccination front. This is fun photos from the very first day and actually some of the very first people who were vaccinated at Houston Methodist. And since that time, we have actually, as of today, this is yesterday's, as of today, we are at 699,000 doses and change, which is really phenomenal. Of course, it's starting to slow down a little bit, mostly second doses now. First doses are slowing down, but we are continuing to push and look for ways to promote that. In fact, we were so effective in the state, we're the #1 in the state, that the governor came and visited us about a month into this on January 19th, basically, as you see on the bottom right, saying, we celebrate and highlight Houston Methodist, encourage others to copy their example, because really we were able to, use vaccine as it came in each and every week and have led the way in that. I'm very proud of our teams for the hard work that's reflected. And just as I've mentioned, a couple of political leaders, we've actually, as I mentioned about staying apolitical, I don't care what side of the aisle someone's on. I just care if they can help solve problems. And we've worked with individuals at the federal level, at the state level, and of course at the local level. And here's, not everybody, but a long list of people that have been very helpful and who have been people oftentimes on speed dial. Many times some of these are 11 p.m., not so much now, of course, but earlier, 11 p.m. at night phone calls for me, and many times troubleshooting either us for them or them for us, and really appreciate the work we've done with all of them. We've also pushed the vaccine, as I've said. We've pushed the communication around the vaccine, the marketing around the vaccine. We started with really amplifying the message of they are safe, they are effective, we should all go get them. And then now, as things have changed, where they're much more available and the demand has declined. Now it's all about action. And so you can walk in, you can schedule, you can do all of these things, and we're in communities everywhere. You can see at least bilingually in many of these activities that we do. And then finally, on the vaccine side, in that context of leading medicine, in the context of a culture that was one of the first hospitals in the country to mandate flu vaccine a dozen years ago, in that context of patients at the center of everything we do and wanting to be the safest hospital anywhere, that unparalleled safety coming first. We were the first hospital system, and still there's only a couple of us still, although many are pretty soon, from the discussions I've been having with lots of people around the country, making this mandatory. And you see a couple of my quotes from one of the articles. I really firmly believe this is our sacred obligation as healthcare professionals to protect our patients in every single way we possibly can. And if we have these available, we should be using them. And that's the philosophy behind what we've done. And this is actually what we've seen kind of independent of the mandate, but just in terms of vaccinations. What you see in red is the number of infections we were having among our 26,000 employees per week. Of course, things were hitting the fan here in the kind of Christmas to New Year's timeframe, and you can see that. But look, as we ramped up vaccines, how we basically now have just a couple infections a week now among 26,000 employees. These work. And in fact, the mandate is working. We've gotten a lot of press. I mean, when you get into the articles, I think it's very positive and it reinforces who we are and the safety we have. But we've had a couple pretty angry employees who've been pretty vocal. We get it. And what we say is, listen, it's your choice. You don't have to take these vaccines. And if you choose not to, that's your choice. But we are requiring it as the safest hospital anywhere on the planet. And what you see on the right is how effective this has been. We are as of yesterday, we are 1 month from the deadline. So there's still a solid amount of time to get your first dose of Pfizer or Moderna. Obviously, there's still a month to get your single dose of J&J. And we are already at 96.23% of people who are either fully compliant or they're on the pathway of getting vaccinated at this point. And this has been going up very rapidly. Before we announced the mandate, it was about 84.5. And so I'm fully confident we will get there. And thankfully, hopefully only a handful of people who choose not to get this. And that is obviously our goal. The final thing I'll say is just what I know all of you have experienced is how important technology has been on this journey. Again, that chance favors the prepared mind. We were doing so many things around technology that when we had to turn on a bunch of things in a month, we turned on a bunch of things in a month, or we took things that we were already doing but hadn't been fully adopted and turned them on largely. And one of the things that's been very cool for us is we used something called CareSense, and we've used this to manage effectively those hundreds of thousands of vaccines that we've been doing. And so the bulk of those are managed through these pathways and through this CareSense pathway and this technology with hugely high satisfaction from our patients. So finally, with that, I'll wrap things up. I love this image that came out, on 3/19/20, so very early, but it's a great image to describe the great men and women who've worked at Houston Methodist, who've worked across the Texas Medical Center, who've worked across our country to care for patients during this pandemic. And thank you very much for the opportunity to speak.
Thank you, Dr. Boom. Yeah, I think I could speak for all of our colleagues. We're very proud to work at such an institution, with a forward-thinking approach. One question I have for you is, would you be able to speak about what we're doing to address the underserved communities and the people who have been hit particularly hard by the pandemic?
No, absolutely. Let me talk, I guess, now about, let me talk throughout. We saw very early on in our market, as did most markets, the underserved communities being disproportionately affected. During wave one, actually the data was mostly around African-American individuals in Houston. And then with wave two, that continued but diminished a little, and then massively with the Latinx community, with the Spanish-speaking community. And in fact, much of the burden of disease that happened in the summer was in that community. Actually, we ended up in three or four articles, as we had a New York Times reporter in bed with us at the hospital, and then featuring these stories. And part of that is featuring the stories and communicating to make sure that we're getting the word out of all the things that need to be done. Really, where that's most in action now, of course, is around vaccines. What we saw internally was that with a little bit of time and a lot of work, we could completely narrow the gaps across race and ethnicity very quickly. And so we really don't see any significant disparity internally. And of course, the higher of a percentage we get, the less likely that becomes. We're still seeing those disparities in the greater Houston community at large. We have done a number of things to focus on that. There's always a little bit of a push-pull between a high throughput vaccination campaign where, you just need to get to as many arms as possible. And of course, anytime I'm protected, I protect everyone around me, and so on and so on. And some of the activities that need to happen to help the underserved or homeless or homebound or others like that, where of course those are not high throughput activities. And so we've balanced those off with 9 sites that are high throughput, as well as rotating, roving kind of sites and community functions to get out there. Now what's happening with the vaccination, getting to some, not saturation yet, we got a long way to go, but it's a slowdown in terms of demand. What we're doing is we're shifting our resources from high throughput to much more even additional reaching out to the underserved. And so we will continue to push that. I'm very proud of what our teams have done. We have done essentially everything we can bilingually. We have done everything we can working with politicians, working with community organizations, working with faith-based organizations to go out into the community, create vaccination sites, create vaccination campaigns, and we'll continue to do so. And we partner with the city, with the county, with the other Texas Medical Center institutions to do all of that as well.
Thank you, Dr. Boom. That's excellent. And again, on behalf of our colleagues, we want to thank you for very strong leadership. One quick question before we end this segment. If you have to take away one important lesson that Houston Methodist as an institution has learned during the pandemic, what will it be? Just one major. You gave us quite a number of lessons learned, but if you have to pick one, which would that be?
I think it'd be, I alluded to it at the beginning, I think it'd be the same thing I'd say about every other disaster that we've been in. It's all about having the culture to do the right things. Disasters, whether they're a long-standing, crisis like this, or whether the usual that we deal with, which is, a few days around a hurricane or something like that. When you have the right culture, people across the institution all rally together, do the right thing, work together. And then really what you're working to do is enhance that culture, protect the people, make sure they have the resources they need, and the right things happen. And I'm just so proud of the people at the institution for doing those things all throughout.
Sure. Okay. Thank you very much. And we really thank you for taking time off your busy schedule to be with us this morning. We'll now move on to preliminary session number 1, which is entitled Overview of COVID-19 Infection. I have here my co-moderators that you've already met, Dr. Howard Wong and Dr. Kodali, who is also of the Houston Methodist Transplant Center. I would first introduce the first speaker in the name of Dr. Mark Kalskowski. He's a colleague of ours, a very leading expert in infectious diseases. He is professor of medicine at the Johns Hopkins University School of Medicine, where he's the director of Division of Infectious Diseases at the Johns Hopkins Bayview Medical Center. He also serves as the director of Viral Hepatitis Center in the division, and also the associate dean for research in the Capital Region. He received his MD from Temple and subsequently trained in internal medicine at Duke University. He completed his infectious disease fellowship in 1998 at Johns Hopkins University School of Medicine, and he's the principal investigator of more than 120 clinical trials related to the management of viral hepatitis B and C with and without HIV co-infection. He's a global PI for more than a dozen trials, including the largest clinical trial for the treatment of hepatitis C. He's a past chair of the Hepatitis Transformative Sciences Group of the NIH, Adult AIDS Clinical Trials Group, ACTG, where he held a leadership position. He's an elected member of numerous societies, including ASLD, EASL, and the Infectious Disease Society of America, ITSA. He has more than 300 peer-reviewed articles. He is widely published in the Annals of Internal Medicine, the New England Journal of Medicine, JAMA, Clinical Infectious Disease, Journal of Hepatology, and also General Hepatology. He's a highly cited researcher, defined as the top 1% of global researchers in 21 fields of sciences and social sciences, based on number of citations for papers. And he's lectured in numerous countries. And it gives me great honor and pleasure to invite Dr. Tsiolkovsky to give us our first talk, which is SARS-CoV-2, pathogenesis, natural history, and clinical features. Welcome, Mark.
Hello, and thank you for the opportunity to join you today virtually to discuss COVID-19 pathogenesis, natural history, and clinical features. I'm thrilled to be part of this exciting conference on COVID-19 and transplantation. I'm Dr. Mark Tsiolkovsky from Johns Hopkins University School of Medicine in Baltimore. There I've got several titles, but over the past year and a half, I've had the role of directing our clinical research related to COVID-19, so have certainly gained a perspective, as we all have, on this unique and terrible pandemic. As we start with the natural history, it's important to recognize that many people, maybe 20 to 30%, who are infected with COVID-19 do not develop symptoms. So at one extreme in the natural history, we have asymptomatic infection where someone acquires the infection, they recover without any negative consequences, even briefly. However, the majority of people develop symptoms sometime within 5 to 14 days after exposure to the virus. You can see on this figure depicted are some of the early symptoms of COVID-19. Congested runny nose, this unique feature of a loss of taste or smell, although there's been some reports that some of the new variants may have less impact on this particular pathognomonic feature of COVID-19. There's also headache, cough, sore throat, fatigue, and muscle ache are common features, and a unique interaction with the gastrointestinal system with nausea and diarrhea occurring in some people. And then, of course, as the disease progresses, if it does, there is the onset of shortness of breath or difficulty breathing. If we look at this a bit in more detail, this cartoon really highlights what people have thought of as the stages of infection. What I just described to you is what's listed here as early infection or stage 1. And that's where there are clinical symptoms of fever, cough, some constitutional symptoms. And then in many people, this will lead to a resolution of the infection. As the immune system responds, the virus is controlled and they recover. Now, we are still learning about long-term sequelae of early infection, and there are reports that some people have post-acute sequelae that are persistent. But the concern over the past 18 months has been people who progress into a pulmonary phase, where they develop a worsening pneumonia with shortness of breath, with increasing hypoxia, and on imaging, abnormal chest imaging. This can be linked to a liver enzyme elevation as well. These are people who are typically hospitalized, and many of these individuals will recover over time. The biggest concern and mortality from COVID-19 has been in this post-inflammatory phase, where instead of recovering in the 7 to 14 day period after infection, people worsen. This is generally linked to a high inflammatory markers, things like CRP, IL-6, D-dimer. There can be elevated ferritins as well, and a worsening ARDS picture. So this is a situation where individuals must be mechanically ventilated, and some recover, but we also continue to see relatively high rates of morbidity and mortality in this group, and certainly post-acute sequelae of COVID-19 are common among people requiring ICU level care. Now, along the bottom of this slide, which is now somewhat dated, we think of using antivirals early in the course of this pathogenesis. In this early stage, within, let's say, 5 days of infection, we think antivirals may be important, and there are some in clinical development. And we generally would not use host-modifying agents, although there are studies looking at things like colchicine and inhaled corticosteroids there. In the later phases, our therapeutics are targeting the host immune system, things like corticosteroids or dexamethasone, as well as anti-IL-6 therapies as well, such as tocilizumab. Now, I would point out, though, that particularly among people who may be immunosuppressed, the picture may not be that clear. In the later phases, we may actually need to use antiviral therapies in combination with host-modifying agents, and I'll come back to that point. I do want to spend a minute talking about what have been termed extrapulmonary manifestations of COVID-19. Importantly, I'll start with thromboembolism. There is felt to be an interaction of the virus with the endothelial system, leading to a heightened risk of deep vein thrombosis and pulmonary embolism. There have been a number of studies focused on how best to anticoagulate patients with COVID-19, and it's an area we've gotten better at. There can also be liver involvement with elevations in serum ALT and AST, although not typically fulminant liver disease. This is more a transaminase picture. Now, if we look on the other side of this figure, I already mentioned the gastrointestinal problems with respect to nausea and vomiting. There can also be abdominal pain. Patients are presented with what's rule out appendicitis, turns out to be SARS-CoV-2 infection. And moving up to the cardiac involvement, there certainly appears to be myocardial injury or myocarditis, even with a troponin leak that occurs in some patients. And these are non-lung manifestations. The neurologic system is also quite interesting in that there has been a clear evidence of stroke and other potential pathologies occurring, which can lead to persistent long-term sequelae that we're only now beginning to unravel. So what leads to this phase, this hyperimmune phase? Well, if we look at this cartoon, we still have a lot to learn about these steps. But really, the SARS-CoV-2 immune response can either lead to recovery or to more severe disease and even death. If we look at the cartoon at the beginning, the individual gets SARS-CoV-2 infection. Some individuals have a very rapid innate immune response, in fact, all do, and they control the virus with potentially low virus titers. These individuals then have the activation of their humoral and cellular immune response and can recover. So the normal immune response would start with innate immunity occurring almost immediately with an appropriate interferon response, as well as activation of Th1 cells and B cells that will begin to produce neutralizing antibodies. First IgM and later IgG. And in this top paradigm, individuals simply require supportive care, maybe transit hospitalization, and with a normal immune response, many will recover. Along the bottom of this figure is the hyperinflammatory state that I was discussing. And in this situation, the immune system becomes part of the problem. Now, there's some evidence these individuals may have a higher viral titer, perhaps an impaired or aberrant immune response, and they can begin to have what's termed loosely as a cytokine storm. And we have seen here that medications that dampen the immune response, dexamethasone and corticosteroids, tocilizumab or anti-IL-6, can appear to improve and prevent morbidity and mortality. But in these patients, they develop progressive lung injury, septic shock, organ failure, and unfortunately, as we've seen all too often over the past 18 months, death. So it's this aberrant immune response that is part of the problem that we see in terms of the accumulating disease. And it leads to this kind of mixed approach where on one hand we're using antiviral therapies, particularly early in the course of infection, and on the other we're using host-modified agents. And I think an important question is how does immunosuppression or immunodeficiency impact this when in fact we're using drugs like dexamethasone to temper or lessen this response. So let's look at risk factors for severe outcomes among persons hospitalized for COVID-19. There have been a number of studies. I've taken the liberty of selecting work done by Brian Garibaldi and others at Johns Hopkins in the Johns Hopkins Crown Registry. They've had 2 papers in the Annals of Internal Medicine. In the first analysis, they looked at 832 patients early in the course of COVID-19, March and April, and noted that the mortality rate was 13.6% at the time of publication. What they found was mortality was associated with increasing age. This has been seen in nearly every cohort analysis looking at indices of risk factors for mortality. The next factor was nursing home residents. Of course, there's an interaction with age, but it also captures the idea of frailty and other comorbid conditions. So nursing home residents may also have received a higher exposure. So a number of reasons why that may have come out early in the course of this pandemic. The Charlton Comorbidity Index, respiratory rate, and then laboratory factors such as D-dimer and detectable troponin levels, getting back to this myocardial injury pattern. So these have been seen in one form or another in other studies. We've also seen greater mortality in some cohorts among African American and people from the Latinx community that wasn't seen actually in the Johns Hopkins cohort. In a more recent study, they looked at 3,163 patients who were admitted with moderate COVID and asked the question, can we predict their clinical outcome? So in this cohort, 7% became severely ill or died within 24 hours of admission, and an additional 11% became severely ill or died within 24 hours of admission. The overall goal was to develop a trajectory that could be predicted. And they used a multivariate data analysis technique called RF-SLAM and came up with a model. So if you were to click on the link in the slide set, you can then punch in characteristics of your patient and predict outcomes. In fact, this is now being used in the EMR at Johns Hopkins to allow clinicians to better predict. Now, this is not the only prediction score. There are other prediction scores that have been published and presented, but in the interest of time, I've decided to stick with the one that came out of the Johns Hopkins Health System. Now, this is the CDC list for risk factors for severe COVID-19. Along the headers is the type of evidence that was used to determine this. So in meta-analyses and systemic data reviews, cancer, kidney disease, lung conditions, serious heart conditions, smoking, obesity, pregnancy, and diabetes, particularly poorly controlled diabetes, have stood out as potential factors linked to worse outcomes among people who acquire COVID-19. And certainly age is a major driver. These are the type of things that we use when identifying high-risk outpatients who may benefit from administration of monoclonal antibodies. If we look at this center section, these are cohort studies, case control studies, cross-sectional studies, so perhaps a less evidence available. And here, HIV infections is seen, neurologic conditions. Now, the data have been relatively mixed with respect to some of these conditions. So, for example, HIV co-infection has not been consistently, although many studies have linked HIV co-infection to worse outcomes. And the same is true to solid organ transplantation. While there are certainly case series and studies suggesting worse outcomes, there's a number of studies that I'll address that actually suggest that this patient population may have a similar outcome to other patients who develop or are admitted with SARS-CoV-2. Now, there may be some influences of their medical care that we can talk about. There's mixed evidence as well to people with underlying cirrhosis or liver disease and immunodeficiencies, although we'll talk about some of these in particular. So comorbidities are clearly risk factors. Now, what's not depicted on this slide is there may also be some viral risk factors, and we'll talk a bit more about the so-called UK variant, the B.1.117 variant. So before we get to that, I want to talk about immune-related risk factors for severe COVID-19. So as we look at older individuals, we know they have impaired B-cell and T-cell immune responses. There's a blunted antibody response to vaccine. This is seen, of course, with the influenza vaccine. When we think about infections, let's think about the chickenpox that comes out as shingles. Every decade of you get older, the more likely you are to develop shingles as the VZV virus emerges. There's also increased risk of sepsis among older people compared to younger. So the impact of age on the immune system is well recognized, in addition to other comorbidities and frailties. There's also an increased risk of superinfection with bacterial and fungal pathogens. So we know that patients who are on immunosuppressive therapy because of transplantation or chemotherapy that reduces their immune system often have comorbidities related to bacterial and fungal pathogens. So certainly immune-related factors. And oftentimes in our critically ill, mechanically ventilated patients, it's fungal pathogens and bacterial pathogens that have increasing burden. Now, this impaired B-cell response is interesting. I'll talk about a study that suggests that these individuals can have very prolonged infection and have difficulty in clearing the virus. Impaired T-cell response is a bit uncertain, but is likely plays a factor in contributing to the virus as well. So this interface between the virus and the immune system clearly plays an important role. Now, I mentioned I was going to talk about prolonged SARS-CoV-2 in immunocompromised patients. So a couple of interesting studies. The one to the right by Buckland and colleagues looked at a single patient with X-linked agammaglobulinemia. So in this individual, there's the absence of humoral immunity. And what you can see is persistent SARS-CoV-2 RNA detection in nasopharyngeal swabs and sputum swabs all the way out to 65 days. Now, what you see on the decline is where this patient was given convalescent plasma and remdesivir. And indeed, these are some of the most convincing data that I've seen for the antiviral effect of remdesivir. But the point is that without a humoral immune response, this individual struggled to clear SARS-CoV-2 infection. So as we think on the left of this slide, 71 patients with COVID-19 and solid organ transplantation, the median time to clearance was 32 days, but you can see some of these individuals with kidney transplantation in particular had persistence of detectable virus and out to day 60, so slower clearance. And one way that I've conceptualized this is people that have a weakened humoral response are more likely to have persistent infection. And certainly our liver transplant team and solid organ transplant infectious diseases team have utilized antiviral therapies later in the course of therapy. Similar to the figure on the right, they have used remdesivir as well as convalescent plasma, and more recently expanded access use of monoclonal antibodies in patients with immunosuppression, particularly hits to their humoral immune response, may require more aggressive antiviral therapy beyond our traditional thought process for COVID-19. Now, I mentioned I would come back to several studies on COVID-19 outcomes in patients with solid organ transplantation. So I've listed 3 studies along the top. The one to the left is from my colleague, Robin Avery, who is a transplant infectious disease doctor who has been extraordinary in caring for patients at Johns Hopkins Hospital. In this prospective cohort with 45 patients, Robin demonstrated no difference in mortality, as you can see by the overlapping figures of solid organ transplant and non-organ transplant. In a similar study, the one to the right is from Transplantation 2021, and in this was a case control study in which they saw no difference in mortality. And the middle study, for which you do not have a figure, is one from Barcelona published in PLAUS 1. And in this study, they used a propensity score matched approach and saw no difference among 41 patients. So several comments. These are small numbers of patients, but in these 3 studies, there were efforts made to control for potential confounders that may occur in case series. So clearly we need more data, and those data are being collected. But I do hold out the notion that people who are immunocompromised may have difficulty controlling this pathogen and may have at greater risk of more progressive COVID-19. But fortunately, these 3 studies, 2 from the US and 1 from Barcelona, really don't demonstrate major worsening of outcomes. Another potential confounder may be the excellent care that our transplant teams provide with early diagnosis, early linkage to care, aggressive treatment in the outpatient setting that may also help to reduce morbidity and mortality. Now I want to switch gears a little bit to talk about how this natural history is changing in May of 2021. We've had increasing COVID-19 vaccination, particularly among older adults. We've had the emergence of the B.1.117 variant, first reported in the UK. We've gotten better at patient management. We have earlier diagnosis because now people get tested. There's not a delay in testing. We're better at mechanical ventilation and anticoagulation than we were in the early 2020. And I'll also highlight that we have effective evidence-based treatments. We're no longer in the era of giving people colchicine and other factors such as hydroxychloroquine. We're now giving people who are high-risk ambulatory patients anti-spike monoclonal antibodies, and hospitalized patient remdesivir and dexamethasone. So evidence-based treatments, I think, are making a difference. So let's look at these in some detail. If we look at vaccination in the US, among those older than 65, nearly 80% have received at least 1 dose of vaccine, and about 70% are fully vaccinated. And overall, among those over the age of 18, it's 56%. So we've really vaccinated our older people who are at risk. Now, I will point out a study by Boyarsky and colleagues, part of the group at Johns Hopkins, recently published in JAMA, indicating poor anti-spike antibody response after a single dose of mRNA vaccine in transplant recipients. So there is the potential for our transplant recipients to be less well protected by vaccine, although time will tell as we get more data. So we have seen a change in who gets hospitalized by age and who's getting infections. So what we're seeing now, not surprising from the vaccine data, is that older people are making up less of the infections that are occurring in May 2021, and we're seeing younger people. Again, not a surprising mix, but that does potentially mean a better prognosis with respect to natural history. But there's a counter activity of the variants. As this demonstrates, taken from the CDC website, we've seen the emergence of the B.1.1.7 variant now making up nearly 60% of the lineages identified in different parts of the United States. So it's fair to say that as we are here in May of 2021, that the B.1.1.7 variant has emerged as a dominant pathogen, which was predicted based on early data from the United Kingdom. Now, what's the impact of that? Well, there is evidence for increased hospitalization risk within 14 days. The hazard ratio is 1.34, and in the public health system in England, there was, after adjusting for sex, age, and other factors, this variant was more likely to lead to hospitalization and potentially a higher fatality rate. So in preliminary data, the relative risk of death was 1.65. So the good news, of course, is that this variant appears to be covered, if you will, by the vaccine. So if we look at these kind of competing trends, we've got higher vaccine, we've got younger age, but we also have the emergence of a potentially more harmful variant. Well, how's that playing out? Well, the good news is that we're seeing a decline in hospitalization And among those hospitalized, we are seeing a shift towards younger patients. There is some concern we'll also see a shift towards patients with immunosuppression, including solid organ transplant, but we need more data to confirm that. And then the other piece of excellent news is that death due to COVID-19 is declining. This is occurring despite the emergence of this UK variant, the B.1.1.7, and this has to do with a lot of factors already mentioned, including more appropriate use of supportive care strategies, antiviral strategies, and a shift towards a younger population. So to summarize on the COVID-19 pathogenesis, natural history, and clinical features, COVID-19 is highly variable, ranging from no symptoms to death. Factors certainly include the virus, potentially a higher viral inoculum, a different viral strain, and host characteristics, including immune response. The data on solid organ transplant outcomes are a bit mixed. I would highlight the potential for prolonged viral replication, which may impact treatment decisions. And finally, like all things COVID, it will change. We're already seeing a change in the United States on the natural history and clinical outcomes. This is due to vaccination, improved care, and evidence-based treatment. So as we continue to learn more about this important virus and focus more on long-term sequelae, we certainly will see changing clinical course of patients, but hopefully the improving trends that we're seeing with less morbidity, less mortality will continue and be extended around the world. Thank you for your attention.
Good morning to everyone. It was a great talk. Thank you, Dr. Sulkowski. I want to just quickly go over a couple of housekeeping items. Please send your questions, which will be discussed at the end of the session. And you can either join by web and go to pollev.com and enter DBakey, and please send in your question. Also, folks who are joining through their cell phones, they can actually text us the questions. Text DBakey to 37607 and please send in your message or your question, and we'll discuss it at the end of the session. Now I'm going to go ahead and introduce our next speaker. It's my pleasure introducing Dr. Randall J. Olson. He is a current medical director for the Molecular Diagnostics Laboratory and Special Testing Laboratory at Houston Methodist. Dr. Olson is also the medical co-director of microbiology, laboratory and professor of clinical pathology and genomic medicine for the Houston Methodist Research Institute, while also serving as the adjunct associate professor for the Texas A&M University System. He will be speaking about SARS-CoV-2 diagnostic tools, pearls, and pitfalls. Welcome, Dr. Olson.
Good morning, everyone. Thank you for the very kind introduction, and thank you to the organizers for inviting me to present today. As mentioned, my name is Randy Olson. I'm the medical director of our molecular diagnostics lab, and today I've been asked to talk about diagnostic tools for SARS-CoV-2, and in particular highlight some pearls and pitfalls that we've discovered during the Houston Methodist laboratory experience. So I'd like to start out by emphasizing that our laboratory is continuously preparing for the pandemic. And this early preparedness was really essential for our success with SARS-CoV-2. That is, over the years, our lab has rapidly developed, validated, and implemented PCR assays for pathogens causing outbreaks and are otherwise reason for global public health concern. So our first drill really began in 2009 with the H1N1 influenza pandemic. We subsequently repeated the drill with Ebola virus, MERS virus, chikungunya virus, and Zika virus, and now most recently with SARS-CoV-2. So by way of a little bit of background, and this background is important for understanding how laboratory tests are developed. Coronaviruses are a large family, meaning there's a very large number of different coronaviruses that are positive sense single-stranded RNA viruses. They may infect many different host species, but most important for today, there are 7 that infect humans. 4 of these are common coronaviruses that are the cause of about 1/3 of your common upper respiratory tract infections. And these will often be tested on various respiratory pathogen panels. Important, these should not be confused with SARS-CoV-2. The other 3 human coronaviruses are highly pathogenic, genetically distinct types, namely SARS, MERS, and SARS-CoV-2 that have recently emerged. And importantly, the genetic distinctness allows us to develop specific laboratory tests to detect each virus. So the SARS-CoV-2 genome, as shown here in the schematic, spans about 30 kilobases, so it's 30,000 base pairs in length, across multiple open reading frames that encode a variety of different non-structural and structural proteins. For example, the spike protein is the major surface antigenic protein, and of course, the target of many of our monoclonal therapy antibodies. In general, SARS-CoV-2 assays will detect a specific target to the virus. And with that specificity, we can limit cross-reactivity with other viruses. I also like to point out that not all assays are the same, meaning that assays created by different manufacturers may target one or more different regions of the genome or proteome. And that is to say that every brand of assay is a little bit different. So shown here is a timeline of the Houston Methodist experience with SARS-CoV-2. And it truly does begin with New Year's Eve 2019, when a cluster of pneumonia cases of unknown cause was reported in Wuhan City. This sort of press release always gets our attention. Subsequently, the SARS-CoV-2 virus was identified, and then a couple weeks later, when the first US case was reported on January 20th, that led our team to activate our drill. The next day, we began to investigate options, review the literature, and began designing our first test. 3 weeks later, on February 14th, we had completed our validation study and had an approved standard operating procedure. 2 weeks later, on February 27th, we performed our first test. And then from there, the whole pandemic really rapidly escalated. Over the course of time, we brought in various automated instruments, as shown here with the Hologic Panther and Panther Fusion instruments, Abbott Alinity instruments, most recently the Roche 6800 instruments, and some other desktop instruments. And I'll speak to each of these a little bit later. We also brought in some serologic assays, and that brings us to this week, where we have now performed more than 555,000, so more than 500,000 PCR tests in our laboratory. So shown here is a graphical representation of the number of new patients testing positive in our laboratory over the course of time. And what I want to point out is that we've seen a series of 3 waves, initially a initial wave, followed by 2 massive subsequent waves. I point this out because with each wave of infection, meaning over the course of time, we've refined some of our procedures and learned a number of lessons that allowed us to improve. So when we talk about SARS-CoV-2 tests, there are really sort of 3 categories of tests available. First are the rapid antigen tests that detect viral proteins. These tend to be very rapid tests, generating results often in less than an hour. However, in general, they suffer from poor sensitivity and specificity, meaning that they have a very high rate of false negative or false positive results. For this reason, our laboratory has elected not to use them to date. However, there are some newer options coming in to the market that we're now evaluating. Second are the nucleic acid tests that detect viral RNA. So these PCR type tests also generate fairly rapid results, typically around 4 hours of runtime. However, they have a very high sensitivity and specificity, meaning that their rates of false negative or false positive is very low. They also have the ability to detect very small amounts of virus, down to 1 to a few copies in a specimen. And then finally, there are serologic tests that detect host antibodies against virus. So since these tests are detecting antibody and not the virus itself, they're not useful for primary diagnosis, but they are useful for detecting prior exposure to the virus, either through infection or viral antigens through vaccination. So to date, in our laboratory, and sort of in the spirit of being a rapid preparer, this slide was prepared a couple weeks ago, so April 22. We have performed over 500,000 tests on more than 280,000 patients. This means that we've generated approximately 5 to 10% of all the positive test results in the Houston metropolitan area. In our laboratory, testing is performed 24 hours a day, 7 days a week, and we support all of the hospitals in the Houston Methodist system, our affiliated facilities, such as our emergency departments, and also perform some reference laboratory services for other institutions. I'd like to point out that our median turnaround time for last month, April, was 3.9 hours from receipt in the laboratory and 7.5 hours from collection. So I think this is a very remarkable service that we're providing. So shown here in the image is Dr. Debbie Wally, who's one of our molecular genetic pathology fellows, standing in front of the Abbott Alinity M instrument. This is one of our newer automated platforms. And I show this just to really demonstrate the size of these instruments. They're very, very large, and that requires some specialized space. So one of our early successes is that we were very well prepared for a rapid expansion, meaning that to support SARS-CoV-2 testing, our laboratory relocated and centralized all of our COVID-19 testing to a new laboratory space that was dedicated to SARS-CoV-2. We were able to hire many new technologists, quadrupling the number of FTEs in our lab. So shown here is a photograph of our team back in March 2020. And you'll notice that this predates social distancing, it predates mask wearing and other precautions. If we were to take a similar photo today, we would have 4 times the number of people. As part of our expansion, we expanded the second shift and we added a third shift so that we could provide 24/7 service. Also, what was really, really important, particularly very early in the COVID response, was that we had a countless number of volunteers from labor pool and other lab sections that joined the laboratory effort. And they were critical to helping us maintain our testing service. And as I mentioned on the timeline slide, we were able to purchase 6 large automated instruments and many smaller desktop instruments. Another early lesson, this was very, very critical and remains critical today, is that sample quality is crucial for best results. And so very early, we discovered that there was wide variation in the technique used to collect nasopharyngeal swabs. And a very high quality specimen is needed, particularly if the viral load in the patient's respiratory tract is low. So to help close this knowledge gap, a team of pathologists and lab leaders trained the collection teams. We also created an online video that anyone could view when needed. So shown here is a screenshot of our video where Dr. Wesley Long, who's the medical director of our microbiology laboratory, demonstrates proper technique for collecting the nasopharyngeal specimen. Another early lesson was that we learned that we needed to distribute our testing across multiple platforms. meaning that we implemented multiple PCR platforms. We didn't limit ourselves to a single test. So each of our tests was granted an emergency use authorization by the FDA. And as I mentioned earlier, every assay is different, meaning that it runs on a different instrument, it uses different reagents, and it has a different operating procedure. Using multiple platforms was crucial for load distribution, meaning that by using multiple instruments, by using multiple tests, we were able to distribute our tests across those multiple platforms, which really helped to reduce our turnaround times. That is, we didn't get bottlenecks in queue for one instrument or another. It also helped us mitigate maintenance and unplanned downtimes, meaning that if one instrument went down, we could shift testing to another instrument or two other instruments. It also very critically helped us manage reagent supply bottlenecks. So a major challenge for laboratories, not only in the US, but globally, is that we've had frequent recurrent shortages of enzymes, reagent kits, pipette tips, and other consumables. So if one instrument, if one assay became temporarily unavailable, we could shift testing to one of the other instruments. So shown here in this image is Erica Walker, who's our developmental technologist, meaning her primary job is to help validate new assays, is loading samples onto one of our two Hologic instruments. Again, I point out that these are very, very large instruments and again require some specialized space. So our current instrumentation is as follows. We've got two Hologic Panther Fusion instruments. Each of these are capable of performing about 1,000 tests per day per instrument. And they can actually run two different assays. One is a real-time PCR assay, and the other is called a transcription-mediated amplification. So it's sort of a different flavor of PCR. I'd like to point out that this was our first automated platform and therefore was really, really important to our early COVID response. We now have also 3 Abbott Alinity M instruments. These two are able to do approximately 1,000 tests per day per instrument. And then most recently, we acquired a Roche 6800 instrument. It too can do approximately 1,000 tests per day. We also have acquired some desktop type instruments. The BioFires are able to do more rapid testing, but limited throughput, meaning that they do one sample per instrument at a time. So because of that reduced throughput, they were mostly used during our peak load times, again, to sort of distribute our testing to reduce turnaround times. There's now a multiple pathogen panel, a respiratory pathogen panel, that includes SARS-CoV-2 that is being used quite a bit with our emergency department patients. So it detects not only SARS-CoV-2, but other common respiratory pathogens like rhinovirus or influenza. And then finally, we've got Cepheid Infinity and GeneXpert and Roche Liat instruments. These perform very rapid tests, so nucleic acid amplification tests in less than 1 hour, but we're limited with very small supplies. So because of this limited supply issue, we've reserved them for emergency situations. And most recently, we've started deploying these rapid instruments to laboratories in our outside hospitals so that rapid testing can be performed on site, as opposed to waiting for couriers to bring those samples into our centralized laboratory. Another more recent lesson is that some patients may test positive persistently post-recovery, meaning a small number of COVID-19 patients, for reasons that still remain a bit unclear, can remain persistently or intermittently PCR positive for an extended period of time after recovery. So in our lab, we've seen patients remain positive for 12 to 20 weeks, or maybe even longer after recovery. And many other institutions have published this finding. Evidence suggests that these sorts of patients are not infectious. They're hypothesized to be persistently positive, either due to residual viral RNA, subgenomic bodies, or persistent colonization in the upper respiratory tract. The CDC recommends that these sorts of patients be considered positive. So the pitfall and pearl is, do not test for cure. The current guidance is you use best clinical judgment to designate a recovered patient. Quickly to finish, I'd like to talk about serologic testing. Our laboratory has validated 4 serologic tests for clinical use. The first is the SARS-CoV-2 IgG. This runs on our OrthoVitros platform, as shown here. This is a qualitative test that detects IgG antibodies against the spike protein. So the interpretation is that a positive result indicates prior viral infection or vaccination. Pitfall is that, as with all serology tests, it has low sensitivity early post-infection. As a pearl, this was actually the first FDA authorized test to be used for antibody testing in COVID-19 convalescent plasma donors. And as Dr. Salazar may touch on later, all of our convalescent plasma donors and recipients continued to receive this test. We've also validated a qualitative anti-spike total antibody test, meaning that as opposed to the previous one, this detects all subclasses of antibodies. It too will indicate prior virus infection or vaccination, and also suffers from poor sensitivity early post-infection. The third serologic test that we offer is a lab-developed test with ELISA. So this is a semi-quantitative test that measures IgG against the spike protein. Again, a positive result indicates prior virus infection or vaccination. The pearl here is that since this is a semi-quantitative test, it's one of the very few quantitative ELISAs that are available in the United States. And then finally, most recently, we've validated a SARS-CoV-2 nucleocapsid assay. So this runs on the Cova 602 instrument. It's a qualitative assay that detects IgG against the nucleocapsid protein. Importantly here, a positive test indicates a prior viral infection. That's because none of the currently used vaccines use nucleocapsid protein as part of its repertoire. So a positive result will be specific to infection. One pitfall is that this unfortunately does cross-react with antibodies against SARS, and it also, as other tests, has low sensitivity again early in infection. But again, the pearl is this test can be used to be specific to an antibody response to infection. So future plans for testing in our lab is we continuously are looking for new assays and new instruments. We recently implemented on-site testing at our outside hospital laboratories, but the number of tests performed is limited due to a limited supply of the reagents for those tests. We will soon implement on-site testing at some of our emergency centers. And again, this will be in very limited numbers. We are exploring new technologies. As I mentioned earlier, we're evaluating some of the newer rapid antigen tests. And we're also exploring the possibility of testing other specimen types, such as saliva. So with that, I will quickly close. I'll thank my colleagues in the molecular diagnostics lab, the microbiology lab, the diagnostic immunology lab, my chairman, and the leaders of Houston Methodist. Thank you so much.
Thank you, Dr. Ellison. Would like to introduce our next speaker, Dr. Kevin Grimes. But before I do that, just want to remind the audience to remember to either text in or enter your questions so that we can discuss them at the end of this session. So Dr. Kevin Grimes is going to be our next speaker. He will be speaking on current and emerging therapeutic options in COVID-19 infection. Dr. Grimes is the Deputy Chair of Medicine and an infectious diseases specialist. He has been instrumental in our response to COVID-19 and did some of the early clinical trials that brought remdesivir online, and he has continued to be actively involved in multiple clinical trials for COVID-19.
Okay, good morning. This is Kevin Grimes. I'm so happy to be here today. For those of you that don't know me, I'm the infectious disease doctor that works very closely with the transplant program. I was the infectious disease physician on call the day of March 14th of 2020, when the first cases start rolling into Houston Methodist Hospital, a day that will live in infamy in my world. Today, we're going to be talking about current and emerging therapeutic options in COVID-19, and I've titled this The Good and the Bad and the Ugly. A few disclosures. I was the investigator on the NIAID adaptive COVID-19 treatment trials since August of 2020. I was also the investigator on the Gilead Simple trial for remdesivir. I will have to note that the views expressed herein are those of myself and do not necessarily reflect the official policy or position of Houston Methodist Hospital or Sergio Leone. This will make sense in a moment, and will be some discussion about off-label and investigational agents. So this was my favorite movie growing up, The Good, the Bad, and the Ugly, and Sergio Leone was the director and producer of all the spaghetti westerns. So there will be some overlap in some of these talks, I'm sure. We will talk about essentially looking at the drug treatments in two main arms in this talk this morning. We'll be looking at essentially antivirals affecting RNA-dependent RNA polymerase, as well as monoclonal antibodies and passive immunity affecting the entry into the cell. So just some facts about COVID-19 that we know. There's a number of immunologic anomalies that have been identified in COVID-19 patients to date. We know that there's elevated inflammatory markers and elevated inflammatory cytokines, profound lymphopenia, and imbalance in JAK signaling, elevated macrophage and neutrophil chemokines, some T cell exhaustion, and an insufficient interferon response. So let's talk about the bad. The bad is the virus itself and what it does to the host. We all know that this is a disease of two phases, the viral response phase and the host inflammatory phase. In the early on in stage 1 of the infection, we see the viral response phase, and this is the typical cold and flu-like symptoms, some mild constitutional symptoms, fevers, dry coughs. Clinically, can start picking up early lymphopenia in the patients. Stage 2, we start to see the pulmonary phase where patients become symptomatic, shortness of breath, and hypoxia, as well as abnormal imaging. And then the worsening stage 3 is the hyperinflammatory stage, and this is what we want to prevent. The patient presenting and developing ARDS, shock, and cardiac failure. And this is when we'll obviously see these significant elevated inflammatory markers in the hyperinflammatory phase. In severe COVID-19, we see several things here, and one thing that's to note is the early on the viremia phase, but this does start to decrease once we see the pulmonic and the severe phase. We'll also notice that there are a decrease in T cells and B cells early on and progressively into the phase 2 and phase 3. And we also start to see elevated inflammatory factors and D-dimers. And this is all while viral nucleic acid is going down. So obviously, antivirals would want to target the early phase of this disease. So let's talk about the ugly. Poor Tuco, he never got any of the credit in these things. Sorry for those of you that have never seen the movie, you won't get some of my bad jokes here. Some of the ugly things we know that don't work. They've been touted, they've been politicized, they've been argued about, and some people still believe in them. But we think at this point we have enough evidence to show that hydroxychloroquine, azithromycin, zinc, ivermectin don't work. Lopinavir, ritonavir, and the other HIV protease inhibitors don't appear to work. Ribavirin, there was some thoughts early on that it might work, but it has gone by the wayside. Other early antivirals, favipiravir, that has also, the studies terminated early. There was one thought that interferon deficiency in certain hosts, as well as a lack of interferon in the later phases, may show some benefit. But one of the trials that we ran here, the ACT-3 study, that showed there was no benefit adding interferon beta to remdesivir versus placebo. So the good, always the hero here in these stories. So we want to look at two things we're going to use to attack the virus, and those are going to be two, either combating the virus itself or helping the host in the inflammatory stage. In combating the virus, we can look at a couple of different things. Remdesivir, which is now FDA approved back in October of 2020. This blocks the RNA polymerase of coronaviruses to inhibit viral replication. Another thing that has been studied extensively, and there are still some ongoing studies of commercial products of convalescent plasma, is essentially developing or presenting with passive immunity to help the host. And the newest, latest, and greatest things is monoclonal antibodies, bamlanivimab, casirivimab, and imdevimab, and I'm not pronouncing most of those correctly, and I'm not sure anyone knows how to at this point in time. So remdesivir. This is a adenosine nucleotide analog. It interferes with RNA-dependent RNA polymerase and gives a delayed termination of RNA transcription. This was one of the earliest studies that showed positive benefit of an antiviral, and this was the ACT-1 study. This was an international placebo-controlled randomized blinded trial organized through NIAID. There was over 1,000 patients internationally enrolled, and it showed a benefit in time to recovery of 11 days versus 15 days, and this was significant p-value here. There was no statistical significance in the 14-day mortality in this study, but there was a trend towards benefit. Another study that was done early on was the SIMPLE trial, which essentially showed that remdesivir was just as good in a 5-day regimen as it was in a 10-day regimen. I felt this was an important trial to do to provide drug to our patients early on in the pandemic, but also it was important that when EUA remdesivir came out, this data was available. And this summer during the second wave, we were able to essentially have twice as much drug to treat patients. So another study in another product that has been very impressive, something we've worked with extensively here, and Dr. Salazar led the way with this study, and he'll be discussing this a little further on, I believe, in his talk later this morning. But essentially, it's adaptive humoral immunity, and we're harvesting plasma from patients and giving that back to those that have convalesced and giving it back to ill patients. There has been various studies, some positive, some negative. I think the jury is still out on convalescent plasma. I would like to hear what Dr. Salazar has to say about this later. There seems to be some benefit in high titer product, but we'll let him talk about that a little bit more. Convalescent plasma has historically been used for many viral infections, and we've been using this for over 100 years. This was something that was seen to be beneficial in Ebola. Again, like I said, there's mixed data in various studies, and again, some are still ongoing. There are some signals that show that high titer is beneficial. Some of the outstanding questions are if convalescent plasma is definitively effective compared to placebo or other standards of care. What are the baseline antibody titers that we would need? When's the optimal timing to give this? My guess is it's going to be earlier rather than later, like the monoclonal antibodies. And optimal dosing with regard to donor antibody titers and the number of units to transfuse. These are all still up in the air at this point in time. So monoclonal antibodies. These are conceptually similar to COVID-19. Convalescent plasma, monoclonal antibodies are immune globulins with affinity for the pathogen-specific epitope. In this case, it's the spike protein that we've all heard about that's involved in the ACE binding pathway in entering the human cell. Theoretically, monoclonal antibodies given therapeutically may share the benefits of convalescent plasma without the additional risks associated with human blood product administration. Where it's unclear at this time whether we'll see other autoantibodies develop related to this. There's certainly some evidence that you may get transfusion-associated cardiac overload with convalescent plasma, and we don't seem to see these with the monoclonal antibodies. Some disadvantages is possible resistance and lack of efficacy, and their usefulness in sicker populations. Another concern is antibody-dependent enhancement, when antibody binding leads to augmented viral uptake in the human cell, so potentially could be a opposite effect that we're looking for. And so far, most clinical research in monoclonal antibodies for COVID-19 has focused primarily on early disease and prophylaxis, and there is ongoing studies regarding prophylaxis. So some of the evolution of these products and as they're coming out, most of us call bamlanivimab Lilly-Bam because it's easier to say. This came out and had an EUA that was given by the FDA in November of 2020. We here at Houston Methodist used a lot of this drug, and we're very proud of trying to keep people out of the hospital with administering this drug. Shortly afterwards, there was also an EUA for caricimimab and imdevimab, essentially Regeneron here, and mild to moderate cases, but essentially in outpatients and trying to prevent hospitalization and progression of disease. In February, the combination Lilly product with bamlanivimab and etesevimab was released and the EUA was approved. This is not quite out, and I haven't seen too many people get this yet. But we did get a little bit of a course correction as things evolved, and after the combination product with Lilly-Bam was out, the FDA then did a bit of a course correction a couple of weeks ago, and they removed the EUA for Lilly-Bam as monotherapy, and this is the first drug we're starting to see that may have some ineffectiveness due to the new variants, and the FDA felt that the potential risks outweighed the benefits of the monotherapy, but it still has its EUA with the combination product. And monoclonal antibodies in transplant patients, at this time they appear to be safe. There's no evidence of high rates of rejection, which was some of the earlier concerns, but there's more data that is needed in this population. So the other approach to therapy is trying to get into the later stages, the inflammatory stage of the pulmonary phase, and what can we do to prevent progression to severe disease. And some of these goals are reducing the host immune response. So corticosteroids, which are very popular these days, IL-1, 2, and 6 inhibitors, as well as JAK inhibitors. So helping the host. One of the most popular now after the recovery trial was dexamethasone. It is obviously a much broader, if you will, anti-inflammatory, affects multiple steps of the inflammatory process, decreases inflammation by suppression of neutrophil migration, decreased production of inflammatory mediators, and reversal of increased capillary permeability, which is important in the surge response and suppress normal immune response. This is obviously FDA approved for other things. The IL-6 inhibitor, which was very popular early on, tocilizumab. This is FDA approved for other indications, but was used widely early in the pandemic. There's been a mix of data on that, and my feeling is that there's likely a niche in certain critically ill patients that are progressing despite other therapies such as remdesivir and dexamethasone. Anakinra is an IL-1 inhibitor. This is FDA approved for other indications. Currently, trials are ongoing, at least Methodist with this drug. Izokizumab is another IL-6 receptor antagonist. This is an investigational product, and trials are ongoing with this. And baricitinib, which is a JAK inhibitor, which is FDA approved for rheumatoid arthritis, and this is studied widely during the ACT studies that we're going to talk about. So the recovery trial, this was the one that really got everyone starting to use dexamethasone, and I think essentially the take-home message on this is that there was lower mortality rates in those that were severely ill and mechanically ventilated patients. There's been few drugs that have shown benefit in the mechanically ventilated population, so this was an important finding. I think it has been expanded to be used in earlier on in disease, but it seems to make some sense as progress to prevent the progression in the inflammatory phase. So baricitinib, this drug has a short half-life. It's been FDA approved for rheumatoid arthritis since 2017, licensed in over 70 countries. This is oral, easy to give, has a good, pretty good safety profile, and inhibits the signaling of cytokines implicated in COVID-19. Some potential antiviral activities like we see in some of the other rheumatoid arthritis drugs like leflunomide. So we'll talk a little bit about the ACT-2 study that was a randomized double-blind placebo-controlled trial with a similar setup as the ACT-1. In this arm, in this study, there was remdesivir in both arms, and it compared baricitinib versus placebo. These were hospitalized patients with advanced ordinal scales. They did allow for sicker ICU patients, oxygen with radiographic infiltrates, and with the need for mechanical oxygenation. They were randomized to remdesivir for 10 days plus placebo versus remdesivir for 10 days with baricitinib, and they were stopped on discharge if the patient continued to improve. So the conclusions from that study did show that baricitinib, in addition to remdesivir, did improve outcomes with earlier recovery of the patients and earlier discharge. So then we were looking at what was going to be better, baricitinib versus dexamethasone. Dexamethasone obviously has some of its baggage. Steroids have issues, hyperglycemia, etc. And I've seen more than one patient go into DKA on steroids with COVID. So we obviously were looking for safer drugs at this time compared to dexamethasone. So there was probably some signals earlier on in both the recovery and the ACT-2 studies that showed there was a benefit of baricitinib in low or high flow oxygen population, and Dex certainly had a benefit in those that were mechanically ventilated. So ACT-4 was Bari versus Dex, comparing remdesivir in both arms with Bari versus Dex. Unfortunately, the study was terminated early as the interim futility analysis showed that we were not going to find a difference between the two. So the take-home message is they both work, they're both effective, and Bari is probably a good alternative when you can't use dexamethasone in certain populations. The only concern of a bit of a safety signal with Variance, there might have been a few higher clots. So for prevention, I think people will get into this later, but there's a lot of ongoing studies for prevention in high-risk or known exposures. And so you can break this down and look at what do you want to do with mild illness? Well, supportive care in mild illness, monoclonal antibodies are beneficial. Moderate illness, probably monoclonal antibodies in those that are not in the hospital and not requiring oxygen. In severe illness, those that are needing hospitalization, higher rates of respiratory rates, higher FiO2 requirements, remdesivir plus corticosteroids or remdesivir versus baricitinib will be beneficial in this population. And those that are critically ill, ventilated, ECMO, remdesivir, and steroids are probably the way to go. So what's in the future moving forward? I did a quick search last night on clinicaltrials.gov with the keywords of COVID and SARS-CoV. This yielded 5,512 ongoing trials. Obviously, you can't sort through all of those, but my opinion is we need better antivirals. As an infectious disease doctor, like a gunslinger, I like to kill bugs, and I would like to see some more effective antivirals. And here are some studies we have ongoing at HMH, and we'll all recognize many of these names. One thing to talk about that's an exciting technology coming up is CAR T cells. These have been beneficial in cancer and other viral illnesses, and we have a study ongoing here of CAR T cells against COVID. I would just like to recognize the AOCT team here that has been performing a lot of the research here at Houston Methodist Hospital, and just to show you that it takes a village to get these kind of studies done. Thank you so much.
Thank you, Dr. Grimes. That was fantastic. Before I introduce our next speaker, I want to remind everyone to please send their questions for the Q&A session. Our next speaker is Dr. Sussman. He received his MD degree and postdoctoral training at Yale. He's been a member of the faculty at Yale, Duke, and Cornell and Houston Methodist. He has served as a chair of radiology, a senior associate dean for clinical affairs, executive vice dean, president of New York Presbyterian Medical Board, and trustee of New York Presbyterian Hospital. After Houston Methodist got affiliated with Cornell, he became the chief medical officer, chief academic officer, and executive vice president at Houston Methodist, and chief executive officer of the TMH Physician Organization. He's currently emeritus professor of radiology at Cornell, distinguished member of Houston Methodist Research Institute, Ernest Cockrell Jr. Presidential Distinguished Chair at Houston Methodist, President of Houston Methodist Academic Institute, and Executive Vice President and Chief Academic Officer of Houston Methodist. In addition to his administrative profile, he's always been recognized as a triple threat in the classic academic tradition. He is an accomplished clinical radiologist practicing cardiothoracic imaging at university medical centers for more than 20 years, and was listed in New York's Best Doctors in America, and America's Top Doctors. He's lectured nationally and internationally, and he's performed innovative translational research in non-invasive vascular imaging and metabolic imaging with magnetic resonance, and he guided pivotal national and international clinical trials in venous thromboembolism that changed clinical practice. He's been the principal investigator of multiple studies and trials, and he's served on numerous NIH and private scientific advisory panels. He is also a founding member of the Society for Cardiovascular Magnetic Resonance and of the Society of Thoracic Radiology. He served as the president for the Association of University Radiologists, member of the New York State Board for Medicine, and counselor for American College of Radiology. He's also a chair of the Houston Methodist Vaccine Scientific Advisory Committee. Good morning and welcome, sir.
Good morning. It's a pleasure to be here. I'm honored to have been invited to speak to you all. I'm going to talk about the latest data with COVID-19 vaccines, and try to say a few words about their application in transplantation patients as well. So I think a lot of you know this, but just the basics of how the messenger RNA vaccines, which are the ones that are the most common by far. We at Methodist are using the Pfizer vaccine almost exclusively. Messenger RNA can be thought of as biological software. It instructs the ribosomes in cells to make a protein. It's delivered into the cytoplasm, activated and instructs the ribosomes to make the spike protein of the coronavirus. And then the messenger RNA is degraded with normal cellular nucleases. Importantly, it does not enter the cell nucleus or incorporate into DNA. There is absolutely no way it can do that. The urban legends about reverse transcriptase are totally fanciful. There's no consensus sequence for this messenger RNA to bind. So patients and others can be totally reassured that the RNA gets to the cell, does its job, and is degraded. The two RNA vaccines that are in common use have very, very minor differences. They're both nucleoside modified, Wuhan strain RNA encapsulated in lipid nanoparticles. The J&J vaccine is one of the viral vector type vaccines, and the basics are the same. A carrier delivers genetic material to the cell that instructs the cell to make the spike protein, but the details are quite different. The carrier is a viral vector. The genetic information is in the form of DNA. In addition to going into the cytoplasm, it must enter the nucleus. It must be transcribed into messenger RNA, which then has to exit into the cytoplasm to do its job, instructing the ribosomes to create the spike protein. So personally, I'm not a big fan of these. There's additional complications in steps that have to be carried out successfully, and obviously the potential for immunity against the adenoviral vector is a potential issue. The clinical trial results for all three of these vaccines are really spectacular. The J&J vaccine is a little bit less effective at protection from symptomatic COVID-19, about 72% in the US data compared to 95 and 94 with the Pfizer and Moderna vaccines. But all three of these are outstanding at protection from severe COVID and protection from hospitalization or death. In the clinical trials, all three performed 100% effectively. There are clearly some slight efficacy differences here, but the exact numbers you'll see are not something to get hung up on. It's clinical trial data versus RWE, different outcome criteria, different lengths of follow-up, different countries, which viral variants are circulating in the countries, and so forth. The message is that these vaccines all work brilliantly to protect one against COVID. The issue about whether a vaccinated individual can transmit COVID is partly a matter of viral load. It's partly a matter of whether the individual becomes symptomatic and coughs and sneezes. It's also a matter of whether they could be asymptomatic and still carry live virus that could then be transmitted. The data here is a little less clean than in the symptomatic disease, severe disease, and mortality data. The non-human primate challenge studies for all three of these vaccines show that they provide sterilizing immunity. And obviously, if there's no virus in your lungs or your nasopharynx, you cannot transmit it easily or at all. And asymptomatic infection appears to be probably protected against with efficacy similar to the protection from symptomatic infection. We obviously want to know what the correlates of protection are, and unfortunately this has not been nailed down, but it really looks like anti-spike IgG levels and specifically neutralizing antibodies against the receptor binding domain are going to be a very good correlate. We just don't know the exact titers that are going to be necessary. And this is going to vary with the different viral variants as well. Fortunately, the durability of the antibody responses looks really good. Here's just an example going out to 6 months for the anti-RBD antibody titers of the Moderna vaccine. Very stable, gradual decline, but very stable, very long-lasting antibody levels. That's pretty well confirmed by the clinical trial data for the Pfizer vaccine, which has now been extended to 6 months of follow-up, and there are 46,000 participants. 91% effective against symptomatic infection, 95% against severe COVID. For the FDA definition, 100% against severe COVID by the CDC definition, and 100% protection from death. Very, very similar to the 2-month follow-up data. The real-world evidence on vaccination totally supports the clinical trial results. Israel, the United Kingdom, and America are the developed countries that probably have the highest percentages of vaccination, and the results are looking really good. Israel, 96% protection from infection, and recently that country was able to celebrate its first day in 7 months without a single death from COVID-19. Scotland public health data, reduction in hospitalizations, reduction in household contact infections after a single dose of these 2-dose vaccines. A variety of English studies showing vaccine efficacies in the 70 to 89% range, 75% reduction in asymptomatic infection, 45% reduction in household transmission. And our own data here at Houston Methodist, very consistent with the CDC national data, reduced our employees' positive test rate by 95%. The fact that these are 2-dose vaccines is also confirmed by our own experience. In 91,000 patients who are, in the Methodist system with Methodist doctors, Methodist follow-up, in the first 4 months of the vaccine campaign, we found that a single dose was effective for preventing hospitalization or preventing death, but 2 doses were far more effective, and close to 100% for preventing hospitalization and mortality. For those who were unvaccinated, the hospitalization rate annualized and the death rate annualized, very consistent with the national statistics. I'm not going to spend a lot of time on safety here. This is probably of greater interest to the general public than the medical community, because really from the standpoint of the medical community, the safety is outstanding. There's now 6 months of safety data on large numbers of individuals in the clinical trials. Over 100 million people in the United States have been vaccinated already. A couple of rare reactions that were not seen in the trials have been seen with wide deployment of the vaccines. The severe allergic reactions in a few per million, mostly seen with the messenger RNA vaccines, probably related to polyethylene glycol allergies, but seen with the J&J vaccines at a lower rate. Some exuberant allergic type of reactions, extended duration of local induration in the injected arm, some systemic rashes, the blood clot risk with the J&J vaccine, probably from platelet factor 4 antibodies. Importantly, no increased risks seen in pregnancy. So I think you can, obviously, you need to be aware of these. You need to be able to counsel your patients, but you can give these vaccines with a clear conscience to just about everybody. So the data with the vaccines is great. It's far better than we dared to hope back in 2020, and it's just been virtually a medical miracle. But what could go wrong? Probably the biggest thing of concern to the general population is the viral variants. As you know, mutation and evolution of viruses is a totally normal phenomenon. SARS-CoV-2 actually is a relatively slow mutator. It does have some error checking capabilities, but the more than 100 million walking test tubes that we've had walking around the planet have given it a lot of opportunity to evolve. And it has quite extensively. You can see in the red here the development of the United Kingdom strain with the 501YV1 mutation, and the so-called South African strain with the 501YV2 mutation, and just the very exuberant arborization of different variants. Obviously, the concern is that some of these are going to increase the fitness of the virus in infecting the population. And as we develop more antibody selective pressure from monoclonals or vaccines or previous infection, this is going to exert selective pressure on the virus, and they're going to be motivated to evolve in a direction of resisting these treatments. And indeed, we've already seen this a little bit. Fortunately, the United Kingdom variant, which is the prevalent variant here in Houston, and I suspect the rest of America, is very well covered by the Pfizer vaccine, the Moderna vaccine, the J&J vaccine, and the AstraZeneca vaccine, which of course is not approved in America. The South African variant seems to be less tractable. Look at the difference between the AstraZeneca vaccine and the UK and the South African variant, 76% versus 10% efficacy. The good news is that the J&J vaccine in South Africa is still pretty effective. It beats the 50% hurdle rate the FDA set for vaccine efficacy. And admittedly, in a relatively small group of about 1,000 patients, the Pfizer vaccine clinically 100% effective at preventing symptomatic disease. All the lab tests that have been done on the South African and New York variants indicate reduction in antibody effectiveness. It seems that particularly the mRNA vaccines give such abundant antibody levels that they're still clinically effective despite some reduction in antibody avidity for these particular variants. Now, at some point, the variants are going to overcome this, and we're going to need vaccines with tailoring to the new antibody profiles. So that's obviously a concern for the general population. What about transplant patients? Well, clearly, avoiding live viral vaccines is a consideration. This obviously does not apply to the mRNA vaccines because there's no virus involved. The adenoviral vector vaccines really should be safe. There's a remote theoretical risk of developing replication competence in these vaccines, which are engineered to be replication deficient. I very much doubt this is a real life risk, but it's certainly something to keep in the back of your mind. As with any other vaccine, vaccines that contain adjuvants could potentially be a concern by the development of systemic inflammation that could promote vaccine-associated rejection. The J&J, Pfizer, and Moderna vaccines do not contain adjuvants. The Novavax vaccine, which is probably going to be the next one that will be submitted for FDA approval, does contain an adjuvant. And there's some thought that the lipid nanoparticles in the messenger RNA vaccines could have some adjuvant activity. At this point, this is really, again, a theoretical concern, nothing in the clinical data to suggest that these are actual real-life problems. Likewise, the theoretical concern of cross-reaction between the vaccine and epitopes in the kidney hasn't been seen in COVID-19 infection in the kidney, and really should not occur with the vaccines. So the safety part of vaccination of transplant patients it really is pretty benign. The efficacy part is the concern. Here's data that was published in JAMA a couple months ago, looking at a group of patients stratified by the age of the transplant, the immunosuppressive regimen, and the vaccine that was used. And you can see if antibodies are the measure of protection, which we think they are going to turn out to be, there's cause for concern here. Antibodies developing in less than a quarter of patients overall, particularly in regimens that include antimetabolites. It looks like the Moderna vaccine is a bit more successful here, so that may be a practical takeaway, is to try the Moderna vaccine on post-transplant patients. If at all possible, vaccinate them before the transplant. Things to beware of in terms of adverse predictors: older age, the more recent the transplantation, the use of mycophenolate or mTOR inhibitors, and those with poor baseline graft functions. There's some evidence to suggest delaying vaccination until a few months post-transplantation. And there are a variety of strategies that are used in other vaccines that could be considered. So a higher dose, additional doses. The EUA for the vaccines does not in any way, shape, or form sanction booster doses. On the other hand, your patients can go to Walgreens or CVS and get a booster dose simply by saying that they haven't been vaccinated before. It's Not something that I can officially recommend, but it's something that I have heard people doing. Intradermal injection of the vaccine is again a possibility, although again it's not on the label. And in the future, the use of adjuvants. What we have now for patients with transplantation who do not develop antibodies and who test positive for COVID is monoclonal antibodies. They are incredibly effective. They are also very effective, it seems, for prevention of COVID. Data in nursing home residents, data in household contacts, and the dual antibody cocktails are active against all of the major known variants that they've been tested for. And recent data show that you don't have to do an infusion. Subcutaneous injection is quite good for prophylaxis. So this is prophylaxis for the immune compromised is a really realistic idea, but not yet part of the EUA. Certainly, if your patients test positive, they absolutely qualify as high risk. And they should certainly be given monoclonals. And if I were you, I would have my my national societies really lobbying the FDA to make these available prophylactically to immunosuppressed patients who do not mount an antibody response to vaccination. So in terms of the future, hopefully new vaccine technologies like intranasal and intradermal will help to generate an antibody response in transplant patients. Certainly the monoclonal antibody cocktails are right here right now for early treatment and hopefully in the future for prophylaxis. I think it's pretty clear that over the course of time, S protein mutations will ultimately escape from the current vaccines. There's theoretical reasons to suggest that maybe the repertoire of mutations for this virus is limited, and actually it is close to its limit, and we may not require updated vaccines, but I don't think that's the way to bet. Fortunately, the mRNA technology can be ready to respond to variants within the course of a few months, including the regulatory process. But I suspect we're all going to need boosters for the next few years. Longer term, the outlook is probably of COVID becoming a mild endemic seasonal illness. And probably following in the footsteps of HCoV OC43, which is one of the causes of the common cold, but probably killed 1 million people more than 100 years ago. So that's a brief tour through where we are now, the efficacy data, which looks great, the safety data, which looks equally great, and some of the weak points that we need to keep working on. Thank you for your attention, and look forward to the discussion in the panel.
Thank you very much, Dr. Sussman. That was an excellent overview of vaccines in the COVID-19 era. So we now have all our panelists back on screen, and we encourage people to submit questions through polls everywhere, either by text or by the web. And there are a couple of questions that have come through. I'll start off by asking Dr. Solkowski that with the emergence of the UK strain, how do you think would be the optimum management of COVID-19 patients in future, given that that's getting hold and getting fit in the COVID patients?
Great, thank you for the question, and thank you for the opportunity to join you this morning. So what we've certainly seen over the course of the pandemic is several strains emerge that have essentially increased fitness, the ability to spread more readily. And the current dominant strain is the so-called UK strain, which carries with it not only a greater likelihood of transmission between individuals, but also a greater likelihood of severe disease. So as we see that play out, we are seeing, I think, younger people who are getting hospitalized because of this. I think the biggest issue, and this was covered very nicely in the discussion of vaccines, is if we can deliver a vaccine, we should lower the dominance of this particular strain since it is protected. Now, the concern, of course, is that another variant could emerge that is no longer easily blocked by current immunization. So I think we are going to be working to stay ahead of variants for some time, and that's our real challenge.
Thank you. Dr. Wong?
I have a question for Dr. Olson. So how do you think, that now we're on the topic of variants, with the accumulation of these new mutations in these variants, how is that going to affect PCR testing going forward?
Oh, that's actually a great question. So the FDA actually requires all the test manufacturers to continuously evaluate whether any of the reported variants affect their assays. And to date, so far, none of the assays, at least for the ones we're using, are affected by the mutations. There are some assays that do have mutations in the primer and probe binding sites that might lead to some false negatives, but they, again, are ones that are not in use in our laboratory.
I actually have a question for Dr. Grimes. Great talk, by the way. With all the new drugs that have emerged in the last year and new drugs being studied, and about all the variants that we are hearing about now, we're hearing about the crisis in India. Where do you see ourselves in a year from now as far as the utility of all these new medications are concerned? And do you anticipate multiple different kinds of vaccines that will target all these variants throughout the globe?
Thank you very much. Yes, where I really see us a year from now is hopefully having more oral antiviral agents. And I think this is something that could be very beneficial in a large outbreak situation like India. There has certainly been some promising data that are coming out, but I haven't seen the actual data on an oral Merck drug as well as other medications. So I think it'll be important to monitor with all these new therapies, what's going to be the antiviral resistance to these. I don't think we're going to have as much problem with dealing with the anti-inflammatory processes with the variants, but certainly viral mutations towards remdesivir and other antiviral agents that are being developed is going to be the big problem. But, as I had said in the talk, really moving forward, I'd like to see better antiviral agents. I'd like to see ones that will be addressing the variants and being tested against the variants to see if there's emerging viral resistance. But really, most importantly, more effective antiviral agents and hopefully oral antiviral agents that can really be shipped to large outbreak centers, because it'd be very hard with intravenous therapies trying to get into more resource lacking areas.
Hey, Kevin, I've got a question for you. Do you foresee combination therapies? So, for example, the Merck drug is a polymerase inhibitor, the Pfizer drug is a protease inhibitor. Do you see this evolving kind of like HIV?
I actually do, and I think that's what we're going to see. And what I'd like to see is developing combination antiviral therapy at the same time, and that we're not where we were in the 80s with HIV is let's add one drug, it gets resistance, add another drug, gets resistant. And then I think combination therapy may really be a way to try to prevent viral resistance rather than just going from one drug to another.
I have another question. So, with the controversial and contradictory results regarding mortality risk in solid organ recipients, and also a variable response to these vaccinations in transplant patients, especially patients showing low response titers, what do you think is a role maybe for a booster shot or another dose in 6 months or 12 months? Where do you think we are in that regard?
I'll start off on that. The data from the Hopkins group, I showed their data in March, which was after a single dose of the vaccines. They just a couple days ago published a follow-up to that, showing the results of a second dose, and it did improve the overall response of patients who generated antibodies. Did improve the titers. Still, in general, less than non-immunocompromised patients. And again, very much the mycophenolate azathioprine group did worse than the others. The Moderna vaccine was maybe a little better than the Pfizer vaccine. This is not foreseen in the EUA. We've had a couple of circumstances where we've gone to the FDA and the CDC and asked them if we could give third doses to people, and they have really consistently said no. But as I said, so we can't get on the air and say you should do this. Personally, if it were me and I were a transplant patient, I would absolutely try getting a booster. And it's nobody's keeping track of it. You can get vaccinated in one place and go to a different pharmacy and tell them you haven't been vaccinated yet and get another dose. Want to be very clear that I'm not recommending this. I'm just saying it's something that a crafty individual could do. Longer term, as Mark and others said, I think we're likely going to need boosters. Also, I recorded my talk on Wednesday, and Thursday and Friday and Wednesday night, all kinds of new information came out. Moderna, for example, issued a press release on their B1351 variant tailored vaccine, which indeed does seem to generate higher titers than the baseline vaccine to the South African variant, but maybe not quite so good to the D614G variant. So we're as Mark said, we're going to be chasing our tails for a while now, but there's I think a lot of good developments in the offing.
On that, maybe jump in and just add one thought. There's been some discussion among our group about the role of prophylaxis with the monoclonal. So take a patient with a solid organ transplant who may not have a adequate immunologic response, and perhaps that person gets the subcutaneous monoclonal injections. Obviously, I'm talking completely off, not even EUA yet, but that's something that we're beginning to at least contemplate as we think about how to protect these individuals from getting COVID-19.
Thank you. On that note, given the time constraints, I want to first thank all the speakers for an outstanding session. It's very informative, very challenging questions were answered. And would also want to thank my co-moderators who helped moderate this session. We will now take a short 5-minute break and resume at 10:30 for the next session, plenary session number 2. Thank you again, speakers. Outstanding work.
All right, welcome to the second plenary session where we'll be talking about the care of the COVID-19 transplant patient. I am one of the co-moderators. I'm Dr. Chukwuma Egwem, and I'm a transplant hepatologist with the Houston Methodist Transplant Program.
Good morning, I'm Dr. Barry Trachtenberg. I'm one of the transplant cardiologists and heart failure cardiologists. Welcome.
I'm Dr. Adrogué. I am one of the transplant nephrologists at Houston Methodist and am the fellowship program director for the nephrology fellowship at Houston Methodist. I want to welcome you guys and have you join by web. Go to pollev.com, please. Enter DeBakey, D-E-B-A-K-E-Y, respond to activity, or join by text. Text DeBakey, D-E-B-A-K-E-Y, to 37607. You can text in your message or your questions. It is my great pleasure to introduce our first speaker, Dr. Eric Salazar, who received his combined MD-PhD program in 2012 from the Tri-Institutional MD-PhD program in New York City. Subsequently, he joined the Houston Methodist Department of Pathology and Genomic Medicine as a resident in clinical pathology and as a fellow in transfusion medicine. He was elected to chief resident and subsequently chief fellow. Dr. Salazar is currently the medical director of coagulation laboratories and co-medical director of transfusion medicine at Houston Methodist. He has an academic appointment as an assistant professor with the Houston Methodist Hospital Institute for Academic Medicine and Weill Cornell Medical College, and is an adjunct assistant professor with Texas A&M College of Medicine. He is board certified in clinical pathology, transfusion medicine, and clinical informatics. Dr. Salazar's research interests range from improving outcomes in therapeutic apheresis patients to optimized testing of the coagulation system. He is deeply committed to helping stem the negative outcomes associated with the ongoing COVID-19 pandemic, and I consider him a colleague. It's my great pleasure to introduce his talk today. Thank you.
Good afternoon, everyone. I wanted to thank the organizers for the chance to discuss outpatient care and the role of passive antibody therapy in the management of COVID-19 positive patients, and in particular, our experience with passive antibody therapy in the management of COVID-19 patients here at Houston Methodist. So as many of you know, many outpatient therapies have been proposed, especially given the pressures of the pandemic, but very few have been proven. Vitamin C, zinc, hydroxychloroquine, many other agents have been proposed to be efficacious, but one of the approaches that has been proven to be efficacious is passive immune therapy. And this has particular relevance to this symposium because transplant patients often are immunosuppressed and cannot mount a robust immune response. So what is passive immune therapy? Well, passive immunity is immunity from an external source. Active immunity requires a robust host immune system and can occur in response to natural sources like an infection or artificial sources like vaccination. And thankfully, efficacious vaccines that take advantage of robust host immunity have been identified and are available. Passive immunity, in contrast, is just infusion of antibodies trying to impart immediate immunity passively. Then there are natural and artificial sources also. An example of a natural passive immunity is the passive transfer of maternal antibodies through breast milk. And an artificial source or sources is transfusion or infusion of antibodies. And I'll spend a lot of time discussing the artificial passive immunity in this talk. Passive immune therapy has a long history. In fact, the first Nobel Prize in Physiology or Medicine was awarded for passive immune therapy to Emil von Behring, who took the serum from immune horses and used it as a method to cure and prevent diphtheria. And depicted here is a painting of the horses being bled from which the serum was harvested to treat patients. And passive immune therapy has a strong rationale. As I mentioned before, it's administration of antibodies against an infectious agent to impart immediate immunity or try to impart immediate immunity. And there are several potential sources. Convalescent plasma is one source, and this is plasma harvested from individuals that have recovered from COVID-19. Polyclonal hyperimmune globulin preparations, which are essentially concentrated versions of convalescent plasma. Preparations generated in animal hosts that can provide a much larger volume, like for example, cows or camels. And then there are monoclonal antibodies, which are targeted antibodies that can be synthesized in the lab. And in particular in this talk, I'll focus on convalescent plasma and monoclonal antibodies, because these are the two approaches that have really become available for COVID-19. So SARS-CoV-2, the agent that causes COVID-19, appears particularly amenable to this type of approach of passive immune therapy, because as many of you know, and depicted here on the left, the SARS-CoV-2 virus is studded by the spike protein shown here in blue. And to invade a human cell, the spike protein binds to and interacts with the ACE2 receptor on the human cell, especially through the receptor binding domain of the spike protein. And therefore, disruption of this receptor binding domain ACE2 receptor interaction can neutralize the virus. And this interaction has been the tremendous focus of many drug companies, academic institutions, attempting to develop vaccines and vaccine candidates that target that interaction, as well as passive immune therapies like antibodies that can target that interaction, bind to the spike protein, and then disrupt that interaction and neutralize the virus. We were fortunate here at Houston Methodist to have the vision of our leaders like Dr. Boom, Dr. Musser, and many others that recognized that passive immune therapy could have efficacy in the context of COVID-19. And the only source of passive immune therapy early on in the pandemic was convalescent plasma. And one of the reasons for that is that convalescent plasma can be deployed rapidly because it's relatively low tech. You need donors that have recovered from COVID-19. You need a donor center to harvest the plasma, do antibody testing to test those units for antibodies, a blood bank to distribute on recipients to receive the plasma, and importantly, those recipients can then go on to become convalescent plasma donors themselves. We were fortunate to be able to put in place and to have the research infrastructure to be able to put in place a donor study and a recipient study to study both the donors that were coming to donate convalescent plasma and those recipients that were receiving convalescent plasma. And what have we learned from these studies? Just a few key findings I'd like to share. We found that early on, only a subset of donors had adequate antibody levels for using convalescent plasma. And you can see here that when we looked at all of the donors that had presented at the time, there was a large range of antibody levels in those donors. Some donors had no antibody, zero antibody when they presented. About a third of donors did not have levels that were adequate for the initial FDA recommended cutoff for virus neutralization antibody titer. We were fortunate to have antibody testing early on, and we used that data, and in particular data from an ELISA assay, to select the highest antibody titer units available for transfusion. And what we would do is we would take all the units that we had in the inventory, sort their antibody levels by which had the highest, and then we would select those units that had the highest antibody level when a request was made. Essentially, the unit that had the highest antibody level available is what gets transfused, and we continue to do this to this day when a request is made to give a convalescent plasma unit. And I'm not aware of another center that took this approach. Importantly, high titer plasma continues to show a signal of efficacy in our inpatient population. When we looked at our propensity score match data through February of 2021, we continue to see a statistically significant reduction in mortality on Kaplan-Meier curves and using the log rank test relative to matched controls that did not receive convalescent plasma transfusion. But very important to note, in our inpatient population is that efficacy really is limited to only certain circumstances. When our analysis was restricted to those patients that were already intubated, to those patients that received a transfusion after 72 hours after admission, or to those patients that received low titer plasma we see no signal of efficacy at all. And it really appears that early treatment with high antibody titer appears key with respect to efficacy of convalescent plasma. And overall, what we found is that some COVID-19 convalescent plasma donors, when we do efficient antibody testing with the Elisa, we find some convalescent plasma units with high antibody titer. And when we give those units to those patients that have early disease, the outcome is significantly decreased mortality. And these findings have been supported by other studies. For example, here is a randomized controlled trial conducted in Argentina, a very well-run study by Libster et al., where they looked at early high titer convalescent plasma therapy to prevent severe COVID-19 in older adults. So they looked at older adults within 72 hours of symptom onset, and they randomized them to receive placebo or convalescent plasma. And they saw a significant reduction in the progression to severe disease in those patients that received convalescent plasma versus those that received placebo. They were able to measure antibody levels in those patients that received plasma versus placebo. And you can see here on the right that those patients that received plasma had a significantly higher level of antibody than those that received placebo. This is an outpatient study. Another study which was done in inpatients by Columbia University and in collaboration with a group in Brazil, a randomized control study, also a very well-run study, showed a reduction in mortality even in inpatients that received convalescent plasma relative to randomized controls that received FFP as a control. I think it's important to use FFP as a control in these studies because plasma alone may have some effect on the progression of disease in COVID-19 patients. And so it's important to use the right control. The largest randomized controlled trial to date is the UK recovery trial, which unfortunately found no benefit at all for convalescent plasma in their inpatient population. But when they did a subgroup analysis, looking at those patients that were specifically seronegative inpatients, they found a potential modest benefit only in that subgroup. And so you can see here a statistically significant reduction in the progression to invasive ventilation or death, specifically in those patients that were seronegative at the time of transfusion of convalescent plasma. They used plasma units with a neutralizing antibody titer of greater than or equal to 1 to 100, which is likely a bit lower than what we're using here at Houston Methodist. So overall, the convalescent plasma data support a passive immune therapy early treatment hypothesis. We're just looking at this curve. Efficacy of passive immune therapy is highest early in disease and appears to drop off as disease progresses, potentially related to the mechanisms by which the disease manifests. Potentially later on, it's more of an immune response, an overactive immune response, as opposed to an inflammatory response, as opposed to a viral replication per se. But there are some key questions that remain unanswered. And one of the key questions is, when does that drop off in efficacy really occur? It's likely individualized and likely is related to viral load, serostatus of the patient, which variant the patient is infected with, and does the antibody have efficacy against that variant? And what is the antibody titer that's able to be achieved in that particular patient? One other key question that I think is very important and very relevant to this symposium is, do immunosuppressed individuals like transplant patients have a longer efficacy window than the typical patient that can mount their own immune response? And there are some data to support this notion that the efficacy window is longer. For example, here is a study of convalescent plasma recipients that had hematologic malignancies and were immunosuppressed. And in this particular population, this group saw improved survival in this patient population, even later in disease, and they received convalescent plasma relative, and this is data matched to relative control, matched to propensity score matched controls. So it's important to note that convalescent plasma has several limitations. A large donor pool is required, Antibody testing infrastructure needs to be in place. There's obviously large variability in donor antibody titer. There's a limited donation window within which you can actually collect the convalescent plasma. And for outpatients, convalescent plasma is not currently FDA authorized. And there are many other limitations. And it's clear that for inpatients, the benefit is modest. There are still some patients that receive convalescent plasma that continue to progress. So what can be done to address these limitations? Well, thankfully, neutralizing monoclonal antibodies have become available. These are quote unquote high tech and can address some of the limitations of convalescent plasma. It's a little bit more complex to identify and make monoclonal antibodies. For those that are available now, those were either derived from convalescent individuals or from humanized mice that received a target antigen. From those sources, B cells are screened using different assays, multiplex B-based assays or others, to screen for receptor binding domain specific single B cells. Then those B cells can be sequenced and the antibody generating regions sequenced and cloned and then analyzed. And these particular antibodies that can be produced by those clones can be assessed with respect to their affinity, their stability. They need to be validated with respect to neutralizing capacity, and then finally selected. And then the clinical trials can start. And as of the end of December, there were about 20 companies with neutralizing monoclonals in the development pipeline. It's likely to be more at this point. The clinical trials can be complex and obviously difficult to run, but we're fortunate here at Houston Methodist to have the clinical trial infrastructure and the support of the Academic Office of Clinical Trials and many others. And Dr. Wong was here at Houston Methodist, PI of some of the studies of monoclonals in outpatients here. And what did these studies show? Well, bamlanivimab, the Eli Lilly monoclonal, showed reduced hospitalization, viral load, and symptoms in outpatients. So if you look at the symptom score in those patients that received placebo relative to those that received the Eli Lilly monoclonal, those patients that received the monoclonal had lower symptoms. The Regeneron cocktail, the casirivimab indevimab cocktail, reduced hospitalization and death in outpatients. You can see a 70% risk reduction in those patients that received the cocktail infusion versus those that received placebo, and a 4-day median reduction in symptom duration. And because of this, these monoclonals, the Eli Lilly bamlanivimab and the Regeneron cocktail, received emergency use authorization. And again, Houston Methodist went to work to rapidly make these available to outpatients throughout the system. Many thanks to the pharmacy team, Mike Leibel, Jennifer Berry, Dr. Wong, many others for leading this tremendously successful effort. And you can see the curve of use essentially mirrors the pandemic curve in the Houston area. So Houston Methodist has been a national leader in the infusion of monoclonal antibodies in outpatients. There are some limitations to monoclonal antibody treatments. They require an intravenous infusion. There can be logistical hurdles related to that. And of course, variants of concern can be a limitation to the use of monoclonals. For example, bamlanivimab, that initial monoclonal that received FDA authorization, had the FDA authorization revoked, likely due to resistant circulating mutants. So reduced neutralization has been observed in laboratory studies for some mutations, in particular the L452R and the E484K substitution, the spike protein that's found in some variants of concern, have been shown to lead to markedly reduced neutralizing capacity for bamlanivimab, may have lower sensitivity for etesivimab and for casirivimab. Etesivimab is another Eli Lilly monoclonal, and casirivimab is one of the Regeneron monoclonals. Thankfully, currently the UK variant, or the B117 variant, is the current dominant circulating strain in the United States, but I know that our sequencing team here at Houston Methodist, Dr. Long, Dr. Olson, Dr. Musser, and many others are on the lookout for these variants of concern. So what can be done to address this issue? Well, the cocktail approach, as opposed to the single monoclonal antibody approach, could potentially address these variants of concern. For example, in the phase 3 cohort of the BLAZE-1 study, 769 patients that received a cocktail as opposed to the single bamlanivimab infusion had reduced risk of hospitalization and death by 87%. There were 0 deaths in the treated cohort, 14 deaths in the placebo cohort. And this cocktail of bamlanivimab, etesevimab monoclonals was given emergency use authorization to take the place of the bamlanivimab single monoclonal infusion. To address the other limitations, the logistical limitations of monoclonal antibodies, a different infusion approach could be taken. And here's an example of some potentially encouraging data. Subcutaneous administration may be efficacious. And in this phase 3 trial, recently infected asymptomatic COVID-19 outpatients were given 1,200 milligram Regeneron cocktail infusion subcutaneously, and then of course randomized to placebo. And the overall risk of progression to symptomatic COVID-19 was reduced by 31%. This was the primary endpoint, and by 76% after day 3, suggesting that subcutaneous administration of a cocktail of monoclonal antibodies may be efficacious. And these patients had shortened symptom duration and markedly reduced viral levels. Again, these data support the passive immune therapy early treatment hypothesis, where the efficacy of passive immune therapy appears highest early in disease and appears to decrease as the disease progresses. So what's the future of outpatient therapy? Well, the United States outpatient convalescent plasma trial should be reporting soon, and we'll be on the lookout for those data. It'll be interesting to see whether the subcutaneous data will lead to emergency use authorization of that approach for the monoclonal cocktails. Hopefully there will be monoclonal antibodies that will be less susceptible to escape variants. Other passive immune agents like nanobodies or aptamers may become available as more research is done. Essentially, any type of immune agent that can disrupt the spike protein ACE2 receptor interaction may have efficacy. And it'll be very interesting to see whether passive immune therapy for prevention, in particular in immunosuppressed patients not responsive to vaccine, will become available. Of course, we're going to continue to have patients that do not respond to vaccination, and it'll be important to have an option for them. And it'll be also very important to see whether oral antivirals will become available. I know Pfizer has started testing an oral antiviral in clinical studies. There are many people to thank for the work that was been presented here. Many of them are listed here, and very likely many folks that contributed to the work presented here are not listed, and my apologies for their omission, but many, many thanks to all of the wonderful teams that are listed here. We're so fortunate to work at a place with such great leadership and such tremendous support. I'm very happy to take any questions during the question and answer session. Thank you so much.
Thank you so much, Dr. Salazar, for that great talk on outpatient management of COVID-19. For our next speaker, it's my great pleasure to introduce Dr. Cedric Spock, who is an infectious disease doctor, and he's works at the Texas Center for Infectious Disease Associates in Dallas and Fort Worth. Dr. Spock is a nationally recognized specialist in transplant infectious disease, in addition to having extensive experience in clinical infectious diseases, bone and joint infections, and HIV. Dr. Spock earned his BA here at Rice University, so it's great to virtually welcome him back to Houston. After that, he graduated from Southwestern University for medical school and completed his residency at UT Southwestern as well. He went on to attend University of Washington for his fellowship in infectious diseases, where he also received a prestigious K-30 NIH grant to pursue an additional year of training in transplant ID and virology. Finally, he obtained a master's in public health and epidemiology from the University of Washington, with which he helped establish an AIDS clinic in South Africa. Dr. Spock will be speaking to us about the inpatient management of COVID-19 in transplant patients, and it's a great pleasure to introduce Dr. Spock. Thank you.
Thank you so much for allowing me to present at this conference. I actually had a little computer issue and there was a firewall upgrade, so they are going to be presenting my PowerPoint slides. So I just want to make sure y'all can see my slides. Okay, great. My objective is to go over a patient case and talk about inpatient management and transplantation. Unfortunately, this is something we've all worried about, and so we'll go ahead and jump right in to try and add to the conversation that we've been having today. This is a patient that we had inpatient over here at Baylor in Dallas. It's a 55-year-old female who had end-stage liver disease due to hepatitis C. She had been treated appropriately and had evidence of SVR. She was worked up and approved to obtain a living donor liver transplant from her cousin. Operative complications did occur, and she required biliary reconstruction and also portal vein thrombectomy. The donor fortunately did quite well, had an uneventful convalescent period. And while the patient was herself recovering from the surgery, multiple family members were visiting. And I think as clinicians in the hospitals during COVID, that is a very important sentence, because that is something that we've all been struggling with, because we have been very aware that COVID is in a way everywhere. And hospitals have been struggling with what to do with visitation and on different floors. And so as the patient was being visited by her family members, and this is now approximately 10 days after the transplant, she developed sudden increased work of breathing, and a chest x-ray, as shown here, demonstrated new infiltrates. Next slide. Laboratory studies were done, and this is just a screenshot from Epic showing it, and I can't tell how well it's coming through, but basically with the point being that right around the time of her illness, she did have laboratory studies that could be consistent with acute coronavirus infection, where she started having a drop in her albumin. Next slide. And then also, really one of the most useful markers in the hospital when you're still waiting for all the tests is when you see the lymphocyte count drop. Now, of course, this is a patient who'd received induction therapies for her living donor liver transplant, and they can have lymphopenia for a lot of other reasons. But as the conversation is happening real time in the hallways, it's useful to have data immediately so you can then discuss with your surgeons and other colleagues and say, all right, I think this is or is not the case. And so the lymphopenia was obviously concerning. Next slide. Patient then proceeded to a CT scan, and the CT scan showed evidence of significant opacities within the lungs. The transplant team had actually asked for the CT scan because they'd seen the liver function tests were slightly elevated, and they wanted to evaluate further what had happened after the biliary reconstruction, as well as the portal vein thrombectomy. And the CT showed multiple findings. Most importantly, unfortunately, were the worsened opacities in the visualized lung bases, which were concerning for multifocal pneumonia, which is obviously a very non-specific radiographic description, but useful nonetheless as we're moving forward. Next slide. So the SARS coronavirus testing then came back positive, and different hospitals have been then looking at how to actually make this test available to clinicians. And so within the Baylor Scott and White system, we have the not detected usual language, and then bam, there's the detected. And so that leads to all sorts of phone calls, because now we have a patient on the transplant floor who got a elective living donor liver transplant, and now unfortunately has SARS coronavirus 2 in the hospital. Next slide. Patient rapidly deteriorated, and so moved to the intensive care unit. The surgical ICU team was consulted, infectious disease was consulted. Patient developed worsening increase in breathing. And this is unfortunately a familiar story to, I'm sure, everyone in the audience. It's remarkable how sometimes this disease hits and it can be so rapid. The immunosuppression was maintained with Prograf. Decadron was selected, and remdesivir was also initiated. Labs at baseline were sent, CRP was elevated, LDH was elevated, ferritin was elevated, and then we sent an IL-6 just for ongoing conversation about further therapies. But that's another challenge also within the clinical settings, is that different hospitals have different lead times for IL-6 for reasons that are sort of part of that, because that's a test that we usually not really order. Patient had worsening clinical status, and 3 days after diagnosis was intubated. Ongoing discussion with the team, recent intubation. Transplant agreed that, okay, we can go ahead and try and give some convalescent plasma in this setting. Next slide. And this is just a screenshot of the IL-6 levels, which came back very, very high. Now, clinically, this is where it gets so challenging, because as we're getting all these data and as we're trying to describe how sick the patient is, risk stratification is something well validated in many kinds of illnesses, we still don't know really how to interpret these data. So, okay, we can say IL-6 is supposed to be a normal number. Most clinicians are not going to be familiar with this, and now we have these results. Okay, it's really high. What do we do now? Next slide. So the remdesivir was continued. The patient was maintained on the ventilator. Decadron was also continued. There's discussion amongst many people in the hospital system. All right, let's go ahead. And this was right around October, November, where there was a discussion of like, is remdesivir better if it's longer, and don't really know. And so the idea was, let's give the patient additional 5 days of remdesivir. Additional laboratory studies were sent. IgG was significantly depressed. IVIG was given. IL-6, as noted, was high. Cytokine storm was clearly what was going on with this patient. Should the patient get tocilizumab? So that's another conversation that's interesting, because I'm an infectious disease doctor. I'm not accustomed to immunosuppressing patients. And now the transplant team is asking the transplant infectious disease doctor, should we give an IL-6 receptor blocker? And there was lots of discussions. We talked to different transplanters who actually do use tocilizumab in a variety of situations, as members of the audience will be familiar. And it was decided, well, let's hold off and let's see how she does. Next slide. So this is a screenshot of the liver function tests, and there was a big discussion of the LFTs. They're going up slightly. Is this rejection? Is this a consequence of portal vein thrombosis? The patient is on anticoagulation for the portal vein thrombosis. Wait a minute, is the portal vein thrombosis a technical complication, or is this a manifestation of the hypercoagulable state that we see in SARS coronavirus 2? And so as we were kind of discussing this, we're looking at the LFTs. The thought was maybe this was coronavirus. There was no real change in immunosuppression at the time. Next slide. Fortunately, she had a liver biopsy. The liver biopsy was not really conclusive for rejection, and then she continued to improve. To put yourself back in reference, she developed acute illness on the 4th of October. So now it's the 19th of October. So 15 days later, she has persistent pulmonary infiltrates. She is delirious. She has challenges with maintaining her secretions. Her liver function has been stable. She was able to be transferred out of the intensive care unit. Next slide. She's now on the transplant floor, and we're still trying to figure out isolation protocols. And that's another sort of moving target. So now you have trying to figure out the isolation. She's staying in isolation. How long do we keep her in isolation? And she's been immunosuppressed, additionally immunosuppressed, and now she survived COVID. Family members are all upset. By the way, they're actually posting everything on social media saying that the hospital gave her COVID, even though they were all visiting her. And we found out later on that one of the family members did have SARS coronavirus 2 infection, but never sought medical care because her symptoms were all in the outpatient setting. While the patient remained isolated, her mental status was poor, and she ended up being on high flow oxygen for over 2 weeks with associated delirium and confusion. Next slide. She had a follow-up CT scan to kind of determine how her clinical course was doing. And unfortunately, the CT scan didn't look very good. She had evidence of what we now know to be seeing in these patients who have sometimes severe disease, but sometimes not so severe disease, where they can have an organizing pneumonia with fibrotic changes. They can also have bronchiectasis. Our colleagues in radiology are now starting to use buzzwords to kind of lead us through. So this traction bronchiectasis without evidence of obvious parenchymal disease. So in other words, does this patient now have permanent lung disease from a SARS coronavirus 2 infection? Incidental effusion, and a few things about the liver transplant. Next slide. So now we get additional specialists to come see the patient. So this patient that had been electively admitted to the hospital for a living donor liver transplant now has been in the hospital for almost 2 months. The interstitial lung disease service is evaluating the patient, and after further discussion, immunosuppression was modified, and it was agreed upon to give a weight-based prednisone taper, looking at about a 2-month therapy and following exam and clinical response. Recognizing it was unclear how much lung function would recover. And in fact, 2 of our pulmonologists were concerned that the lung disease may progress, but did not want to actually evaluate the patient at the time for a lung transplant, and instead wanted to further follow the patient longitudinally with a follow-up CT chest and then proceed with acute inpatient rehabilitation. Next, this is perfect, this slide. So this is a pause because there's been a lot of great slides, a lot of great science, but when we take care of our patients, they're not looking at the science, they're looking at the internet, And I have 3 teenagers. And so they teach me a lot about how to use the internet because it seems how everybody's getting their information. And so there can be good things on the internet, bad things on the internet. And so these are just some humorful memes that my teenagers have shared to me while I've been working in the ICU, taking care of a lot of COVID patients. You know, we can do the Mandalorian, don't take off your mask, this is the way. We can remind people that if they didn't want to wear a mask, it's a lot more comfortable to wear a mask than it is to have a laryngoscopy with endotracheal intubation. And then my favorite is this one sounds like something out of Tolkien, where instead of saying, I can't go outside because of the virus, it's I've sworn an oath of solitude until the pestilence is purged from the lands. By the way, this last one was very popular across the hospital and got shared across multiple specialties. Next slide. This is not a opportunity for me to go over all the diagnostics of SARS coronavirus. I throw this slide up there for the audience just to remind you that there are tests available. And as in this case, the testing was done and we got the results relatively quickly. In fact, testing is now even more available. Antibody testing is frequently being done too. It's being done in the inpatient as well as in the outpatient setting. And sometimes we use it when we're trying to figure out what's going on with the patient, if in fact they have negative antigen testing or negative PCR. However, it is really important to remind many people in the treatment team that antibody testing is not useful as proof of protection. And I have these discussions on a frequent basis in the hospital when patients are admitted, oh, they have an antibody, therefore they're fine. Well, that's not necessarily true. We really don't have a good correlate of immunity for any of our patients, specifically our transplant patients, that is readily available at the clinical site. Next slide. Treatment options. Treatment options have already been discussed this morning because the treatment options, there's kind of like this gradient where if you have outpatient therapy, early disease, now you have inpatient disease, and then there are these medications that get brought up. I struggle with even what medications to put on a slide in this kind of a format. Hydroxychloroquine was so popular a year ago, and now nobody's using it. And then there's other things. Most recently, the ivermectin, which I put in the middle of the slide, I have had patients almost physically attack me because ivermectin was not offered to their loved one because of the challenges that we see on social media. And so it is important to remember that we have to be professional and we have to make appropriate clinical decisions. And we shouldn't necessarily cave and say, oh yeah, okay, you want ivermectin? Sure, here, have some ivermectin and shut up. Because the ivermectin isn't going to help. We know that. I didn't think it was relevant to go into all the details for the basic science. But I do think it is important to remember that although it is exciting to see press releases, preprints, things that haven't yet been peer reviewed, I think we're all doing it. Some of these have actually already been shown in some of these slides earlier today. Maybe that's where we're getting some of this from. I don't know. The other thing is that when treatment options are discussed, if I'm in a conversation with family members now, I remind them that if there's a sick family member, everybody else should go get vaccinated. I don't want to go over the vaccines because I know we have that to discuss with other talks, but that is a miracle of modern medicine, how fast we've come with vaccines. Next slide. So the treatment that we know for certain, breaking it down really simply to patients and their family members, the steroids save lives. This is a great example of how science teaches us that things are different. Years and years, doctors have been trained. Don't give steroids if somebody has an active infection. But wait a minute, not so fast. Actually, sometimes we can give steroids in active infection, and we needed randomized controlled trials to actually show that steroids do save lives, and this did make the press. Dosing isn't clear. There's still some argument going on. You'll talk it over with your different colleagues. I didn't think it was relevant to actually go into the weeds about the different kinds of steroids. I do think it's useful to have discussions with the other members of the treatment team and say, all right, what kind of Decadron dosing are we going to do? Are we going to do methylprednisolone? And are we going to do a taper, et cetera, et cetera? The other options definitely require a multidisciplinary approach. Already within the lecture, we've heard that, okay, transplant patients may do better or worse. That actually has been seen at all institutions, including ours. Holding the anti-metabolite, as is frequently done in other viral infections, is frequently done, and it does seem to confer some benefit. Reduction of immunosuppression further, not clear. IVIG, which was given liberally in some of the early experiences, less so later. And then actually in this case, it was given. Maybe it helped, maybe it didn't. The other things that might help, remdesivir, plasma, given to this patient, maybe it helped, maybe it didn't. Monoclonal antibodies were offered to this patient. There were some clinical trials going on at the time, but it was felt that this patient didn't qualify. And then other issues like baricitinib and tocilizumab or other IL-6 blockade mechanisms could also be considered. Next slide. cytokine storm. As an infectious disease doctor, it is great to be able to refer to different clinical syndromes and make a clinical diagnosis. So endocarditis, I have the modified Duke criteria. I can use that, major criteria, minor criteria. We don't have a defined cytokine storm. Instead, it's sort of operator dependent. Different specialists in the hospital taking care of the patient will agree this patient is having cytokine storm based on initial descriptions at the beginning of the epidemic, recognizing it was in the third phase of this triphasic illness of COVID-19. Unfortunately, it's not like we have lab tests that say when it's supposed to be. We also don't understand how it will be different in different hosts. So if somebody is already a solid organ transplant patient, what are their risks for cytokine storm? And when is the best time to act so that we can ideally prevent it? And if it is occurring, how do we mitigate it when it is actually occurring? Next slide. Remdesivir. Remdesivir came, was used a bunch, then got used a little bit less, and is still getting used. Part of the reason it's not being used as much as it was is because it's not as good as it really should be. It was originally discovered for the use for Ebola, and it did have some efficacy for that disease, and it does certainly reduce length of hospitalization. Mortality benefit has been very difficult to demonstrate. Fortunately, the drug is relatively well tolerated. It is probably better early, and all I did was I just took the summary slide from the New England Journal showing that if we looked at all comers, there does seem to be a change in the signal so that there is improved chances of recovery. It's intravenous only, 5 days therapy. Can you give it shorter? Can you give it outpatient? Can you give it longer? Can you give it nebulized? Are there other ways to give it? These are still things being looked at. If I'm talking to other clinicians who aren't familiar with remdesivir, I actually kind of tell them, it's kind of like Tamiflu, because Tamiflu does help some, but it doesn't fix the problem. Later disease doesn't seem to be helping. As has been mentioned earlier in these talks, what is later disease in a transplant patient? Can you still get a benefit giving it to later? I think a lot of us would still give remdesivir in patients like this. Next slide. Convalescent plasma. So very well described already in previous lectures. The main challenge is that the data show that if you have high titer in the plasma, that's what you should give. So therefore, we need to rely on our transfusion specialists and our blood banks to be able to provide that to us. And that is happening. When the randomized controlled data is being shown all comers, it doesn't seem to benefit from a mortality standpoint. However, a lot of us have used it in a lot of situations. And in fact, it doesn't seem to have a bad signal associated with it, so it shouldn't worsen clinical cases. Next slide. Other interventions. Bamlanivimab had the best name because when it was being used before patients got admitted, it was being used down in the ER and they would just write BAM on the screen. So we would get calls. Hey, there's a transplant patient. They're starting to get sick. We've already seen some of them done badly. So although the purpose of this sort of little segment of the talks is to talk only about inpatient, I was always getting called to try and get patients to avoid inpatient. So what do? And so I would then share, this is a letter to the editor, for example, from Westchester County, showing that they actually used it in 10 solid organ transplant patients, and none of them did badly. That's pretty good. And in fact, none of them got hospitalized. And this was a single agent study. Now we're learning that we need different agents. We might need different monoclonal antibodies to be infused at the same time. These are additional things that we will learn over time. Unfortunately, this drug, this approach does not seem to have much utility on the inpatient setting. There does seem to be that it can be worse for inpatients. Wrapping things up, this is the next slide, thank you. Other interventions, baricitinib. This was a recent publication in the New England Journal. And the idea is that, okay, we can use alternatives to steroids. When this trial was recruiting up here in Dallas, it was actually an interesting conversation because it was like, wait a minute, for about a year now, or half a year, sorry, we know that steroids are life-saving. We're going to use a clinical trial where we're not going to use steroids. That was actually a cumbersome conversation to have because most of the ICU docs observed pretty quickly that the steroids were definitely beneficial. And so it may have been harder to recruit some patients because of that. However, the clinical trial was published and did demonstrate, compared to placebo alone, baricitinib did provide additional benefit. So once again, the infectious disease doctor taking care of the infectious disease is now provided with additional molecules that have nothing to do with infectious disease. Now we're talking about using a molecule that our hematologists use. And so forcing the infectious disease specialist to be familiar with new pathways of disease, talking about JAK inhibition to try and help my patients. So there may be future directions as well as we continue to undercover disease. So finishing things up, thank you, tocilizumab, the immune modulation of the cytokine storm. Probably what's going on here is because of the complexity of the cytokine storm and because the cytokine storm itself hasn't been adequately defined on when's the best time to clinically act, salvage therapy for cytokine storm is probably not the way to go. And that was the original way based on CAR T therapy when our hematologists were saving patients' lives from untreatable cancers, and then they would get an IL-6 mediated cytokine storm, they'd use tocilizumab. Now, in that setting, there have been anecdotes, rare case reports of possibly infectious disease complications, aspergillus, CMV, HSV, but really there hasn't been much seen from a practical standpoint. And in fact, if you look on Sanford or Infectious Disease Society guidelines, they now recommend tocilizumab to be given early in patients hospitalized, ideally to prevent severe complications of COVID-19. Next slide. This is the summary slide from the New England Journal, looking at all patients, all comers, when they used IL-6 blockade, IL-6 receptor antagonists, whether it was sarilumab or tocilizumab, and they were able to demonstrate that there was a benefit. Confusingly, in the exact same issue, there was another article that showed there wasn't a benefit. This means that we have to keep talking to each other, and we have so much work to do. We haven't figured this out. And so tocilizumab is once again a promising issue. And so this slide also tries to grab at that. And I think this is the only published report of tocilizumab used in solid organ transplant patients. And this was from AJT at the end of last year. And they tried to show that the patients that were given non-intubated versus intubated, death versus hospital discharge. And what they basically showed that is it didn't seem to have much benefit. Flip side is it didn't seem to cause much harm. So wrapping things up, inpatient management of SOT and COVID, we do have treatment options, but it's not standardized. And so we do need to talk amongst ourselves as we're on the case. What are we going to use? What are we not going to use? Clearly steroids, most likely antivirals, adjustment of immunosuppression, immunomodulators may have a role. Early intervention is key. So we need to have a high index of suspicion, and we really need to make sure these patients get diagnosed early before they get hospitalized, because then that gives us the opportunity for monoclonal antibody therapy so that they don't have to be hospitalized. And of course, prevention, whether it's vaccines, masks, other interventions. And that's the talk. So I appreciate everyone's attention.
Thank you, Dr. Spock, for that very insightful talk. I'd like to remind the audience to text in your questions, and we'll be able to address those as time permits in the Q&A section. I have the pleasure to introduce our next speaker, Dr. Constance Mobley. She earned her MD and PhD in molecular physiology and biophysics from Vanderbilt University School of Medicine in 2003. She completed her general surgery residency as well as her fellowship in surgical critical care at University of Michigan. Subsequently, completed her fellowship in abdominal multi-organ transplant and hepatobiliary surgery at UCLA. She joined the Houston Methodist staff in 2014. She is board certified in general surgery, critical care, as well as transplant surgery. Currently, she's the medical director of the surgical and liver ICU, as well as the program director for the Surgical Critical Care Fellowship. She's had many accomplishments. Most recently, she's a 2020 recipient of the Health Disparities Research Education Program Scholar Award, sponsored by the ASTS and supported by the NIH. She will be talking about ICU care of the COVID-19 infected patient, giving us an update. Dr. Mobley.
Good afternoon. My name is Constance Mobley. I'm a transplant surgeon here at Houston Methodist Hospital and the medical director for our surgical liver ICU. Today I'm going to talk to you about the ICU care of the COVID-19 infected patient and focus in on some specific topics that are particular for COVID-19 infected patients and how that care impacts their stay in the ICU. So I want to talk about critical illness and COVID-19 and primarily focus on their extrapulmonary manifestations. That will include the impact of liver disease, cardiac involvement, renal dysfunction, as well as sepsis and superimposed infections, and how that impacts the care in their ICU stay. So a little bit of background about COVID-19. You've heard this all before. The patients with COVID-19 have acute respiratory distress syndrome from their infection with coronavirus 2 or SARS-CoV-2. The overall case fatality rate ranges between about 2 to 6%, and the fatality rates are much higher in elderly patients, as well as those with underlying comorbidities. Of course, the patients who are elderly tend to have more comorbidities, and so this is part of the reason why we see a higher fatality rate in this patient population. Approximately 2 to 11% of patients with COVID-19 have underlying chronic liver disease, and that is going to be shown in some of the data from the papers I will present later on in this talk. And this is impacted in our patient population in our surgical liver ICU because we manage these patients both pre and post transplant and have taken care of them after clearance of their COVID-19 virus, as well as while they have these infections ongoing. So the COVID-19 fatality rate shown here is distributed by age. And what this shows is, which is what I mentioned before, is that the impact of fatality is most prominent in those who are elderly. So those who are greater than 70 years old, and certainly beyond that, have the highest fatality rates, as we can see here. If you then look at their incidence of comorbidities and their fatality rate with COVID-19, we see that comorbidities in patients who die of coronavirus is much higher. So these patients have high incidence of cardiac disease, diabetes, chronic respiratory illnesses, hypertension, as well as chronic kidney disease. So in these patients with coronavirus, liver disease is also very, very prevalent. It's been reported that anywhere from 14 to 53% of patients with COVID-19 develop liver dysfunction. Hepatic involvement has also been associated with higher mortality rates. Shown here are some studies that were done looking at comorbidity of liver disease and dysfunction in patients with SARS-CoV-2 infection. One of the largest studies that was done, shown at the top, which included over 1,000 patients, showed that about 23 of those patients had pre-existing liver disease, but patients with abnormal liver function spanned greater than 20%. And nearly 600 or over 600 of those patients with non-severe disease, and 56% of those patients with severe disease developed liver dysfunction. So the predominance of liver disease and severity in these patients is shown here. We see that elevated liver enzymes are observed predominantly in severe cases of COVID-19. In addition to that, we see that there's an elevation of AST in about 62% of patients in the ICU, compared to only 25% of those patients who are not in the ICU setting. Again, this shows that those patients who are more likely to get sick and critically ill from COVID-19 will have liver dysfunction. And this will also impact their ICU stay and their management in the ICU. The peak of their ALT and AST levels were also very high, almost 8,000 and 2,000 respectively in those patients with COVID-19. And so this is a very significant increase in liver function consistent with shock liver, which would typically be managed in an ICU setting anyway. This in addition to their underlying in addition to their primary diagnosis with COVID-19, again, severely impacts their management in the ICU. So COVID-19 and cardiovascular disease is also a known phenomenon. And we know that there are risk factors associated with cardiovascular disease and COVID-19, as well as their underlying complications. So, of course, we know that coronary artery disease is most prevalent as you age. And so, of course, risk factors include older age, as well as those comorbidities associated with older age, diabetes, lung disease, renal disease. Also, systemic inflammation, coagulation abnormalities, um, all of these, including immobility, are risk factors. The complications that arise from this are myocardial injury and myocarditis has been seen, acute myocardial infarctions, heart failure and cardiomyopathy, arrhythmias, shock, and even cardiac arrest, as well as a known increase in venous thromboembolic events in these patients. So when we looked at when cardiovascular disease and COVID-19 were looked at in one meta-analysis of 6 published studies from out of China, this included greater than 1,500 patients with COVID-19. It was reported that nearly 10% of the patients had diabetes, 16.4% with cardiovascular disease, and 17.1% with hypertension. The overall case fatality rate was 2.3% in the entire cohort. However, what was significant is it was a much higher case fatality rate in those patients with these underlying cardiac conditions, including an increase to 6% in patients with hypertension, 7.3% in patients with diabetes, and greater than 10% of those patients with underlying coronary artery disease. So the systemic inflammatory response in COVID-19 is thought to be one of the primary factors that cause some of these manifestations. And so the mechanism of injury in cardiovascular disease is also thought to go through this systemic inflammatory response. And so when we see this high level of cytokine surge, we believe that this can result in injury to the cardiac myocytes. Indeed, studies have shown that elevated levels of pro-inflammatory cytokines in patients with COVID-19 are present. Acute plaque rupture is also one of the leading causes to acute coronary syndrome. Again, both of these likely linked to this systemic inflammatory response. The second mechanism of injury is direct myocardial cell injury. And what the thought is that this is mediated through the ACE2 receptors. And this is an entry point for the Sars virus to get into the cell. Once the virus is in the cell, with the ACE2 receptor, this can result in changes of the pathway for angiotensin actions. And this pathway leads to acute injury in both the lung, heart, and the endothelial cells. So this is believed to be another mechanism for the cardiovascular events that are seen in patients who are infected with COVID-19. In addition, there is a mechanism with myocardial oxygen supply demand mismatch. The idea is that there's an increased cardiometabolic demand associated with systemic infection and ongoing hypoxemia caused by severe pneumonia and acute respiratory distress syndrome. This can lead to increased demand in the face of inadequate oxygen supply, and this ultimately leads to myocardial damage. So these are the 3 mechanisms that are believed to cause the cardiovascular impact in COVID-19. So the third manifestation of COVID-19 in critically ill patients is with the impact on renal function. And so we know that patients who have COVID-19 often have concomitant acute kidney injury. And acute kidney injury has been reported in nearly 25% of those patients who are critically ill with COVID-19 infection, especially those with underlying comorbidities. Acute kidney injury is associated with higher mortality rates in the setting, especially those who ultimately go on to require dialysis and continuous renal replacement therapy. Several studies have highlighted the changes in urinary sediment, including proteinuria and hematuria, as evidence of urinary SARS-CoV excretion, suggesting that the presence of a renal reservoir of the virus is present. And next, we'll talk about some of the mechanisms that we believe the kidney injury is used to is or goes through for to cause these type of injuries in the kidney. In fact, the kidney injury is and the mechanisms for kidney injury are thought to go through multiple pathways. Mechanisms of acute kidney injury with SARS-CoV infection are shown here. And one of the ways that SARS-CoV can impact kidney function is by penetrating the proximal tubule by linking with the ACE2 receptor and as well as CD147, as well as in the podocytes. By linking with the ACE2 receptor, virus entry is then possible into the podocytes, leading to kidney dysfunction. This causes glomerular disease, such as focal segmental glomerular sclerosis, acute proximal tubular injury, as well as tubular necrosis. So this is felt to be one of the mechanisms of kidney injury. In addition to that, SARS-CoV is responsible for an imbalance in the renin-angiotensin system. And this activation can promote glomerular dysfunction, fibrosis, as well as vasoconstriction and inflammation. And this again can cause damage to the kidneys. SARS-CoV infection can also trigger coagulation activation, leading to kidney vascular injury. And this can lead to ischemic glomeruli, as well as necrosis. The glomerular capillaries can become obstructed by red blood cells, and this has also been shown in co-infection, or I'm sorry, in infection with coronavirus. The elevation in cytokines are increased in severe infection, and this may also precipitate further acute kidney injury as a mechanism. Finally, unspecific or nonspecific, unidentified factors relative to ICU care management may aggravate kidney injury. TNF alpha, as well as interleukin 6, IL-1 beta, or interleukin 1 beta, MCP1, monocyte chemoattractant protein 1. All of these different factors can possibly precipitate injury to the kidney and unspecified mechanisms as of yet. But more than likely, these mechanisms are precipitated through the care of the patient in the ICU with this through this inflammatory response that we see. And so this can come from both the hemodynamic instability of the patient, fluid resuscitation, fluid restriction, nephrotoxic drugs, the ventilator management in the patients with high level of PEEP, as well as the cardiac and pulmonary dysfunction that we see in patients in the ICU. And so the treatment of these patients for their underlying infection can then cause this systemic inflammatory response and the alteration of the normal pathway of these cytokines that can then lead to further injury in the kidney. So one of the most important ways that COVID-19 affects patients is through secondary infection or sepsis. So we know that admission in the ICU is required in about 20% of the patients who have coronavirus. ICU patients are more susceptible to hospital-acquired infections, and that is associated with an increase in both morbidity and mortality. ICU patients with COVID-19 are more prone to develop bacterial co-infections. And this is shown on the next slide. where here we show a Kaplan-Meier curve showing the proportion of patients with who have bloodstream infections. And what we see is that patients who are not infected with COVID-19 versus those who have COVID-19 have a much higher rate of secondary infections in their bloodstream. So, how does this impact the care of the patients? Well, shown here, you can see that overall there's nearly 60% of the patients who develop secondary infections. And these are compared to those in hospital versus ICU, and looks at their discharge from the hospital as well as their death. And as you can see, in the patients who have secondary infections versus non-secondary infections, there's a higher rate of death and a higher rate of in-hospital infection in this patient population. So far more patients are impacted when they have a secondary bloodstream infection. In fact, the secondary infection rate in critical care patients is much higher in those patients with severe infection with COVID-19, about 83% versus only about 15% of those patients without severe disease. So patients with infection, again, severely impacted by having secondary bloodstream infections. And so we know that the incidence of bloodstream infections was very high, and the cumulative risk of bloodstream increases with your ICU stay. ICU bloodstream infection risk was higher in COVID-19 patients than non-COVID-19 patients, even after only 7 days of an ICU stay. So clinicians and intensivists who are taking care of these patients in the ICU should be keenly and particularly aware that the co-infection of any bacteremia can significantly impact both morbidity and mortality in these patients. So in summary, severe acute respiratory syndrome that's caused by coronavirus infection is known obviously to cause the pulmonary infections or pulmonary complications that we see. And the systemic inflammation that's precipitated by this infection can lead to multi-system organ dysfunction, particularly in patients who are at very high risk. These patients are typically managed in the ICU setting. ARDS and respiratory failure, sepsis, acute cardiac injury, heart failure were the most common critical complications that caused exacerbation of patients infected with COVID-19. Common complications were observed more frequently in patients who died from acute respiratory distress syndrome. And that included having underlying sepsis, acute cardiac injury, heart failure, and acute kidney injury. And so these comorbidities that are seen in patients who tend to be elderly, tend to have severe COVID-19 infection, are typically managed in the ICU and have a significant impact on their overall care. So with that said, this is our transplant team here at Houston Methodist and my colleagues that I work with every day. And I just wanted to show our team here. And if there are any questions, please, I would be happy to answer them in our Q&A session to follow. Thank you very much, and have a good afternoon.
Dr. Mobley, thank you very much for that excellent talk on the ICU care of the COVID-19 patient. And since we've shared a lot of patients, we really admire your dedication to everything you do for us. Thank you. It's now my great pleasure to invite another excellent ICU doctor, Dr. Davina Toison. She's a pulmonologist and intensivist specializing in critical care medicine, anesthesiology, and critical care for the Houston Methodist Specialty Physician Group. Dr. Toison is currently the CV ICU Medical Director for the Houston Methodist DeBakey Heart and Vascular Center and is the co-chair of the ECMO CMPI, as well as a standing member of the Critical Care CMPI. Dr. Troison has more than 30 years of experience in the medical field, graduated from University of East Ramon Madagascar Memorial Center, and completed her residency at the University of Texas Health System. We welcome Dr. Troison. Thank you very much.
I'm Divina Troison. I'm the CVICU Medical Director at the DeBakey Heart and Vascular Center in Houston Medical Hospital. I have no disclosures for this talk. And as you have already heard from the previous talks, COVID-19 has caused a global devastation and panic, mainly because of its transmissibility, incidence, mortality rates, and mutation emergence. And as of May 3rd, there are already 153 million confirmed cases, with 3 million deaths, and still with 721,000 new cases, despite the 1 billion vaccine doses that have already been administered. Majority of the cases are in the Americas, Europe, and Southeast Asia. In the United States alone, there are 32 million confirmed cases, and it's mainly from community transmission. And as if you heard by now, there are no targeted COVID-19 therapeutics. The emphasis of supportive therapy is on oxygen delivery. The spectrum of manifestations range from asymptomatic to having severe ARDS or even multi-system organ failure. So refractory ARDS now has prompted ECMO therapy as a rescue therapy, despite it not having been adequately determined as specifically beneficial in this patient population. So in March 2020, the World Health Organization had published interim guidelines recommending its use in ARDS patients with COVID-19 unresponsive to conventional therapy. This has stemmed from our knowledge of the VV-ECMO having various success in patients from different etiologies. In 2006, the Caesar trial has recommended referral to an ECMO center to improve survival. And in 2009, ECMO was successfully used in H1N1 with a 21% mortality rate. In 2016, ECMO use in MERS was associated with lower mortality. And in 2018, Eolia trial had showed us a lower 60-day mortality in the ECMO group as opposed to the conventional management group. And as of May 3rd, there are more than 5 million patients with COVID-19 who have been placed on ECMO with a 49% mortality. Majority of them are in North America and in Europe. Because of the COVID-19 pandemic, there has been a published article about planning and provision of ECMO services for severe ARDS. It highlights the importance of ECMO preparedness and acknowledging its unique challenges during this outbreak of an infectious disease. It also reiterates the use of ECMO in specialized centers globally. It also affirms the need for judicious allocation of resources and adhering to strict infection control measures. And also it highlights the importance of safety and coordinated movements of staff and equipment to improve ECMO access. In the early part of March and beginning of the pandemic, China had published an article regarding their 8 patients. At that time, they had a 50% mortality with a duration of mechanical ventilation ranging between 4 to 21 days. However, they have said that when ECMO is applied timely and safely, it can be an effective tool in improving clinical outcomes in patients with COVID-19. Dr. Silva, however, had also said that patients with need for ECMO should go to specialized centers. Now, patients who in these specialized centers already have a 33 to 92% mortality when treated with ECMO, but when patients with ARDS due to COVID-19 undergoing ECMO, their mortality rate had increased to 82.3%. Thus, they stated that there's not enough evidence to support its use in this patient population. This was echoed by the pooled analysis of the Italian group, saying poor survival of ECMO in patients with ARDS. So ELSO had published its interim guidelines in the early part of last year, saying that ECMO, when used as salvage therapy, should be used until further decompensation. So there's not enough supported data, but it is still preferable to not initiating ECMO at all in such patients. They've also come up with an algorithm to determine which patients can benefit, or at least when ECMO will be recommended on this patient population. Now, later part of the year, a major academic medical center had released their outcomes on on 6 patients. Of course, younger age population, most are male and obese, but they have shown 83% of their patients are still alive, with 67% having been successfully decannulated. So they concluded that VV-ECMO can successfully be utilized in this patient population. And again, there's another group who published their study on outcomes of their patients after the first wave, now with a larger volume of 20 patients, all placed in VV-ECMO. And they have noted already that the older age are associated with increased hospital mortality. There's certain complications that have noted were associated with mortality, such as culture-positive septic shock, culture-negative SIRS, and renal failure. But their main cause of death was septic shock, culture-negative SIRS, and stroke. So even though ECMO can be used in patients with COVID-19, patients with refractory ARDS, they have recommended that proper control of bacterial infections is critical in improving patient outcomes. Now, ELSO had published their data from 213 hospitals and noted that their 90-day mortality was less than 40%. This was also echoed by the Paris group, where their 60-day mortality of the patients they have placed on ECMO with COVID-19 is the same or similar to their 60-day survival of the patients that they have taken care of in the past 2 years for severe ARDS, even from other etiologies. So they had said that, ECMO can be considered for this patient population as well. Now, the local Texan group have also shown that their survival to discharge is 57%. However, in this particular article, they have stated that the time from admission to ECMO was less than 12 days, with a median of 11.5 days, which actually affected their higher survival to discharge. Now, the Chicago group in this particular study have shown their outcomes of 40 patients with a mean BMI of 34 and obesity as the primary pre-existing condition. And they have stated that their mortality is only 15%, but it appeared like they're more selective in their patient population. Their patients has a time of onset of symptoms to intubation of a median of 9.8 days. And their median days of onset of symptoms to ECMO initiation is less than 14 days. And their ECMO runtimes are less than median of 30 days. And their hospitalization has a median of almost 45 days. Most of their patients are no longer receiving ventilatory care and ECMO support at the end of their study. But they also have noticed less complications, no ischemic strokes, no use of inotropic support, and none of their patients actually require tracheostomy, simply because of their advocacy of early extubation strategy. They have patients who have been extubated within 13 days of ECMO cannulation or initiation. Now, also in this multi-center registry, they have noted 90-day survival of 41.7%, but they've also noted that the survival is better in those patients who've been mechanically ventilated in less than 7 days and those who are of younger age. Now, there's also another article to support this, that younger patients actually are better survivors. And also the patients who who have shorter duration from symptom onset to cannulation and shorter duration of ICU length of stay prior to cannulation have better survival. And in fact, this particular study showed that each day from ICU admission to cannulation increased the adjusted risk of death by 4%. And each year increase in age increased the adjusted risk of death by 6%. Now, one other study in Europe showed their outcomes, which is actually more of a 6-month all-cause mortality, which is a little higher to 53%. But again, remember, this is a 6-month all-cause mortality compared to the other studies that have shown the longest is only a 90-day mortality, and most of them are in-house mortality. But this particular study had showed that it's mainly advanced age and low arterial pH is the one that affected their 6-month mortality. Now in HMH, I report to you our experience where we have not changed our inclusion and exclusion criteria, except that we have included age of more than 65 years old, more than 2 weeks of COVID positivity or onset of symptoms, and greater than 7 days on mechanical ventilation as part of our exclusion criteria. In fact, in the early part of the year of 2020, we have come up with an algorithm to help the clinicians in all our system hospitals determine like what are the optimal management of patients with COVID-19 and when to call for ECMO support. We all had our own surges, ups and downs of patient population on ECMO depending on the surge. Majority of them are VV ECMOs with a 32% mortality. And we have found out that patients have improved survival when they're in the younger age group, higher BMI, shorter run times, shorter time between admission and intubation, shorter time between intubation and ECMO insertion, and a shorter time between admission and ECMO insertion. However, we have not noticed any influence in survival or mortality in patients with hypertension or diabetes, their PF ratio, proning therapy, or use of Flolan. Now in 2020, out of the 20 patients that we have, 45%, we have 45% mortality, but all of them are in VV ECMOs. We have still 3 patients who are in-house, and we have noted no influence in survival or mortality with all the variables that we have noted in 2020. Coincidentally, in December 2020, NIH had stated that there's insufficient data to recommend either for use of ECMO in patients with COVID-19. However, this particular paper showed the result of 11,000 patients across US academic centers, showing an overall rate of in-hospital death of approximately 45.9%. They also have a lengthy hospital stay, but they've also reiterated that in-hospital mortality increased with age. And so they concluded the therapy will require appropriate selection of patients that would mostly benefit from the ECMO use. Now, ELSO had updated their guidelines in April of this year and stated the ECMO run may be longer this time, but the overall mortality also may be increasing. And in fact, this is the latest ELSO data showing that the mortality is nearing 50% and currently is around 49%. Also, they have noted that when resources become constrained during a pandemic, then implementation of stringent contraindications is necessary. They also reiterated the formation of regional ECMO referral centers to facilitate communication, resource sharing, expedited patient referral, and possibly mobile ECMO retrieval. They also noted they're not to deviate from conventional ECMO management, and this is actually even included in the paper that they had published recently. Now, Paris had released their data, which included a 90-day survival on patients who are actually of younger age with less days between intubation and ECMO use and ECMO cannulation, as well as a lower pre-ECMO renal component of the SOFA score, which is an independently associated with improved 90-day survival. Their most common cause of death is multi-organ failure and septic shock. But they've also noted that when patients are admitted in a center or an ECMO center with a higher caseload, they have improved survival. So they advocated management of these patients in a center with a high caseload. Now we know that we can use ECMO severe COVID-19. The question is, should we? Does the evidence suffice? When is it justified and when is it unjustified? We all know that patients who survive critical illness are a higher risk for long-term physical, psychological, and cognitive deficits. However, while we know that ECMO shows survival benefits, the impact on long-term recovery on patients with COVID-19 was vastly unknown. Now, recently, well, actually very recent, it's in April 30, there's an Oracle group who presented an American Association for Thoracic Surgery showing that long-term recovery of COVID-19 survivors is not negatively impacted by ECMO. This particular group from 5 academic sites studied and measured physical, psychological, and cognitive defects in 46 patients on ECMO and compared them to 262 mechanically ventilated patients not on ECMO. And they have noted that the rates of physical, psychological, and cognitive defects did not differ significantly. That is actually the first study that have shown that. Now, when is ECMO use during COVID-19 pandemic unjustified? So we know that the use of ECMO in a pandemic can follow a U-shaped curve. So when patient load is increasing, ECMO use also increases. However, when there's a severe surge of patients, there's going to be a decline in ECMO use, mainly because of the decrease in resources, and at some point may have to be abandoned altogether. Now, with decreasing patient volume, there may be an increased use of ECMO again for those who qualify, but at the same token, there might not be enough patients anymore who qualify. That's why the downward green curve. However, there's also this conundrum of ECMO capacity, which most of the hospitals have reached at this point in time, meaning that the ECMO use should not be considered in a vacuum, because it's not only the patient alone that has to be considered, but there's the ECMO specialist, the ECMO bed, the ECMO perfusionists, the intensivists, the surgeons, or even equipment, etc., that all have to be considered when thinking about ECMO capacity. Now let's talk briefly about VA ECMO in COVID-19. As we all know, the literature is very scarce in supporting or discouraging the use of VA ECMO in COVID-19, despite literature showing a significant proportion of COVID-19 patients with cardiovascular complications. Now, the ELSO consensus guideline had stated that placing a COVID-19 patient in VA ECMO should be made on a case-by-case basis. It should be avoided, though, in advanced age, with multiple comorbidities, and in the presence of multi-system organ failure. In the ELSO registry, only 4% of the patients receive VA ECMO, and they have noted that even though the in-hospital mortality for all comers was 37%, the mortality of those who received ECMO was even higher. Now, there are 3 case reports that I have noted here that showed successful use of VA ECMO in COVID-19 patients. However, if you notice, these patients are relatively younger, and they're mostly patients who have either cardiogenic shock or combined cardiogenic and respiratory shock without other organ dysfunction. So one patient had an MI, the other patient had a cardiac arrest secondary to saddle PE, and the other patient mainly had cardiogenic shock. None of them had other organ failure, and that could have contributed to their having good outcomes. Cardiogenic shock in COVID-19 is likely secondary to an exacerbation of underlying cardiac disease, and from a myocarditis or cytokine-induced or right heart failure from pulmonary venous thrombosis. So COVID-19 patients presenting with cardiac injury are most likely have an underlying cardiovascular comorbidities and by that criteria are of advanced age, and these two increase the mortality risk. Now, VA ECMO being resource intensive is going to be contraindicated in these patients with the presence of multi-organ dysfunction. So some authors even recommend that VA ECMO be reserved for the rare cases of patients with COVID-19 who present with the isolated myocardial dysfunction. The last time I had a talk, I was asked about ECMO in pregnant women with severe COVID-19. So I did a research and I found these 3 case reports of younger pregnant women with earlier age of gestation, and all of them underwent successful VV cannulation and were all decannulated and discharged home with the fetus being of normal growth and no overt fetal compromise. 3 of the 4 patients in this case reports gave birth after decannulation, but 1 of them gave birth after 106 days post cannulation at term gestation, and again with good APGAR score. So ECMO is actually safe in pregnant women with COVID-19. Now, we don't have any experience cannulating children with or without COVID-19 in HMH. However, I present to you the findings of the updated 2021 guidelines from ELSO recently, showing that children, minority of the children develop multi-system inflammatory syndrome within 4 weeks of exposure to COVID, and they can rapidly progress to shock. However, most children who develop this multi-system inflammatory syndrome, they recover and they're discharged home. And rarely do children require ECMO. And if they do, the basic principles of ECMO use in children do not significantly differ from ECMO use for other diseases. So in conclusion, ECMO as a rescue therapy for severe COVID-19 has shown survival benefit. However, early ECMO provision is necessary and advocated to improve chances of patient recovery. Now, appropriate patient selection is of utmost importance, simply because these certain variables actually affect survival and mortality, such as age, comorbidity, multi-organ failure, timing between reaching the threshold for indication, and the decision to begin ECMO therapy. The complications that may affect outcome include bleeding, thrombosis, stroke, secondary infections, AKI with or without RRT, shock, and multi-organ failure. There's still limited data regarding VA ECMO use in COVID-19, except for, like what I mentioned earlier, isolated myocardial dysfunction. ECMO use in pregnant women with ARDS due to COVID-19 is safe, with monitoring and management of a multidisciplinary team. Now, children may require ECMO support, and the management should follow conventional guidelines. There's no data to recommend deviation from conventional ECMO management for COVID-19 patients during their ECMO run. ECMO is clearly a finite resource. There are several limitations to providing this resource, one of which is capacity. So when a hospital system capacity diminishes, the contraindications for ECMO use should become more stringent based on characteristics associated with increased mortality and longer ECMO runs. Patient referrals to specialized ECMO centers is advocated to ensure proper provision of care and compliance to standardized ECMO guidelines. ECMO centers, on the other hand, should consider forming networks within geographical regions to pool resources and coordinate patient referrals for ECMO. And that is it for my talk, and I thank you all for your attention.
Thank you, Dr. Troisan, for that excellent overview of ECMO and COVID. I know it's kept you busy this last year. So thank you for your talk. And for our next talk, it gives me a great pleasure to introduce my colleagues and leaders in our J.C. Walter Transplant Center here at Methodist. First, I'd like to introduce Julie Corcoran, who's currently the Director of Abdominal Transplant. She earned her bachelor's degree from Montana State University and her master's degree from Western Governors University. Second, it will be Lori Loza, who is the Director for Thoracic Transplant here at the Walter J. C. Transplant Center. She earned her bachelor's from South University and her master's degree from UT Tyler, and they've both been part of the transplant team here for over 12 years, and we look forward to their talk on COVID-19 vaccination in transplant patients, challenges and opportunities.
Good morning. So we're here to tell you the story of our COVID vaccines in transplant. So the story kind of begins. So on the afternoon of 12/29, I get a call from Lori, who received a call from our Executive Vice President and Chief Innovation Officer, Roberta. Lori explains that she got a call from Roberta inquiring about our ability to do a vaccine clinic for our transplant patients, but she deferred to me since she was on her way out of town to go skiing. So Roberta and I do connect. After wishing me a happy new year, Roberta asked if we are going to be able to do a vaccine clinic for our transplant patients. So of course, we think this is a great opportunity. So I say sure and ask Roberta kind of the time frame of when she's looking to do this. And the answer is in the next 7 to 10 days. So of course, my response is sure. And Roberta then tells me to stay tuned. We'll be in touch to get more details. And of course, after the call, I just kind of have this oh panic moment, and I think my face can be described below in the emoji, and that is sheer panic. So kind of how the story begins is that we have a lot of planning to do. And so we have over 4,000 patients who are either pre-post or LVAD patients in our program. And so some of the main questions that we had about that was who can have the vaccine? How do we prioritize patients? How many doses are we going to get? Where do we set up the clinic? How do we schedule the patients? Which vaccine are we going to have access to? Of course, this is going to be essential for planning with timing and getting the consents. And how will we know if patients have or do develop antibodies to the vaccine? How are we going to minimize disruptions to our daily activities in the transplant center and provide the patients the vaccines? So of course, when I think about all these and reach out to Lori, of course, oops, sorry, no service up here on the mountain, but she does send a beautiful picture, which is posted below to see. So on to phase 2. So the key players in this process, of course, are all of our hospital teams, to include the COVID task force that we had previously put together to help manage our COVID population in transplant. So this did entail some daily meetings with the task force to create protocols and guidelines around vaccination. And of course, somebody brought up the opportunity that this is a great research opportunity, and that I just realized then planning is going to be a lot more complex at that point. So then onto our EPIC and IT teams. So they're going to have to build a vaccine schedule, create order sets for the vaccine doses and labs, and then get everybody the proper access to do this. Our lab would have to create a separate team to do the vaccine draws that we're going to need that are going to be involved in research, and then the process and storage of these lab specimens, and then tubes for research. So our research program, I knew, would probably need people to educate the patients and consent them to research, and then they would also be involved in some of the storage process on the specimens that they're going to need for research. The pharmacy, of course, are the big players. How are they going to distribute the vaccines? What is their capacity for giving daily vaccines? Are they going to draw the dose? Do we have to draw the dose? How are we going to reconcile the doses? And how are we going to be prepared for an emergency if one takes place? So what we're calling the manuscript here is the protocol that our task force put together for who should be vaccinated. So ultimately, we decided that all patients who are 30 days post-transplant would be vaccinated unless they've been in the process of being treated for rejection. And then also if they're receiving any of the COVID therapies, convalescent therapy, or any of the monoclonal antibody infusions, they would be ruled out until they're 90 days post-treatment. And then the patients need to be asymptomatic and free of COVID symptoms at the time of vaccine. They can't have had vaccines within 14 days of receiving this vaccine. And then after that, then we decided how are we going to prioritize the vaccine. So our decision was that we would go with all post patients in the first year. After their 30-day mark. Wait-listed patients for all of our heart and lung programs, because there are smaller patients who definitely are the sickest, and then our recipients and donors who have upcoming living donor surgeries, and then wait-listed patients for liver and kidney based on their estimated time to transplant. So with those, we had to look at the MELD scores and EPTS scores for kidney. So after that, we would move on to priority 2, which included all LVAD, all post patients greater than a year, and then all of our waitlist patients not included above. Our priority 3 would be previous living donors and any of the patients not mentioned above. So moving on, we were able to identify space within the hospital that was being utilized by our hepatology clinics. This allowed us 6 to 8 clinic rooms that we would be able to use for vaccine administration. Of course, we had to look at patient satisfaction and what to do to avoid long patient waits and delays. So what we ultimately decided is that if a patient was scheduled for routine transplant services, they would receive the vaccine as part of that visit. And then if they weren't scheduled for any other services and they were only coming in for the vaccine, they would be seen in the vaccine clinic only, where a separate lab would be offered to them. So this, of course, creates 2 locations now, but we still have to function as one. So our EPIC team was surprisingly in a short time frame able to build out their schedules. And of course, we had to have 2 schedules, one by location, and then from there it had to build in the appointment types. So from our location, we had the main transplant clinic, then we had our vaccine clinic, and then for all the patients that needed labs, the lab actually needed all those patients then to be on the lab schedule as well. So the vaccine types, they were able to type out or create an initial vaccine appointment schedule. And then from there, the booster appointments had to be broken out by Moderna and Pfizer specifically based on their initial dose. So EPIC Team 2, which was more our clinical team, was able to build what we call our express lane. This was a very nice feature that was built and included the vaccine order and then the lab order set that tests that. So we didn't have to order all of the labs separately. We could just click on the smart set. And then we also built out smart phrases that we created for the vaccine administration itself. The lab was able to identify a dedicated team. We identified one conference room in our clinic that we dedicated to the lab. They gave us 2 phlebotomists that were assigned strictly to the vaccine clinic. The pharmacy, that process, they were able to create a central pharmacy within the hospital in a large conference room that was utilized for vaccine pickup and drop off, and they did all the reconciliation there. The check-in, they checked in with us pretty much daily until they knew that we had the proper Pyxis access and that our Pyxis was stocked with anaphylaxis kits and that we had the capability to keep vaccines in the refrigerator there. They had to do some heavy educating on storing the vaccine, drawing it, and then how to reconcile and all that stuff that kept us in compliance. We utilized MS Teams with the pharmacy to communicate dosing and our needs. And then for the research, they were able to get an emergent IRB approval for research. And then they dedicated 2 to 3 coordinators for educating and consenting our patients. The conflicts that we found throughout this process is definitely an increased workload. We obviously were not given a vaccine team, so we had to basically put one together with our existing staff. So we have in between 40 and 50 coordinators in our program. And so we broke those up and asked them to each cover 2 to 4 hour shifts weekly to help administer the vaccines in the clinic. The management team created a rotation to help with organizing the clinics and kind of keeping an eye on the vaccine. And then our regular work pretty much comes to a major slowdown or even a halt on some days. It was a little bit challenging not knowing what vaccines we were going to get until the day prior to clinic. And then obviously if we started with Moderna and switched to Pfizer, we did anticipate there was going to be an overlap in the dosing for those with the boosters. So when it comes to communication, we definitely felt that there was some over communication with MS Teams that we used. The texts that were sent out, we had phone calls directly, and then also mass emails that kind of went out from pharmacy to other areas in the hospital. And so we did find that our phones were consistently going off, our emails were flooded, and then also alerts on the phones with text and team chats. Unfortunately, with all of the mass communication that went out, we did find that occasionally people were left off of communications, or people joined the process that weren't being included in the group chats and the emails. So even though we felt there was a lot of over communication, in the end, we kind of found that sometimes there was a little under communication. So the vaccine administration itself, the problems we found there is that we didn't obviously know until the day prior, some days, which vaccine we were getting. So sometimes it would be 5 or 6 o'clock at night, we would get the notification that we were getting the Moderna. And so we'd have to scramble and put in 100 orders so we would be ready the following morning to give those doses. The other challenge we had was we had medical assistants in the clinic that were willing to give vaccines and help, which was great, but they could not actually place orders in Epic. So the nurses would have to take time out of their day to help do that. And then calculating and reconciling the doses was a little bit tough too, to make sure that there were no doses that that expired or didn't get used. We definitely had to have a backup plan for last minute doses, as we had some patients show up that we anticipated getting the vaccine, but they either maybe just had a vaccine, or maybe they were febrile, or found out that they had something that prevented them from getting the vaccine in that day. So we would have to work closely with our other teams to make sure that that dose got placed somewhere. And then this is just a quick little overview of our monthly call volume prior to vaccine, and then go live, and then shortly after. So definitely how we chose to communicate to patients was mass communication. We sent out white chart notification, we sent out email blast, and then all of our patients in priority 1 received a call from their coordinator asking them to come in. So you can see in November and December, we had call volumes averaging about 7,300 to 7,500 patients calls a month, and that spiked to about 8,330 in January. It tapered a little bit in February and March, but still right around the 8,000 mark. So not only did we get calls from our own patients, we did get some calls from other patients at other transplant centers, because they knew that we had the vaccine and were giving it to transplant patients. So they called to see could they come over to get that. We had a lot of caregivers that wanted those, and so that created a little bit of an extra call volume as well. So at that point, we're pretty much ready to go live at this point, and Lori's back from her ski trip, so I'm going to pass off to her and let her kind of give you the details on how we managed this clinic and went live with that.
And so it begins. Our first vaccine clinic was actually on the 5th of January, was a Tuesday. We started off with just a handful of patients, but within a couple of days we were, or at the end of that week, we were already booked up to over 75 patients per day. In the first week and a half, we were provided Moderna, and that was fairly easy. It's good for 12 hours out of the fridge, and up until the time that you actually draw up the doses, that's when the clock really starts. You have 6 hours to give it after that. So it's really easy to manage, the doses and the number of patients coming in between our morning clinic and afternoon clinics with the Moderna. Then about halfway through the second week, we were given Pfizer, which is needed to be diluted by the central pharmacy. And so that was a little bit more challenging. Number one, there's only 5 doses per vial. And the clock started ticking down in the pharmacy before we even picked it up. And so because we had 6 hours after dilution to provide the vaccine, it did increase some of the complexity. And then by the second week, we were really at full capacity at about 100 patients a day. So this added a lot of extra running back and forth to get vaccines. And we included a little map here of Methodist Hospital. You can see that in the lower left-hand corner is the outpatient center, which is where the transplant clinic and our vaccine clinics are located. And then as we cross over University and Bannon Street to get to the main hospital site, that's where the central pharmacy was located, as well as the employee health clinic, which is where we would pick up vials and drop off any extra doses that we might have had. This, led to a lot of extra running around by the courier team. A lot of times it was Julie and myself. But conveniently located close to Central Pharmacy is Starbucks. And so a lot of times at the end of the day, as we were kind of wrapping things up, we would swing through there and get our beverage of choice, as shown in the picture. The other thing with pharmacy at this time was that they had also opened up vaccine clinics within our building on the oncology BMT floor, as well as our radiology floor. And so the benefit was that we would share vaccine doses throughout the day as patients would the patient flow would increase and decrease. Whoever had extra doses or things that were about to expire and had a patient in front of them. But that also added some complexity at the end of the day when we were reconciling doses. And we were lucky that one of our PRN nurses offered to really champion the COVID vaccine that we put on the liver clinic downstairs. And so she really took charge of that clinic all 5 days a week for the 2.5 months that we were down there. So at the beginning of February, we really still needed to get the bulk of our patients vaccinated, and we were off to a great start, but we were allowed to do a mega clinic where we ended up utilizing the lobby of our building, and we had to figure out how many booths we could get set up. We had to organize who was going to man the booths and what other support staff we were going to need. So we came up with a list of 50 people to help us out with that. All volunteers from the transplant staff and our physicians. And what we ended up doing was designating duties for everybody to participate in. And so this really helped keep us organized. As patients would roll in from the parking garages, we would do the screening, verify their appointments. Of note, we did find that there was one patient who had been placed on the schedule to receive the vaccine, however, was currently sick with COVID, undergoing treatment, and therefore not a candidate. He, in goodwill, passed his appointment time on to his family member who showed up in order to receive the vaccine on their own behalf. And that caused a little bit of a confusion for a few minutes. We had to figure out what we're going to do with that patient and their caregiver. Ultimately, we were able to manage to get them in, but it did just raise the awareness that, it was kind of like winning the lottery. Patients were so happy to be invited to get the vaccine that they were passing off their appointment slots if they weren't able to make it to others that may or may not have qualified. Once we were rolling and had given pretty much the month of January's initial vaccines. So as we headed into February and we had switched from Moderna to Pfizer, there was going to be a huge overlap in the booster clinics. And we didn't want to prevent patients from getting new vaccines. So in order to accommodate new patients getting their initial vaccine, as well as keeping those scheduled for boosters on time, we doubled up our booster clinics on Monday, Wednesday, Friday, seeing about 200 patients a day. And then we would open up Tuesday, Thursdays for new patients so that we can continue to vaccinate our patient community. And so this was very helpful in organizing the number of doses, if they're going to be morning or afternoon. That way we could kind of split up the vials throughout the day so that we wouldn't have any expiring doses. And on the days that we were doubled up with booster vaccine, we took great caution in trying to ensure that nobody received the incorrect booster. So we created color-coded labels that we put on the syringes. We labeled the patient, actually. We labeled the vaccinators, and we labeled the rooms designated for each brand of vaccine. And so that actually worked out very well. It was just really busy. Okay, so everything was actually going pretty well. And unfortunately, we had the freeze. And when I say that everything froze, I mean everything. Pretty much all of our outpatient processes came to a halt as the state of Texas closed down with single-digit temperatures, freezing rain, and snow. And so as the storm rolled in on that Sunday night, by Monday, everything was shut down. And it was 2 or 3 days before most of the employees were able to make it back into work. And so it was almost like deja vu of the pandemic in regards to supplies. Although we had toilet paper and Clorox wipes as well as PPE, now we were out of food, water, and electricity, which was also, heat. And so it was really quite detrimental to the processes, as well a lot of the just patients and staff. So what we had to do was, along with the power outage that was statewide, we got a call Monday morning from Harris County saying that the freezers holding their vaccines had lost power, and that they had around 5,000 doses that they needed to get out as quickly as possible. So Methodist was able to rally whoever was on site and give about 1,000 doses that Monday morning before they expired at noon. And it was a lot of our administrators and our own Julie, who was here helping to give those vaccines. As luck would have it, I was out of town, and I had planned to be back Sunday morning prior to the storm rolling in, but as the weather was a little worse than anticipated, they had shut the airports down early and my flight was canceled. Despite the freeze in February, you could see that with the number of new and returning vaccines, our clinic numbers really took a pretty good increase. And so again, as Julie alluded to earlier, this was really all manned by our own clinic staff as well as physicians. So it was a huge effort in order to get everybody through the process. Ultimately, initial vaccines, we ended up doing a little over 2,600. That included our Saturday initial mega clinic with 800 patients that particular day. And you can see in the early phases, we really focused on those patients who were at most risk, which was post-transplant, and the waitlisted patients, or those who were actively being evaluated. We did have about 300 patients that fell into the other category. That included living donors, some of our LVAD patients, and maybe some of those who were pre-transplant or being medically managed. Because we had such a great response with the research enrollment, we were able to stop enrolling new patients around the 1st of February, and we ended up with just under 1,000 patients that were actively going to participate in the study. Interestingly enough, that unlike some of the other service lines, transplant patients are scattered all over. And so we had patients driving in from Austin and Dallas, San Antonio, and then even some of our out-of-state patients were coming in, obviously Louisiana, our next door neighbors, but we had patients as far away as Georgia, California, and the state of Washington who actually said that we had offered the vaccine earlier than they hadn't been offered it yet, and they were happy to come over in order to get it. So that was really surprising to see them come from that far away. And all of those patients actually came back for the boosters as well. We did have a little bit of a drop off between first dose and booster clinics or booster doses. A lot of that occurred either because patients had been admitted to the hospital for various reasons. A few of them got transplanted between their first dose and their second dose, and they needed to wait 30 days to get the second vaccine. But overall, we ended up giving a little over 2,300 boosters and almost 750 on the booster Saturday clinic day. So this is just a collage of kind of the vaccine clinic itself. Patients were actually really excited and happy to show up for vaccine clinic. It was a great experience, and really we only had a few patients who opted out, and anybody who opted out of the vaccine tended to be just really afraid of just a lot of the stuff they had heard via the media. But we did our best to educate everybody and encourage them to get the vaccine, because we felt it was the safer option. And so as a COVID clinic kind of came to the close, at least the transplant COVID clinic was closing down in early March. Methodist had moved all of the vaccine clinics to the community hospitals, and this offered an increase in accessibility and scheduling opportunities, because we had opened up to more patients and their caregivers at this point, and so they were happy to sign up and get the vaccine closer to home. And again, it was really a great experience. Patients were very appreciative and excited about getting the vaccine, and we continue to encourage everybody to follow safety guidelines with masking and avoiding large crowds as we head into the era that our state and the country is opening up, lifting the mask mandates, and really encouraging people to have more opportunity to interact. Houston Methodist is back in the news with the requirement to mandate vaccine for its employees, and I'm sure you'll hear about that throughout the conference. Overall, it was a big success, and it couldn't have happened without the help of so many people. We definitely want to thank our EPIC team, the laboratory staff, pharmacy, all of the transplant center staff, our task force and physicians really helped lead us through the process, the research team, and of course, our good friends down at Starbucks that Julie and I often visited as we were running vials back and forth. And hopefully in the near future, we'll have a sequel that we can talk about getting back to normal. Thank you so much for your time and attendance. We appreciate you participating today.
Thank you very much, Julie and Lori. That was certainly a massive and complex effort and quite the achievement for our transplant patients. I'd like to remind our audience to text in your questions, and we'll address those at the Q&A section. And now it's time for our final talk in this session, and it is my pleasure to introduce Dr. Linda Moore, who is the Director of the Scientific Core for the Department of Surgery and Transplantation at Houston Methodist for the Houston Methodist Research Institute. She's an Associate Research Professor of Nutrition and Transplantation in Surgery with a PhD in Biomedical and Health Sciences from Rutgers University. She is responsible for investigator-initiated clinical research development for the Department of Surgery and has over 100 peer-reviewed publications. So it's my pleasure to introduce her. She'll be presenting on outcomes of transplant recipients at Houston Methodist. Dr. Moore.
And the committee for inviting me to give this presentation. I'll be talking today about the COVID vaccine response in transplantation. I have no Good afternoon. Thank you to the organizers and the committee for inviting me to give this presentation. I'll be talking today about the afternoon. Thank you to the organizers and the committee for inviting me to give this presentation. I'll be talking today about the COVID vaccine response in transplantation. I have no disclosures, and the objective of this presentation is to report the status of the SARS-CoV-2 response to COVID-19 vaccination of solid organ transplant candidates and recipients. For background, we want to consider that the SARS-CoV-2 infection leads to COVID-19 disease, that immunocompromised patients are at high risk for having more severe outcomes from the disease. And those patients might be people with chronic diseases, like late-stage chronic diseases such as cardiovascular, kidney, pulmonary, and liver, and also transplant recipients and patients with autoimmune diseases because they're immune suppressed as part of their therapy for their transplant or their autoimmune disease. However, these patients groups were not broadly evaluated in the pivotal trials for vaccine approval. Some people with cardiovascular disease or liver disease might have been in those trials, but they didn't have late-stage disease. So we don't know as much as we want to know about how to manage these patients with the vaccine. Thus, the purpose of this report today is to address the knowledge gap regarding patients who are immune suppressed and receiving the COVID-19 vaccine. To do that, our transplant center evaluated the humoral immune response of transplant candidates and recipients. Our approach was that a clinical vaccination campaign was organized in early January of this year. Using 2 doses of the messenger RNA SARS-CoV-2 vaccine, we used both Pfizer and Moderna, with each patient who got one of those getting their second dose of the same kind. Transplant candidates and recipients were invited to receive the vaccine here if they were asymptomatic for COVID, had not received passive antibody therapy in the last 90 days, and had not received other non-COVID related vaccines in the previous 2 weeks. Transplant recipients had to be beyond 30 days of receiving their transplant in order to get the vaccine. Our approach included blood sampling at 3 time points prior to dose 1, after dose 1, but before dose 2, and after dose 2 of the vaccine. We looked at the anti-SARS-CoV-2 testing, combining first 3 different assays to examine the spike protein, which is this protein that spikes out of the virus that you've seen on everywhere. And the tests that we used were 2 tests created by Ortho Clinical Diagnostics with FDA emergency use application approval, the total immunoglobulin qualitative assessment, and the IgG qualitative assessment. We also used an in-house test developed by our Houston Methodist Laboratory Diagnostic Service that examined a semi-quantitative assessment of titers of antibodies to these spike proteins. And then finally, we looked at a nucleocapsid antigen, which is the protein inside the virus that helps to detect the presence of an adaptive immune response to SARS-CoV-2 exposure, reflecting prior or recent infection. Our preliminary results demonstrate that during the period of January 5th to February 10th, our first cohort of patients that we vaccinated included 2,646 people. 1,000 of those had not received their second dose when we reviewed this data, so they're not included in this report. 813 had received vaccine at a special vaccine clinic day that was held on a weekend, and so we had no ability to assess their blood levels. But 816 patients have data available for this review. This figure shows the breakdown of that, and but it also demonstrates here in the middle where we split off the candidates and recipients. We noted that 72 patients had, at the baseline first blood level that we drew before any vaccination, had already developed some titers to SARS-CoV-2, and which meant that they had some exposure, so we excluded them. Then after we gave the first dose, but before we gave the second dose, we noted that there were 7 people who had a nucleocapsid protein that became reactive, meaning that in between the 2 dose periods, 7 people had been exposed to SARS-CoV-2. So we're reporting on this group here of 148 candidates and 589 recipients. Our preliminary results indicate that of the patients that we evaluated, who were candidates for a solid organ transplant, were most likely around 60 years of age, were most likely male, and were about evenly split or a little less likely to be non-white. In some instances, as you'll see in the kidney group of candidates, more were non-white than were white. And our recipients, the same is true. They were slightly older than our candidates. They were more likely to be male than female. And around 30 or 40% of them were not Caucasian or not white. And I bring that up just to point out that this data, that this group of people were diverse in race and ethnicity. As you can see here, our preliminary results demonstrate that our transplant candidates had a better response to 1 dose of the vaccine than our transplant recipients. Transplant candidates in the blue bar, recipients in the red bar, going left to right, heart, lung, kidney, and liver. The response here is the response to the total immunoglobulin test that was performed. In this picture, you see the response to the IgG test, again demonstrating that candidates had a better response than recipients. Candidates in the blue, recipients in the red, going left to right, heart, lung, kidney, and liver. This slide depicts the antibody titer levels, and the colors represent the strength of the titer. So a titer less than 1 to 50, which is no response, is shown in the dark blue, red in this case is a titer of 1 to 50. Green is a titer of 1 to 150. Orange is a titer of 1 to 450, and aqua is the highest titer level detected by the test. And the way the slide is laid out, it's still heart at the left, then lung, kidney, and liver on the right. And it's still set up as candidates first and then recipients. The dark blue bars are showing you in each one of these groupings which patients had no response to the first dose of vaccine. And you see that the highest of these no response dark blue bars is in the recipients of each of the organs that we represented here. You can also see that the candidates had differing levels of response, but more likely to have a positive response instead of no response than the recipients. We interpret from this that some candidates in our cohort appear to have a good humoral response to the first dose of vaccine despite their chronic disease. Chronically immune suppressed solid organ transplant recipients are less likely to produce a humoral response, however, after one dose. And then that a lower response is positively correlated also with patient's age and differs slightly between the type of transplanted organs. Our preliminary conclusions are that solid organ transplant recipients may need additional vaccine. We're awaiting our results from the response to the second dose that will provide more information on which patients do not exhibit an overall reactivity to by testing these assays. It remains unknown whether patients without a reactive result in the assays might still have some protection from the disease caused by this virus. Meanwhile, we are still suggesting that our patients should continue to wear masks and practice social distancing until we have further updated information. Thank you for your attention.
Thank you, Dr. Moore, for that great update and sobering update on the vaccination in our transplant patients here at Methodist, and certainly mirrors what we see nationally. Now we have a Q&A session, and so please text your questions in. In the meantime, I'll read the first one, which is really a comment from Dr. Bhimaraj, who's the division chief for our heart failure and transplant program. He just wants to acknowledge and give his kudos to Julie and Lori. They were truly the unsung heroes during this entire process of how we're able to care for our transplant patients, not just the vaccination program, but also the entire logistics of the operations for the transplant center. And he just wanted to convey his gratitude to both of them on behalf of himself and the MTC transplant program, and certainly echo that sentiment. So we'll start off with some questions. Dr. Spock had to attend to hospital duties, won't be available for the Q&A, but hopefully the rest of our panel is here. And we'll start, I think Dr. Adrega has the first question.
So this is a question for Dr. Salazar. Again, we really appreciated your commitment to this pandemic and trying to get rid of it. I have a lot of patients that ask me, why is it that vaccines tend to produce more antibody titers than the disease itself? And you pointed out that the range of antibody had a lot to do with whose convalescent plasma you could use. So is there anything that could shed a little bit of light into that? Because it certainly helps promote vaccination over allowing people to just say, I'll just wait till I get the disease, then I won't get it again, which we know you can get it again. Dr. Salazar?
Yes, thank you so much for that wonderful question. Can you hear me?
Yes, sir.
Yes.
Okay, great. Yeah, thank you for that wonderful question. So it's clear that vaccinated individuals that come in to donate plasma have very high titer of antibody in general. especially those patients that have previously had COVID. If they previously had COVID and then went on to get vaccinated, their antibody levels are just screaming high. And why is that? Well, the truth is I don't have a great answer for it, other than that, vaccination was really designed to mount an immune response. It was really designed for that intent. And therefore, vaccination, in contrast to natural infection, has adjuvants, immune adjuvants that are added to the vaccines that are intended to boost the immune response. And in general, while we don't know the exact answer, all I can think is that it's wonderful news that these mRNA vaccines were so quickly seen to be so efficacious and to cause such a robust humoral immune response in vaccinated individuals. So we're just really lucky that ended up being the case.
Thank you.
So great. So I have a question for Julie and for Lori. So really, as we encounter so much vaccine hesitancy in our communities and the misinformation that's out there, how did you guys deal with that? And just wanted to hear your experiences and how often did you encounter that, and what your strategies were for countering the misinformation?
Can you hear me?
Yes.
Okay. For the most part, we had a really great response to the invitation to get the vaccine, and I really think most people were looking forward to it and really excited about it. It was interesting that as we were prepping for the mega clinics and we were really inviting masses of people to come in on a short notice, that we went through like a lot of the wait lists and people that were a little bit further down on the wait list, offering them the opportunity to come in. There were a few people who were hesitant about getting the vaccine. A lot of it was due to the just a lot of the media hype and everything that had been going around. There were a few people that once you talked to them and answered their questions, they went ahead and came in for the vaccine. We didn't have a whole lot, but that was interesting. And maybe just because of the volume of kidney patients on the wait list that had the opportunity or had the invitation to come in, I feel like they were a little bit more hesitant than some of the others that we might have called. But I think it speaks loudly to have those patients who came from even California, Washington State, and Georgia as to really how much of a response people wanted to get the vaccine. Julie, do you have anything you want to add?
Sorry, nope, I think that covered it pretty well.
Remotely's on or not. No, I don't think we're sure. All right, thank you. I have a question for Dr. Salazar. Could you speak to the logistic issues you may have encountered with the monoclonal antibodies or antibody therapy generally for patients in terms of access from time of diagnosis on an outpatient basis?
That's a great question. Thank you for asking that. So certainly there are some logistical hurdles to monoclonal antibody therapy. The biggest one being that it's an infusion, right? That you have to present to an infusion center. So what's the best setting to sort of deliver that type of therapy? We're lucky to have Jennifer Berry, many other wonderful colleagues that have a lot of experience with infusion centers and could rapidly put in place the logistical processes, the screening processes, the wonderful pharmacists that assisted with screening these individuals to make sure they qualified and then got scheduled. So I would say that probably the biggest hurdle was that it had to be given as an infusion. As I presented in my talk, there's some hope, especially with the recent press release. Unfortunately, we're doing a lot of science by press release. We don't get the data until it takes quite a while. But in one press release, what was very hopeful is that a subcutaneous injection, at least very early on, seemed to be effective in preventing progression to symptoms. And beyond that, and especially for transplant patients, a subcutaneous injection appeared protective with respect to the risk of getting coming down with COVID-19 in the context of exposure, like in a household. So I think that's great news. As we saw the wonderful talk by Dr. Moore, we see that our transplant patients very likely do not mount a significant immune response, and we're going to need alternatives to try to combat that. And it seems logical to me that monoclonals really fit that little gap.
Yeah, thank you, Dr. Salazar. A question for Dr. Toisan. In your conclusions, you mentioned a network for ECMO, and I think that's really important. I mean, we get calls for ECMO a lot, and a lot of it comes down to how many machines we have running that day, what the outcomes have been the last few months or the few weeks, and it's really challenging to try to have some consistency in how you run an ECMO program, and it depends on the resources and what the peak COVID rates were at that time. But moving forward, pandemic and post-pandemic, what do you think the best way to kind of establish some kind of network, whether it's national, regional, to try to best allocate the limited resources we have?
Thank you for that question. Actually, that has been brought up even in our most recent ECMO CMPI meeting. Actually, the last two ones. That the one that I have researched, it's mainly in Europe, especially in Paris, that they actually have successfully formed an ECMO network in their local area. So because there are a lot more ECMO centers, no, shall I say, they have a lot more capacity for ECMO over there. And so they were able to form an ECMO network, and then they actually have ECMO mobile units who are retrieving patients from several community hospitals and even from homes, subways, and all that. So our network here, well, we're trying to form a network in the medical center. We don't have that much capacity as of yet, but as what you said, moving forward, that is really the goal, is to have, you're right, we do need a lot more of a resource pooling from around our, especially, in the medical center, we have a lot of ECMO centers, 3 better than the ones that they have in the other areas. So we should pool all our resources so we can actually share, which ones our patients would benefit from them. And so we would not deny the patients who most need them the most, And so, yes, we are moving forward. We are going to certainly do that, collaborate with with the hospitals within the area. So we can offer the ECMOs to those who need them the most.
Thank you. I think we have one more question.
Yeah, this is kind of a comment. This is for Linda Moore. And again, thank you for everything you've done to kind of put together all of this research. But, I was actually struck by the fact that almost 80% of our kidney transplant potential recipients, had a response because, we have a very hard time getting them to respond to the hepatitis B vaccine as an example. And I was speaking with a thought leader yesterday about the excessive deaths in the ESRD population in 2020, and it looked like we lost, out of about 500,000, we lost about 30,000 dialysis patients that had not been lost in 2019. So COVID-19 really struck that population very, very significantly. And since the ESRD population make up about 100,000 of the people waiting for a transplant, I think that this is very important data that everybody should take home, that in that population, and it looks like in the other populations, but the numbers really go towards, we really need to immunize the dialysis patients and the CKD4 and 5s before they get the transplant, because after, it's really, less than encouraging, the results. I don't know if you had any thoughts on that, Linda.
I do agree with you that the data are very interesting about our candidates, and I'm happy that we were able to reach out and include them in this effort. I think they will teach us a lot about what we need to do going forward. And we do have a few patients in this cohort who did subsequently receive a transplant. So we'll be very interested to follow their antibody progression or duration after the transplant as well. This is a rich data set. We're very happy that our leadership recognized a need to look deep into this and not just vaccinate without understanding what we were doing. Very.
Yeah, thank you, Dr. Moore. I think we lost the audio just at the last few seconds there, but thank you for your efforts and for your comments. That wraps up the second plenary session, and we want to thank you guys for being here. On the agenda, starting, it says it starts at 1:05. We're going to actually extend that just because we're running a little bit behind to 1:20 for the third plenary session on thoracic transplant and COVID-19. So take a quick break, and at 1:20 we will be back. And on behalf of Dr. Egwin and Dr. Adrege and myself, thank you for tuning in.
Thank you very much.
Thank you.
Good afternoon and welcome to the third plenary session. I'm Dr. Carl Dahlberg. I'm a pulmonologist and medical intensivist at the Houston Methodist Hospital in Houston, Texas.
I'm a physician assistant with the thoracic transplant team at Houston Methodist Hospital.
And I'm Ed Chan. I'm one of the thoracic surgeons, one of the lung transplant surgeons at Houston Methodist as well. We're starting off the third session, as Dr. Dahlberg mentioned. We have the state-of-the-art lecture entitled The Impact of COVID-19 in Europe. We have the pleasure of being joined by Dr. Marina Berenguer, who is a consultant hepatologist at La Fe University Hospital and a professor of medicine at the University of Valencia, Faculty of Medicine in Valencia, Spain. Among numerous distinctions in her career, she is the president-elect for the International Liver Transplant Society. She's also a research coordinator within the National Network Research Center in Hepatology and coordinator of La Fe University Research Group, Hepatology, Hepatobiliopancreatic Surgery, and Transplantation. So welcome, Dr. Berenguer.
It's my pleasure to present today at this Emerging Concepts Transplantation in the Year of COVID-19 Pandemic session on the impact of COVID-19 in Europe. And I would like really to thank Mark Gabriel for his kind invitation. These are my disclosures. So COVID-19 has deeply impacted transplant activity. This is a figure showing the trends of solid organ transplantation in several European countries and in the US since March 2020, showing a significant decrease worldwide and a recent recovery in recent months. And here showing the data in Spain and Italy, where the impact was really significant in the first months of the pandemic. The impact on outcomes of the decline in organ transplantation and donation is still difficult to assess at this time. In this multi-center, multi-society, prospective cross-sectional web-based survey, we try to assess the impact of COVID on transplant processes, immunosuppression, live donation, and organ procurement. Overall, comparing overall transplant practices across the globe during the first 6 months of the pandemic with the corresponding period from 2019 revealed significant differences in the number of waitlisted candidates, which were reduced in 2020, waitlist mortality, which was increased, and the number of liver transplants, which were significantly reduced. And these findings, these differences, were more pronounced in heavily hit countries. In the next few minutes, I would like to address the pre-transplant management and COVID-19 in the post-transplant setting. So the first consequence of COVID in most centers relate to the organization of transplant activity during the outbreak, such that phase approaches need to be put in place whereby in living and disease donor liver transplantation would be carried out preferentially in unstable patients, that is, patients with the highest MELD scores or high risk of dropout from cancer progression, according with intensive care units and healthcare personnel capacities and facilities. In Europe, most of the activities based on deceased donation. So when there's a 25% reduction in transplant activity, in general, elective cases are carried out. In terms when there's a 50% transplant reduction activity, urgent transplantation is focused on urgent cases, particularly those with higher MELD scores greater than 25 or risk for dropout from HCC. And in case of 75% reduction in transplant activity, only emergency cases are done, particularly fulminant hepatic failure or those with acute and chronic liver failure with very high MELD scores. Very importantly, there's been a huge effort to avoid viral transmission from donor to either the recipient particularly, but also to healthcare workers. So if the recipient is either symptomatic or is PCR positive, and this is kind of the approach we use in Spain. So if the recipient is positive, then we would call a backup recipient, but we would not proceed with a recipient that has symptoms or has any epidemiological risk of being infected unless there's really a significant risk of death. And I will touch upon this in the next slide. In terms of the donor, there's a need also to perform an epidemiological and clinical screening together PCR testing. If the donor is positive, then we discard the organ. And I'm just going to focus on disease donation, which is much more common in Europe. But in terms of live donation, it is delayed for at least 28 days. If both epidemiological and clinical screening are negative and the PCR is negative, then we proceed with liver transplantation. If both are positive, then we discard the organs. And if one of the two are positive or negative, then we really discuss a case on a case-by-case basis. There may be exception cases which have been reported and we have all faced in our transplant units. This is one example that was just published in the literature from an Italian center where an urgent liver transplant was performed soon after recovery from COVID-19 in a patient with decompensated cirrhosis. So this was a patient who decompensated in the setting of COVID-19 infection. The patient had a negative, required ventilation, but really with an increase in MEL score, and only 3 days after the first negative PCR, with two negative PCRs with only 3 days days elapsed in between the first and the second negative PCR, the patient underwent liver transplantation with an eventful outcome. So this is particularly an option that we really may approach in patients with very high acuity of liver disease. So what about the COVID-19 post-transplantation? Was the data mostly observing in Europe? So in terms from a theoretical point of view and based on the pathophysiology of COVID infection, immunosuppression and the transplant setting may be viewed as a double-edged sword. In the setting of transplantation under immunosuppression, there may be an inhibition of antiviral immunity, and in doing so, there may be a delay in viral clearance, perpetuation of illness, and hyperinflammation. But at the same time, immunosuppression may reduce hyperinflammation, which we all know is associated with worse outcome and the hyperinflammatory response in patients who eventually die. So what's really the reality? Well, there's been this early systematic review and meta-analysis where many studies were from European centers, 12 observational studies with overall 517 hospitalized liver transplant patients who were analyzed. The mean age was 64 years. Most were male. Most had been transplanted for decompensated cirrhosis with a median time from transplantation to COVID of about 9 years. The majority had comorbidities such as type 2 diabetes, hypertension, cardiac disease, obesity, lung or malignancies. In terms of symptomatology, this was not different from the non-transplant population, but dyspnea and gastrointestinal symptoms were more frequently reported in the liver transplant population compared to the non-transplant population. In terms of outcome, radiological signs of pneumonia were found in 77% of the liver transplant population, and a need for mechanical ventilation and ICU admission in 24 and 22% of the liver transplant patients, respectively, with a 20% in-hospital mortality, which is not really different from what we've seen, and it's been reported in the non-transplant population. In addition, this mortality was higher in the elderly population, greater than 65 years of age, and there was no correlation to sex or time from transplantation. There's also another multi-center international registry study where many centers were also from Europe, and where there was a propensity score match analysis performed between liver transplant cohort of 151 patients and a non-transplant cohort of 627 patients. Overall, again, no differences in hospitalization, requirement for intensive care, and mortality. So really suggesting that liver transplant does not confer major additional susceptibility to adverse outcomes from COVID-19. In addition, the same data appears to be reported also for other solid organ recipients. This is a summary of many studies that have been published in the literature. These are the the liver data, but there's also the heart, kidney, and lung data. And the mortality in most of this series is around 20-25%, perhaps it's slightly higher in lung recipients, again pointing towards that immunosuppression, the transplant per se, is not associated with a worse outcome. So what are the risk factors for greater mortality? And in general, most studies report similar risk factors of poor outcome compared to the general population. In this review, which includes most large series, and I've just highlighted in red here those that come from European countries, and the overall mortality reported in this series ranged from 18 to 23%. These were hospitalized patients most of the time, no different from the non-transplant population, and risk factors associated with poor outcome were similar to those reported in the non-transplant population, particularly advanced age, reduced renal function, diabetes, or other metabolic comorbidities, and a background of cancer. And I'd like just to highlight some of these studies. This is the first Italian study where they compared long-term liver transplant recipients to short-term liver transplant recipients more highly immunosuppressed. Interestingly, most of the mortality was observed in the long liver transplant recipients who were significantly less immunosuppressed, but had significantly higher number of known risk factors associated with poor COVID outcomes, such as advanced age, obesity, diabetes, hyperlipidemia, arterial hypertension, or a history of cardiovascular event or chronic kidney disease. Similar findings were reported from the ELITA ERTR registry, where mortality was observed only in those who were aged 60 years or older. And although not statistically significant, again, most mortality was observed in patients who had been transplanted at least 2 years previously. This is another interesting study, is a more recent study, which is again an international European liver transplant recipient, but this time it's a prospective cohort where 19 European centers participated. There were 19 probably unconfirmed COVID-19 in liver transplant recipients, after excluding some where there was not enough data to substantiate the infection. There were 57 COVID-19 in liver transplant recipients. 28% were managed as outpatient, and there was no mortality, and 72% were managed as inpatient, and there was 12% mortality, which is about 17% mortality of those who are hospitalized, not different from the non-transplant population. A history of cancer was more frequent in patients with poorer outcome, and very interestingly, patients infected early after liver transplantation did not have a worse outcome and tended to have less symptomatology. So the key point here is really understanding what's the impact of the type of immunosuppression, and also the appropriateness to modify immunosuppression. The problem that this is very difficult to assess from studies because there are large variations in SARS-CoV-2 and immunosuppressive management and in clinical characteristics, particularly in terms of time from transplantation and thus in baseline immunosuppressive intensity. In addition, there's really very limited data in terms of medication and changes in these medications and what have been the circumstances that have led to the changes in immunosuppressive medication. So what do we have in terms of immunosuppression in these patients who are infected with COVID? Well, this is again the systematic review that I mentioned before. So in terms of maintenance immunosuppression, 86% of the population is under CNI, mostly tacrolimus, 50% under MMF, and 9% under mTOR inhibitors. And changes in these drugs were particularly done for MMF and mTOR inhibitors, 60% and 50%, either decreased of the doses or discontinuation of these drugs once they were infected with COVID-19. In addition, pulse steroids were used in 22%, presumably with intent to modulate the cytokine syndrome, and 6%, also in 6% of these liver transplant patients, tocilizumab was also used in order to modify this cytokine storm. So there have been 2 studies only that have found an association between the type of immunosuppression and outcome. In this first Spanish multicenter study, which included 111 liver transplant patients, 105 months from transplantation, the standardized mortality ratio was not different from that observed in the general population, but the authors reported that the use of mycophenolate, and particularly mycophenolate at high doses, was associated with a worse outcome. In this large European multi-center study, which included 243 COVID-19 cases in liver transplant recipients, and where 80% of the patients were hospitalized, and the mortality overall was 20%. Advanced age and chronic kidney disease were associated with worse outcome, as mentioned in all the studies that I just have shown. But interestingly, the use of tacrolimus was protective, suggesting that patients should be kept with tacrolimus at the usual doses. So based on all this data, I think this is a good summary of the time course of SARS-CoV-2 infection and the development of COVID in liver transplant recipients. So after infection with SARS-CoV-2, individuals may transmit the virus 1 to 2 days prior to and about 8 days after the onset of clinical symptoms, which is shown here in dark orange. SARS or RNA by PCR is detectable for longer periods of time, and the infection is followed by the inductions of SARS-CoV-2 specific antibodies and T cells. In addition, a hyperactive immune response contributes to the immunopathology associated with COVID. So if we look at these steepled curves, we can see that PCR positivity, and this is in the which represents the liver transplant population. So PCR positivity is prolonged in liver transplant. It's really longer in liver transplant recipients, which has potential implications for prolonged infectivity in the liver transplant population. In addition, the immune response with SARS-CoV-2 antibodies in T cells seems to be impaired in the setting of immunosuppression. So what are the implications in terms of therapeutic management? On the one side, antiviral drugs or convalescent plasma, together with reduction in immunosuppression in the early period of infection, may ensure control of viral replication, whereas immunomodulatory or anti-inflammatory treatment regimens associated with restoring or intensifying immunosuppression in the later stages of infection may counteract immunopathology. In essence, early after transplantation, strong immunosuppression may adversely affect sufficient induction of specific immunity, which may account for insufficient control of viral load and frequently observed prolonged detection of viral RNA after disease onset. And in contrast, in later periods of the disease, immunosuppressive drugs may be beneficial in suppressing pro-inflammatory processes and cytokines. So the modulation of immunosuppression may be either harmful or beneficial depending on the clinical stage of the infection in solid organ transplant recipients. So I would like to finish with the response to SARS-CoV-2 infection in terms of humoral immune response. This is a recent study performed, a multi-center study performed in Spain, where there was liver transplant patients and controls were matched for the typical factors that are associated with worse outcome in COVID infection. We had finally 62 liver transplant patients and 62 controls, and antibodies against IgG antibodies against SARS-CoV-2 were detected both at 3 and at 6 months post-transplantation. And overall, these antibodies were significantly less detected in the liver transplant population, both at 3 and at 6 months, 77% at 3 months compared to 100% in the immunocompetent population, and 63% compared to 90% in the immunocompetent population at 9 months. In addition, the median levels of IgG antibodies were also lower in the transplant population, 4.28 versus 5.41 in the immunocompetent population, and at 6 months, 1.95 compared to 4.33 in the immunocompetent population. In fact, if you look at the kinetics of this response, we can see here in dark, in black, you can see that the response was lower in the liver transplant population than in the controls, but in addition, the decline was substantially greater in the liver transplant population in this 3 months, from month 3 to month 6, than in the immunocompetent population. If we look at the factors that were associated with this immune response in the liver transplant population, female gender with an odds ratio of 13.4, longer intervals since liver transplantation with an odds ratio of 1.1, and the use of renin-angiotensin-aldosterone inhibitors were associated with a greater immune response in the liver transplant population. What may this indicate in terms of the response, the immunity against COVID reinfection, and the impact of vaccination in these liver transplant recipients? We still need more information, including the information on T-cell response. So I think based on all this data, these would be my takeaway messages. Liver transplant recipients, they are a vulnerable population. They are presumably at high risk of infection, and this was found in the Spanish multicenter study, where the standardized incidence risk of infection was higher than that seen in the general population. In terms of mortality, though, the standardized mortality rates appear to be similar to those seen in the general population, with about a 12% mortality in general in the overall transplant population, and a symptomatic population of about 20% of those who are hospitalized. In terms of presentation, it appears to be similar to that seen in the general population, but dyspnea and gastrointestinal symptoms appear to be more common in the transplant population. In terms of risk factors for death and worse outcome in the liver transplant population, they appear to be similar to those reported in the non-transplant population, particularly advanced age and the presence of comorbidities, and in particular the presence of impaired kidney function and diabetes appear to be strongly associated with a worse outcome, as well as a background of cancer. In terms of immunosuppression, based on the data that I just presented, it doesn't seem that the liver transplant patients per se are at a higher risk of death compared to the non-immunosuppressed population, and thus most societies recommend maintaining the same immunosuppressive therapy, particularly in long-term transplant recipients. Reduction, and particularly with tacrolimus, based on the recent multicenter European study, reduction of some of the drugs, particularly mycophenolate, might be considered under special circumstances, particularly lymphopenia or a severe progression of the disease. And finally, as compared with immunocompetent patients, liver transplant recipients show a lower prevalence of anti-SARS-CoV-2 antibodies and a more pronounced antibody levels decline. And the impact of these findings in terms of response to vaccination just needs further investigation. And with this, I would like to thank you for this invitation, and I'd like to take any questions that you may have. Thank you very much for your attention.
I'm here to introduce Dr. Safdar. She's the interim director of the Houston Methodist Center for Advanced Lung Disease, director of Pulmonary Hypertension Care Center, and director of Pulmonary Fibrosis Center and Clinical Research. She's a PI of several ongoing clinical trials in pulmonary hypertension and interstitial lung disease. She's extensively published, and also she's a nationally and internationally recognized leader in pulmonary hypertension and IPF. Dr. Safdar.
Good afternoon, everybody. Today, the task that's given to me is to talk about management of patients with advanced lung diseases, those who develop COVID-19 or are unfortunate enough to catch the COVID-19 virus and end up in the hospital. A lot of what we've already discussed is about what the virus is, what the epidemiology is, the ICU management of patients with COVID-19, and the different treatment options, and ECMO, and also further talks about transplants. So I'm going to concentrate on advanced lung diseases and COVID-19. So patients who have advanced lung diseases are many. It could be any reason that leads to the end-stage lung disease, advanced lung disease. It could be interstitial lung disease. It could be idiopathic pulmonary fibrosis, emphysema, COPD, end-stage sarcoidosis, bronchiectasis. There are a list of things that can lead to advanced lung diseases, and this is just a few of them. It can be a lot more. It could be also mixed fibrotic and emphysema changes. There could be restrictive changes. There could be congenital changes. Patients are born with different anomalies. There could be radiation-induced pulmonary fibrosis and a lot of other causes. But the end point is that they have advanced lung disease and they have a high risk of deterioration to begin with. And in addition, if they get COVID-19, they will have, they may have a poor outcome, and aggressive management and identification and treatment is paramount for these patients. We know that in general, about 50 to 30% of patients who develop COVID will go on to develop COVID-associated ARDS. And this number could be even higher for patients with advanced lung diseases. Although with treatment and proper management, it could be lower. But we are still waiting for the data to come out. In some patients, especially in older patients, they have a risk factor for developing COVID-19. And we know that patients who have advanced age, they may have some interstitial abnormalities, and this is based on the data from screening X-rays and screening CT scans. Prevention is the best policy, so social distancing, wearing a mask, getting vaccinated as soon as possible, testing frequently if there's an exposure, and to self-quarantine, seeking medical help and monitoring oxygen saturation, and then going to the ER, calling your doctor, going to a hospital which is well-versed in handling COVID patients, such as Houston Methodist, and following the COVID protocol. So there are many risk factors associated with severe illness in COVID-19. These have been shown in different studies, different meta-analyses, and retrospective review that advancing age, various comorbidities such as severe illnesses associated with illness and mortality or cardiovascular disease, your advanced lung disease, COPD, different malignancies. Smoking is a risk factor, and of course, male gender and social economic background. And this is just this forest plot showing that patients, this meta-analysis showing that patients who have advancing age more than 75, and this is a forest plot with line 1, all the lines, all the numbers, all the points are to the right, showing that it is high risk. If they were on the left, that would be low risk. So you can see that all these studies have shown across the board that advancing age is a bad risk factor associated with a bad outcome. And male gender also have a high risk of severe illness in addition to severe obesity. Now we know what is the risk factor for IPF, idiopathic pulmonary fibrosis, which is the leading cause of advanced lung diseases in patients. Is the risk factors are male, older age, and smoking. And you can see that 3 out of 3 are associated with worse outcomes. So patients with advanced lung diseases such as IPF, who develop COVID, would have an even worse outcome, could have even worse outcome. So other risk factors, hypertension, diabetes, chronic kidney disease. In my mind, when I look at these, it tells me that these patients who are older will have these comorbid conditions, and therefore they are at high risk. So this is a case-controlled study of patients with COVID, and they took patients who had ILD and those patients who did not have ILD, and they matched them with race, gender, and age. And you can see that in patients who were ILD and COVID, they are more likely to be on steroids, more likely to be immunosuppressive medicines. They are more likely to be admitted to the hospital, require an ICU level of care, and they are less likely to be discharged and more likely to be discharged if they don't have any ILD. And interestingly, and expectedly, they had high risk of deaths, as we previously said and suspected. And even when they were adjusted, these patients for age, sex, race, smoking status, and cardiovascular, and even immunosuppressive medicines, even then they had a high risk of death. So suggesting that the underlying disease predisposes these patients to even worse outcome. We know there are certain abnormalities associated with worse outcome which have been pointed out, but one study suggested that higher D-dimer may be associated with the developing post-COVID fibrotic changes. But then when they did a multivariate analysis, that did not pan out. In this study of a patient with fibrotic lung disease, changes and who were survivors of COVID, and they had some fibrotic lung diseases. They looked at different parameters, and you can see that there are longer hospitalization, longer stay in the hospital, associated with a longer ARDS. If they have ARDS, if they have non-invasive ventilation, and if they have worsening score on the CT, they were associated with developing more fibrotic changes, more advanced lung changes as a sequelae of COVID infection. I wanted to present a case. This is a patient with scleroderma, multiconnective tissue disease, and pulmonary hypertension and ILD, and she was diagnosed. She's a 54-year-old female diagnosed in 2016. She was on immunosuppressive medications, as you can see over here, and some prophylactic medication. We were consulted for worsening shortness of breath, and some of her medications were optimized and switched to improve her RV function, and she was discharged. So a few months later, she got readmitted for worsening symptoms, again, right heart failure, and she then started on intravenous epoprostenol, and which then provided support to the RV, and she felt better. She had PFTs done, which were really bad. They were like FEV1 of 48%, FVC 45, and diffusion capacity was really low. She walked, her walk distance was poor. She walked 335 meters and required 6 liters of oxygen to maintain her SATs above 90%. At this point, she was referred for lung transplant evaluation. And then 1 month later after that, she came back to the ER with worsening shortness of breath for 2 days. And she said that increased her oxygen from 6 liters to 10 liters. Even then, her SATs were barely 60%. She was, of course, admitted to the hospital. Her echo showed that the LV was underfilled. The RV was severely enlarged. The RV function was severely depressed. PA systolic pressure was more than 100, and right atrial pressure was more than 25. She was clearly in right heart failure. In addition to severe hypoxemia, she was tested positive for COVID. At this point in time, unfortunately, she had a college-going daughter. It could have got from her, unclear where she got it from, though she said that she stayed in the house all the time. She was profoundly hypoxic, required 100% oxygen. And this is a chest x-ray showing that she had worsening infiltrate on high flow oxygen. At that time, this was in April of last year, COVID protocol was initiated and medications were given. She was started on IV heparin. She was given antibiotics. As you can see her, this is day 2 chest x-ray, and then this is day 4, worsening infiltrates, present cardiomegaly. And you can see this ring over here. She was started on helmet ventilation. She was also started on inhaled nitric oxide in addition to high flow oxygen. That gave her some improvement in her oxygen saturation. She developed profoundly refractory hypoxemia, and we tried to increase the intravenous ipoprostenol to a maximum tolerated doses of 13.7 nanogram per kg per minute. And this further titration was limited by her low blood pressure, and she was also on some pressors. So profound hypoxemia in her case was because of right to left shunting through a PFO, and helmet ventilation and inhaled NO was added, in addition to optimizing her ipoprostenol infusion as much as we could possibly do. Unfortunately, she was not considered transplant candidate because her BMI was very low, 17, and she was given a target of 18 BMI by the transplant team, and she was unable to meet that at the time of admission, plus she had the COVID infection. So her family made her DNI, and despite all the oxygen that we could provide her, she passed away. So unfortunate event, but that goes on to say that how little time we have for these patients, and then these patients need to be aggressively managed in terms of immunosuppressive medicine. Unfortunately, we were involved in her case a little later than what should have been, and she was referred to us at the very end and referred for transplant at that point in time. So to me, the CT finding, any infiltrate, any ground glass, any opacities is COVID unless proven otherwise at this point in time. Management of these patients require oxygen for most part. We can give them oxygen through nasal cannula, through high flow oxygen, however we can give them as much oxygen as needed to maintain their SATs above 90%. That is a reasonable target for them. Of course, giving too much oxygen is also not recommended. Hyperoxia is not recommended because of reactive oxygen species that could be created by giving too much oxygen and causing lung damage further. So invasive ventilation non-invasive ventilation is the goal first, and treating the underlying problem, which is your COVID pneumonia, giving them support as much as possible. But in case they do need invasive ventilation, there are further goals. A high tidal volume has to be avoided to prevent ventilator-induced lung injury. As I mentioned, high flow oxygen is the recommended treatment for hypoxia for these patients. It does not increase risk for disease transmission. Patients, the staff taking care of these patients should follow strict PPEs. Invasive ventilation should require low tidal volume ventilation and positive pressure to optimize oxygenation and recruitment and prevent the alveolar units from opening and closing and causing further damage. Prone position have already been shown to help these patients, and neuromuscular blockade is something that all these things are going to be discussed in terms of the ICU management of COVID patients. There are different schema to follow for severe COVID pneumonia patient. This is one of them. If there is increased work of breathing and hypoxemia, then of course these patients need to be on oxygen. If they have some altered mental status and hypotension, then invasive ventilation is recommended, versus if they are not, then you can try them on non-invasive ventilation with a close monitoring. But at any point in time, if the work of breathing increases too much, or if the patients have altered mental status, it is better to intubate them early and ventilate them early rather than to leave them on a non-invasive ventilation till they crash. That is not recommended. For patients with end-stage, a referral to lung transplantation should be done early enough, as soon as possible, hopefully before they catch COVID. But if they do catch COVID, then again, transplant team should be again involved and should be consulted. ECMO, there's a whole talk about ECMO in this conference, very nice talk, so I'll refer to that talk on ECMO, but it could be a bridge to recovery or a bridge to lung transplantation in these patients. Prolonged intubation, if they have been intubated for a long period of time, tracheostomy can be considered. There's no much data out there. There's data coming out for antifibrotic therapy in patients who have post-COVID fibrotic changes, and in patients who have advanced lung disease, they may already be on a fibrotic medication. So in the post-COVID complications are many. Fatigue, dyspnea. Fatigue is very common. Up to 85 to 90% of patients complain of fatigue for 3 months or longer. Cough may be lingering and present for a long period of time. Other symptoms can be present. PTSD-like symptoms or impaired memory or concentration is also common. So quality of life after COVID may be compromised or may be decreased. So in summary, patients with advanced lung disease who develop COVID are at high risk of deterioration. Hypoxia is the main concern for these patients, and to give them enough oxygen to till their own body recovers. There's a hyperimmune response, inflammatory response that has already been discussed in these patients and which may be exacerbated in patients with advanced lung disease. Now, the role of antifibrotic medication in these patients is not yet defined. But there are studies going on. There's anecdotal data about using it in post-COVID ILD patients. Now, what happens to these post-COVID patients? Well, do they improve? Do they stay the same, or do they worsen? There are a minority of patients who actually worsen post-COVID, and but majority of them, their lung function will improve. Their their CT scan and chest X-ray showing opacities will get better. So it's important to follow these patients in a post-COVID clinic in some kind of a organized manner to catch these patients who are going to do worse, and who will develop long-term ILD or fibrotic changes, so that they can be closely followed and monitored and treated as appropriate. And if there's no improvement or if there's progressive changes, then of course refer to lung transplantation. And I think the next session is going to talk about the indication for lung transplant and management of COVID patients. So when there is extensive parenchymal opacification, these patients may have undiagnosed interstitial lung abnormalities, especially in patients who have advancing age and develop COVID. So we don't know, we may not have the baseline chest X-ray or CT scan, so we don't know what the underlying lung pathology is. COVID may actually promote fibrotic changes in post-COVID, as I mentioned. Of course, in post-COVID ARDS, they may have some ventilator-induced injury. They may have some inflammatory triggers that can lead to fibrotic changes in these patients, in a minority of patients. So these patients should be followed in a systemized, in an organized fashion in a clinic to figure out what the residual abnormalities are and what the long-term sequelae of those are going to be, and the implications and the effect on the long-term mortality and long-term lung function. So with this, I'm going to stop my talk here, and I thank you for your attention. And after all the talks are over, I'll be happy to take any questions. And for any feedback, this is my email outlined over here. Thank you very much.
Thank you, Dr. Safdar, for a very interesting and informative lecture. Our next lecture is when to refer the COVID-19 patient with pulmonary disease for lung transplantation. And our next speaker is Dr. Simon Yao. Dr. Yao is a transplant pulmonologist for Houston Methodist J.C. Walter Transplant Center and Sleep Medicine, Critical Care Medicine, and pulmonologist for the Houston Methodist Academic Medicine Associates. He is also an instructor in medicine for the Houston Methodist Academic Institute and the Weill Cornell Medical College. Dr. Yao attended medical school at the University of Texas Health Science Center in San Antonio and completed his medical residency and fellowship training in pulmonary and critical care medicine at Baylor College of Medicine. His interests include lung transplantation, advanced bronchoscopy, general pulmonology, critical care medicine, bedside ultrasonography, and ECMO. Please welcome Dr. Yao.
Hello, my name is Simon Yao. I'm one of the lung transplant pulmonologists at Houston Methodist. I wanted to thank everyone for tuning in on a Saturday afternoon and for the opportunity to speak on this topic. I'm going to be talking about when to refer the COVID-19 patient with pulmonary disease for lung transplantation. I have no financial disclosures. I think for the purposes of this topic, it's helpful to think in terms of two patient population types, although there is some overlap between the two groups. The first group includes patients with severe acute respiratory distress syndrome from COVID-19 pneumonia. They have refractory hypoxemic respiratory failure requiring mechanical ventilation, tracheostomy, and in severe cases, ECMO support. They're often in the ICU for weeks to months with no improvement prior to lung transplantation being deemed their only route to improvement. The majority of cases reported in literature are these types of patients who are critically ill prior to lung transplantation. The other group of patients to consider are patients who have had COVID-19 pneumonia, who have improved, left the hospital, have gone home, but have persistent shortness of breath and progressive fibrotic lung disease with physiological impairment and hypoxia. We're seeing more and more of these patients in the outpatient setting as the pandemic progresses. Although the majority of patients with COVID-19 have mild disease, 5 to 10% can progress to severe disease and ARDS requiring mechanical ventilation. Mortality is very high in these patients, up to 40%. ARDS is characterized by diffuse bilateral infiltrates and severe hypoxemic respiratory failure, not from a cardiac source. There are three pathological phases in ARDS. The first is the exudative stage, also known for diffuse alveolar damage, acute inflammation, interstitial edema, and hyaline membrane formation. Usually occurs in the first 7 to 10 days. After this is the fibroproliferative stage. It's characterized by proliferation of type 2 alveolar cells and collagen deposition. Usually occurs at weeks 2 to 3. After this is the fibrotic stage, where there's obliteration of normal lung architecture, fibrosis, and cyst formation. The etiology of fibrosis in COVID-19 is multifactorial, thought to be from viral damage, chronic inflammation, cytokine release syndrome, high airway pressures, and hyperoxia, all playing a role. The overall etiology of fibrosis is still uncertain, however. So with the increasing number of cases of COVID-19 ARDS and their possible need for lung transplantation, Hirano wanted to look at the outcomes of lung transplantation for all causes of ARDS. This was a retrospective review of UNOS database looking at patients transplanted between May 2005 and December 2018. Only 39 patients were transplanted for refractory ARDS during this time period. This is only 0.15% of all transplants. Gives us an idea of the infrequency of transplant for ARDS, given how sick these patients often are. The median age was 30, and 77% used ECMO as a bridge to transplant. They compared this patient population with 78 matched controlled patients who were transplanted for restrictive lung disease during this time period. There was one transplant for H1N1 ARDS during this time period. They found that when selected appropriately, the 90-day, 1-year, and 3-year survivals were no different between the two groups. So, regarding COVID-19 ARDS, the International Society for Heart and Lung Transplantation COVID-19 Task Force released this recommendation in April of 2021. They recommended lung transplantation to be considered in carefully selected patients when severe lung injury is present for more than 28 days and signs of irreversible damage are noted. There should also be 2 negative COVID-19 PCRs 24 to 48 hours apart, with one ideally being a lower respiratory tract specimen. They should also meet all other criteria deemed necessary by the local center. So this international multi-center case series by Northwestern, published in The Lancet on March 31st, 2021, helps us to better characterize COVID-19 ARDS patients receiving lung transplantation. They looked at 12 patients from 6 high-volume transplant centers from the United States, Italy, Austria, India, from May to September of 2020. All patients had severe interstitial fibrosis, honeycombing, bronchiectasis, and the explanted lungs from these patients showed severe pleural adhesions and high-low lymphadenopathy. There were concerns about outcomes after the transplant, given deconditioning, neuromuscular blockade, and sedation prior to transplant. 145 non-COVID transplants occurred during this time period at these 6 centers, so COVID-19 ARDS cases accounted for only about 7% of transplants in these centers. The median follow-up time period was 80 days. I wanted to highlight a few characteristics about these patients. The median age was 48, so overall a younger population. The median BMI was only 26. 4 out of the 12 had no known comorbidities, and the other 8 had medically controlled diseases like hypertension, diabetes, arthritis. 9 out of the 12 required mechanical ventilation, and 10 out of the 12 required tracheostomy. In terms of extracorporeal life support, 11 of the 12 required veno-venous ECMO as a bridge to transplant, and 10 were awake ECMOs. Sepsis and bacterial superinfections were common. 10 out of the 12 had nosocomial pneumonias with multi-drug-resistant Pseudomonas, Serratia, Klebsiella, and Achromobacter, and 11 of the 12 did recover from sepsis before transplant. In terms of the timing of listing, patients had been on ECMO a median of 49 days prior to listing, with a range of 38 to 80 days. In terms of timing of COVID-19 diagnosis to listing for transplant, there is a median of 69 days from the time of diagnosis of COVID-19 to listing, with a range of 51 to 82 days. Once a patient was listed, they were transplanted at a median of 6 days. There was a high number of blood products transfused intraoperatively, and because of dense adhesions, all patients were performed on central VA ECMO support. 11 of the 12 patients were alive at a median of follow-up of 80 days. 1 patient had died of critical illness and sepsis. The overall 30-day survival was 100%, so similar to non-COVID transplant survival. The authors of this article go on to propose criteria that are helpful to think about when selecting patients with severe COVID-19 for lung transplantation. In general, they should be younger patients, less than the age of 65. They should have single organ failure, although this should be evaluated on a case-to-case basis, as there's recent reports of dual organ transplantation, including heart, lung, as well as lung, kidney for COVID-19. There should be no malignancy or disabling comorbidities. They should be non-smokers with a BMI of less than 32. They should have adequate social and financial support and be able to relocate nearby to the transplant center. Patients should be awake, interactive, able to participate in the lung transplant decision-making process. However, hypoxemia, hemodynamic instability in these patients can at times limit awakening, so in a small minority, transplant can be considered with the consent of the next of kin. Similarly, they should be able to participate in physical therapy. However, their progress of therapy can be limited at times by hypoxemia, hemodynamic instability, cough. The hypothesis here is that frailty in this younger population is reversible, given that the majority were in a normal state of health with relatively few comorbidities prior to their illness. This needs to be evaluated carefully on a case-to-case basis. 2 negative PCRs from the lower respiratory tract are recommended if the patient has a tracheostomy, otherwise nasopharyngeal testing is recommended. In cases of persistently positive viral shedding or positive PCRs, a viral culture is recommended. There should be evidence of irreversible lung damage, and as recommended before, waiting at least 4 weeks prior to consideration of lung transplantation. The emphasis here is on a multidisciplinary approach, with decision being made by the surgeon, lung transplant pulmonologist, as well as the intensivist involved. Now we will switch gears and talk briefly about patients who have recovered from COVID-19 and were discharged home, but have had progressive increasing shortness of breath, hypoxemia, and fibrosis. In transplant, we talk about this window for transplant. In the more critically ill ARDS patients, that window is smaller and narrower, but patients that recover, that window can extend and move depending on their clinical trajectory. There are multiple proposed mechanisms of how COVID-19 causes fibrosis. However, the etiology is still unclear, as we discussed earlier. What we don't know is which patients will recover and to what extent they will recover, which ones will get stable scarring, and which ones will get progressively deteriorating fibrosis. There is some evidence that patients intubated on high-flow oxygen or requiring non-invasive ventilation will have a higher chance of developing fibrosis. We do have some data from the original severe acute respiratory syndrome coronavirus and the Middle East respiratory syndrome coronavirus regarding pulmonary fibrosis. Zhang et al. Found that for a 15-year follow-up of 71 patients with SARS, 4.6% had persistent interstitial abnormalities, although their lung function stabilized after the first 2 years. Similarly, in MERS, 33% had reticular nodular opacities on their CT scans at 43 days. A meta-analysis of both SARS and MERS patients showed that most have a restrictive impairment, but most do improve over time, but the reduction in DLCO is present in 11 to 45% at 12 months. So this was an observational study that was published in Annals of Internal Medicine looking at 60-day follow-up for COVID-19 pneumonia. Patients were contacted with a telephone survey. 488 patients were contacted. Of those 488, 32% reported persistent cough or dyspnea. Another 18% had new or worsening symptoms. Oxygen use persisted at 6.6%, and there was new use of CPAP or other non-invasive mechanical support in 7%. Respiratory symptoms post-COVID-19 pneumonia are very common. Up to 40% in these studies report persistent dyspnea and cough at 60 days post-COVID-19. I think we're going to be seeing more and more of these patients, if not already seeing them in our clinics. And when to refer them to lung transplantation is going to become more of an important question. We talked about the window for lung transplant earlier and how it can change depending on the clinical course of a patient. The most recent International Society for Heart and Lung Transplant consensus recommendations published in 2015 still give us some guidance. The emphasis is on early referral for progressive lung disease in the absence of any absolute contraindication. The recommendations for restrictive lung disease or interstitial lung disease timing of referral are usual interstitial pneumonitis or fibrosing non-specific interstitial pneumonitis pattern regardless of lung function. At the timing of diagnosis should be referred for lung transplant. Forced vital capacity less than 80% or diffusion capacity less than 40%. Any dyspnea or functional limitation from lung disease, any oxygen requirement, and any failure to improve despite medical optimization. These are the guidelines for referral for lung transplantation. For listing is a more in-depth evaluation and often looks at the trajectory of their lung function and weighs the careful risk-benefit analysis before listing a patient. In terms of any absolute contraindications for lung transplantation, any severe and treatable malignancy, end organ dysfunction, active infections, bleeding diathesis, or significant coronary artery disease not amenable to revascularization are contraindications. A BMI above 35, non-adherence, as well as substance abuse and poor social financial support are all absolute contraindications. I wanted to go over a case of COVID-19 ARDS we encountered last year. This was a 39-year-old male with history of obesity. His BMI was 31. Initially presented to an outside hospital with fevers, chills, shortness of breath, and cough. He was diagnosed with COVID-19 and treated with remdesivir, convalescent plasma, and methylprednisolone. Despite this, his respiratory failure progressed and required high-flow nasal cannula alternating with BiPAP. He was transferred to us for transplant evaluation hospital day 55. On hospital day 61, we did accept him for double lung transplant. However, given his clinical improvement over the course of his next few weeks, we held off on listing him. He was able to wean down his oxygen requirement and ultimately was sent over to an LTAC for continued rehabilitation. On hospital day 83, he was actually discharged home on 2 to 3 liters of oxygen with a plan to follow up in clinic. His initial chest x-ray shown on the left that showed diffuse interstitial infiltrates. And on the right is his chest x-ray on discharge that showed significant improvement in his alveolar parenchyma. His CT scan on the left is from admission showing diffuse ground glass opacities. There was also diffuse reticular infiltration and traction bronchiectasis as seen on the left. His CT scan 6 months later is seen on the right, and it shows significant improvement in his lung parenchyma, although there is still some dilation of the airway. He continued to improve clinically, however he does have some persistent cough. He was seen 3 months after his initial illness in our transplant clinic. His FEV1 was 45% at the time, and his forced vital capacity was 39%. 3 months after that, 6 months from his initial illness, his FEV1 had improved to 73%, and his vital capacity had improved to 64%. His walk distance also has improved dramatically, and his oxygen requirement has been weaned off. He continues to be on room air and is doing well. We plan to continue following him in 6 months. So in summary, in terms of timing referral for lung transplantation for the COVID-19 patient with pulmonary involvement, in general, earlier is better. For COVID-19 ARDS patients, we want to allow for sufficient time for lung recovery, usually more than 4 weeks, unless hemodynamic instability or complications with ECMO or other complications arise. These patients do better with aggressive physical therapy prior to listing, and the emphasis is on a multidisciplinary approach in determining which patients are candidates for transplant. For the COVID-19 progressive fibrotic lung disease patient, the main thing we want to emphasize is earlier referral and then following the clinical trajectory of the patient to determine timing of listing. With that, I want to thank everyone for listening and take any questions or comments at this time. Thank you very much.
Thank you very much, Dr. Yao. It was very interesting, very informative. Next up, we have Howard Wong. He's going to be talking about lung transplantation and COVID-19, public health, and scientific challenges. Dr. Wong completed his training and his residency at UT Southwestern and subsequently did his pulmonary and critical care fellowship at Washington University in St. Louis. After that, he became an assistant professor of medicine at WashU, where he conducted extensive clinical, translational, and bench research and had NIH funding at that time. He joined Baylor University Medical Center in Dallas in 2014 as Assistant Director of Lung Transplantation and Director of Lung Transplant Research. We were fortunate to recruit Dr. Wong to our faculty at Houston Methodist Hospital in 2018. He's currently the Section Chief and Medical Director of Lung Transplantation for the Houston Methodist J.C. Walter Jr. Transplant Center and the Interim Division Chief of Pulmonary, Critical Care, and Sleep Medicine. Thank you, Dr. Wong, for joining us.
Good afternoon. Thank you for the opportunity to present. I've been asked to talk about lung transplantation and the public health and scientific challenges revolving around COVID-19. So, as we all know, COVID-19 has created a major disruption in our society and in everything we do, and this includes the transplant system in the United States and around the world. This plot from SRTR shows the number of lung offers before the pandemic, which is depicted to the left of the vertical line, and after the pandemic to the right. And you can see there was a sharp dip when COVID, the pandemic panned out in early 2020. There was a pretty quick rebound in the number of offers that were made, but it has not reached pre-pandemic levels at this time. And similarly, for the number of lung transplants that were performed, there was a sharp dip at the time of the declaration of the pandemic. And the volume has rebounded, but is slightly below where we were prior to COVID. So here we are faced with an ongoing issue, which is that these patients with advanced heart and lung disease and end-stage organ failures still need their transplants, and we have to adapt to this kind of new environment. So, you know, the title of the talk talks about public health and lung transplant, but I think it's more the impact of kind of the public health environment that we're in on lung transplant, because I don't think there's been enough lung transplants to make a big impact on a public health level. The first topic I'd like to touch on is the issue of infectivity, and this has real implications for both organ donors and organ recipients. This is a report that came out in the New York Times several months ago about a case in Michigan where, unfortunately, COVID-19 was transmitted to a lung recipient during the surgery. Several members of the surgical team became infected in the process. This was a donor that tested negative by real-time PCR in the upper respiratory tract, so the nasopharyngeal swab. But later, the lower respiratory tract samples became positive, and this was clearly a case of donor-transmitted COVID infection that actually resulted in the death of the patient. Subsequently, the UNOS committees have reviewed several more cases where this occurred, and at this point, they are recommending more extensive testing of donors, including upper and lower respiratory tract samples. Now, what about recipients who have COVID-19 and have become severely ill and need a lung transplant? And so the concern is taking these patients to the OR with active virus and how that's going to impact their course when they are heavily immunosuppressed early after transplant, and is this going to blow up into a severe COVID infection? So the recommendation from this recent review paper is at least 2 negative lower respiratory tract samples obtained at least 24 hours apart. So this has been our practice. We want to make absolutely sure that the recipient is testing negative before going to the operating room. So what happens with COVID in terms of testing? When are we sure that the patient really isn't infectious? And that's been difficult because the availability of cellular assays to really test infectious viral particles is very limited. So we depend a lot on PCR data. And so this was a report from Korea where they looked at a cohort of patients and measured both PCR and viral cultures to determine how long it takes for the infection to clear. Now, this is a population of normal people. You have to keep that in mind. So on the x-axis is time, days since onset of symptoms, and on the y-axis is the cycle threshold for PCR. So in general, lower the cycle threshold, the more likely this is really an infection. And you can see that that's correlated with these red dots, which are the positive cultures. At about 12 days, all the red dots become blue dots, meaning they did not test the culture negative. And then in general, there's a downward trend on the y-axis, showing that as the cycle threshold increases, you're less likely to have truly infectious virus particles. Now, this is for a normal population, but I think there's been other data that suggests that these rules don't really apply to immunosuppressed populations. And this is relevant in patients who had a lung transplant, and get a COVID infection. When are you sure somebody is infectious or still infectious? Or there's a lot of kind of operational issues in terms of bringing them to a pulmonary function test lab, having them around other patients, other members of their family. So this report from Memorial Sloan Kettering showed in 20 immunocompromised patients that there can actually be live virus that's detected for many, many days after the initial infection. So they were able to culture viable virus in one patient for up to 61 days. Most of these patients in this series were severely immunocompromised. 15 of the 20 were undergoing active chemotherapy. And by sequencing, you can see in the bottom right panel there, they were sure that these were persistent infections and not de novo infections because the pattern was not changing in the sequencing. This next report follows the course of a COVID infection that was persistent in a very heavily immunosuppressed patient for almost 6 months. So this is a man with antiphospholipid syndrome and diffuse alveolar hemorrhage, multiple immunosuppressants. And by sequencing, one can trace kind of the evolution of the virus within the patient. So it was actively acquiring mutations. That the patient was so heavily immunosuppressed that he was never able to completely clear the virus. And so this is obviously a disturbing observation. So these individuals clearly are able to harbor infectious virus for much longer than the typical population. And then this new piece of data is very interesting and potentially concerning. So we also see patients who have been infected who continue to test positive for PCR for many, many, many days, even months afterwards. So this report shows that there's evidence that some of the RNA after an infection can actually be incorporated into the host DNA. And as a result, some of this viral shedding that's detected is actually elements of the viral RNA that have been incorporated by these retrotransposons into the host DNA. So another great reason not to get a virus infection. So this is obviously very concerning and perplexing. The next topic I want to talk about is the long-term consequences of infection. So once these people become infected, what do we do with them? Or what are they potentially dealing with? And so this was a recent article that looked at a large population of veterans. And in this population, they looked at the burden of disease and the conditions that the patients had at 6 months after infection. And there was a very high burden of disease. This correlated with the severity of the illness and how much medical care somebody needs. For example, hospitalization or the ICU population. It is remarkable that at 6 months, you're still looking at a high number of patients with respiratory symptoms. They have multiple other comorbidities. There was a higher use of opioids. And they also found a signal that suggests there's a higher risk for mortality. So there's very real long-term consequences. This kind of long COVID concept, I think it's still not completely defined, and we don't fully understand the molecular origin of this. So there's definitely work that needs to be done to better characterize what long COVID is so that we can actually address it. This paper kind of begins that process, I think. This is from a Yale group. They looked at a development of autoantibodies in a cohort of patients infected with COVID-19. And so they did this multiplex screen for extracellular human antigens in patients who have had COVID. They found a lot of autoantibodies that were correlated with severity of disease, and something that autoantibody development and the persistence of this and the immune dysregulation is in part what long COVID is, and that remains to be seen. So is it time to panic yet? Probably not. These things are issues that are concerning and represent challenges that we need to overcome scientifically. So last topic I want to touch on is vaccine unresponsiveness. So I think some of my colleagues and the other speakers that are speaking at this event are going to delve into this and already have discussed this in some detail. So I'm just going to cover a few recent publications. So the Israelis have really led the way in vaccinating a large part of their populations. They're one of the highest vaccinated populations in the world right now. And they've reported on several different solid organ transplant cohorts. So this is in a cohort of kidney transplants, healthy controls on the left, kidney transplants on the right, after receiving the 2 doses of the Pfizer mRNA vaccine. And you can see that the anti-spike antibody response is significantly different between the two groups. It's an association with higher age, and these are things that we would expect in general for vaccination. But also there's definitely an association with higher immunosuppression. Similarly, this is a Israeli group of liver transplant recipients who were vaccinated with the Pfizer COVID vaccine. And again, you can see that there's a blunted response in the transplanted group. There's an association with age, association with high dose of immunosuppressants. And then finally, this is an Israeli group of lung transplant recipients. And you can see that after 2 doses, 31 out of 168 seroconverted, had detectable anti-spike antibodies. And the seronegative population was more associated with use of mTOR inhibitors and also anti-metabolites in their immunosuppressive regimen. So again, kind of more association with higher degree of immunosuppression, which is not surprising. And finally, this is from the Hopkins group, and several other speakers have already alluded to this study, and they show in a cross-sectional study of lung, solid organ, not just lung, but solid organ recipients, that there's definitely a decreased response. This is somewhat associated with use of cell cycle inhibitor. But there's also an association, clear association with age. Now, that's not the end all. That the antibody response or the humoral response to vaccination shouldn't be seen as the end all. That doesn't tell the entire story. And so there are several papers now that are that reports that have really delved into the cellular response. So the B cells, the T cells, T follicular helper cells. All of these components in the immune system are not fully characterized in this population. And so in this study, they looked at a cohort of patients, a little over 1 month and a little after 6 months after infection. And they looked at kind of at a deep level using this multidimensional analysis, T cell and B cell response. And they did find durable and functional T cell responses and also a memory B cell response that was evolving and maturing. So the immune system sees that initial infection and it is responding to it over time, and it doesn't forget about it. So there is memory that's being generated, and we can see that. The other piece of information here, so this is another study that was reported recently, and 20 healthcare workers who were vaccinated in Singapore. And they serially measure their cellular and antibody response. And I think the remarkable thing about this small report is that from a cellular response standpoint, they were able to detect SARS-CoV-2 specific T cells at day 7 before many of them, just about all of them, developed any sort of antibody response. So there's a T cell response component that we're really not paying a lot of attention to that needs to be further characterized and studied, and also the B cell response that are going to contribute to protective immunity. So taking that into consideration, the AST and ISHLT came out recently with this statement that pre-transplant, that's probably the time to vaccinate these patients because you're more likely to see a response. But they did not recommend stopping vaccination in post-transplant patients. They point out specifically that this other component of immunity that we don't know as much about right now could potentially be protective, could prevent severe illness. So may not necessarily prevent, maybe you don't have enough antibodies to prevent all infection, but are we lowering the rate of severe illness and hospitalization and death? Continuing in immunosuppression instead of withdrawing it, because we don't want to cause rejection in the process of trying to vaccinate these people. And so there's more that needs to be studied in this population. So scientific challenges ahead, again, developing improved methods for distinguishing between who's truly infectious and who is shedding virus. What are the immune correlates of protection beyond neutralizing antibody titers? Can vaccination elicit a protective T cell immune response, right? Even if you don't have a very robust humoral response. Does the infection cause autoimmunity? And if the patient develops autoimmune or autoantibodies, how does that affect the health of the lung allograft? What is the optimal immunosuppression strategy for these patients when they're infected? How should we manipulate their immune suppression? And how do we get them kind of back into equilibrium and resolve this immune dysregulation that is associated with COVID-19 infection? So I think we need to remain steadfast. There's these people with advanced lung disease that continue to need organ transplant. And we're just going to have to learn as we go along and incorporate this new data as it becomes available. And And with that, I want to thank the organizers and the Transplant Center, and thank you for your attention.
I'll be introducing Dr. George Youssef, who will be discussing on novel therapeutic strategies for COVID-19 ARDS. Dr. Youssef is a transplant pulmonologist at the Houston Methodist J.C. Walter Transplant Center in Sleep Medicine, also critical care medicine, and section chief of the academic pulmonary for the Houston Methodist Academic Medicine Associates. He's an associate professor of clinical medicine for the Houston Methodist Academic Institute and Cornell Medical College. Dr. Youssef went to school at the American University of Beirut, Facility of Medicine in Beirut, Lebanon. Dr. Youssef completed his internship and residency at Good Samaritan Hospital of Maryland. He then completed a pulmonary critical care medicine fellowship at State University of New York at Stony Brook, and a pulmonary transplant medicine fellowship at University of Pittsburgh Medical Center. His interests include lung transplantation, advanced bronchoscopy, general medicine, critical care medicine, development of novel inhale therapeutic interventions to treat lung transplant graft dysfunction. His core interest is in the use of vasoactive intestinal peptide in the treatment of critical COVID ARDS, post-COVID pneumonitis as a bridge to lung transplant, primary lung allograft dysfunction, post-COVID pneumonitis, pulmonary hypertension, sarcoidosis, and checkpoint inhibitor pneumonitis. Dr. Youssef?
Good afternoon. My name is George Youssef. I'm one of the pulmonary critical care sleep and pulmonary transplant physicians at Houston Methodist Hospital. I will be talking to you this afternoon about novel therapy in the treatment of critical COVID-19 with respiratory failure. I have no other financial disclosure or conflicts of interest beside the fact that I received funding as an investigator through my institution. Regarding the natural history of COVID-19, 80% of patients have their symptoms resolved within 5 to 7 days from symptom onset, up to 14 days. 20% of patients with COVID continue to progress, and 6% of these patients develop critical COVID and end up in the ICU. Outcome for those patients requiring mechanical ventilation is poor. Critical COVID-19 with respiratory failure in patients with advanced comorbidity is a highly lethal condition, despite maximum intensive care therapy. So far, no drug has been approved for treating respiratory failure in COVID-19. Antiviral therapy, as well as monoclonal antibodies, have been shown to be ineffective in this particular group of patients. Similarly, convalescent plasma did not show any efficacy in this group of patients. Steroids and anticoagulants have demonstrated general effectiveness in open-label clinical trials. For the rest of my talk, I will focus on vasoactive intestinal peptide, VIP, as a novel potential therapeutic blocker of SARS-CoV-2. Vasoactive intestinal peptide is a natural 28 amino acid peptide with no known toxicity that is 70% concentrated in the lung. There's in vitro evidence that VIP blocks SARS-CoV-2 viral replication. It also increases surfactant production and inhibits cytokine synthesis. Case control study demonstrates association between VIP blood levels and increased survival. Prospective clinical trial in high morbidity patients with COVID-19 respiratory failure demonstrates 6-fold improved survival on hazard ratio, 9-fold improved recovery from respiratory failure, 6-point mean difference on WHO ordinal scale, 4-fold improvement in PF ratio. A recently concluded randomized multi-center double-blind prospective trial in which participants were assigned VIP plus maximum standard of care versus placebo plus maximum standard of care in a 2-to-1 randomization. This showed a median 10-day reduction in length of stay in the hospital and a median 18-day reduction in ICU admission. When compared to placebo, there was successful recovery from respiratory failure at day 28 and day 60 and improved survival when controlling for ventilation status and treatment site. "50 years ago, Nature published the discovery of vasoactive intestinal peptide by Dr. Said, who was seeking the soluble factor responsible for hypotension and pulmonary embolus. Although purified in the intestine, VIP is 70% concentrated in the lung. Sami wanted to name it a very important peptide, but he was forced to settle for vasoactive intestinal peptide to achieve publication in Nature. Over the next 50 years, more than 500 publications documented the role of VIP in protecting the lung against a wide array of injuries, from inhaling smoke to inhaling stomach acid. In his final study, I had the privilege to work with Dr. Said to treat 8 patients with acute respiratory distress syndrome caused by sepsis. All 8 patients demonstrated improvement in oxygenation. 7 patients survived and left the ICU on room air. That ARDS study, sponsored by Stony Brook University at that time, served as the model for the current treatment of COVID-19 by VIP. VIP plays this role by binding to its VPAC1 receptor on the alveolar type 2 cell. This is the same pulmonary cell to which SARS-CoV-2 virus binds selectively via the ACE2 receptor. VIP by intravenous administration has previously demonstrated effectiveness in treated ARDS, as I mentioned before, and also showed promising results when used in an inhalation form against sarcoid and pulmonary hypertension. It blocks cytokine storm by blocking IL-6, IL-1, TNF-alpha, and IL-17, as well as gamma interferon. In addition, VIP is a nitric oxide co-transmitter. It also plays in the pulmonary vasodilatation, improving oxygenation in the lung, as well as increased surfactant production. It's very important to understand the lung in COVID-19, as respiratory failure in this disease begins with the alveolar collapse caused by a failure of surfactant production. This would generate a characteristic ground glass appearance and radiography. Surfactant is manufactured by alveolar type 2 cells, and selective viral attack on type 2 cells is enough to produce the lethal manifestations of critical COVID-19. Recently, VIP was shown to block replication of SARS-CoV-2 virus in human pulmonary epithelial cells and monocytes, while also demonstrating clinical improvement on radiographic and laboratory parameters. In addition to its antiviral effects, VIP protects alveolar type 2 cells by upregulating surfactant production, blocking apoptosis, and blocking cytokine effects. In vitro evidence also suggests that human monocytes treated with VIP secrete soluble agents that further protect type 2 cells via a bystander effect. In addition to its blocking of the viral replication, VIP blocks cytokine synthesis and also cytopathy in human pneumocytes and upregulates surfactant production. Therefore, VIP has a mechanism of action that directly addresses Mason's articulation of the site and mechanism of viral injury to the pulmonary epithelium. In vitro studies suggest that viral replication is reduced by 50% in cells that are pre-treated with VIP, as well as 40% inhibition of pulmonary cell death. In a case control non-intervention study of patients with critical COVID-19 and respiratory failure, there was 2 times more circulating VIP in survivors versus non-survivors. In an open-label prospective study in highly comorbid patients with critical COVID-19 and respiratory failure, 21 sequential patients compared to 24 patients who received maximum standard of care, including steroids, anticoagulants, remdesivir, tocilizumab, as well as convalescent plasma in the prior weeks. Treated and control patients were comparable based on age, Rothman index, SOFA score, and WHO ordinal scale. Groups were comparable at hospital admission when it came to age, Rothman index, SOFA score, but at time of ICU admission, VIP treated patients were higher risk on Rothman index, SOFA score, and ordinal scale. PF ratio was comparable. However, ordinal scale was statistically significant and was in favor of standard of care group. Primary endpoint, survival from time of ICU admission. VIP treated patients were 9 times more likely to survive long-term compared to those treated with standard of care. Secondary endpoint, recovery from respiratory failure. Respiratory failure as defined by the FDA, need for mechanical ventilation, non-invasive ventilation, or high flow oxygen more than 20 liters per minute, FI2 more than 50%. On hazard ratio, VIP treated patients were 6 times more likely to recover from respiratory failure compared to standard of care. Secondary endpoint, WHO 10-point ordinal scale. Substantial and statistically significant improvement by 6.1 point difference in the WHO scale in the VIP group compared to standard of care group. Another secondary endpoint, improvement in blood oxygenation, PF ratio. There was a 4-fold benefit in favor of VIP with a p-value of 0.01. Radiologic finding on one of the patients treated with VIP who was on ECMO. Clear improvement in pulmonary infiltrates and COVID-19 pneumonitis, which seen within 48 to 96 hours, not reported previously with other COVID-19 therapeutics. Also, substantial decrease in inflammatory markers in the VIP patients. Further data from the open label studies shows that resolution of respiratory failure was between 3 and 20 days, and time to ICU discharge was between 1 and 21 days, in addition to the fact that 14 of 21 patients were discharged out of the ICU. 19 out of 21 patients survived to day 28 in the VIP group versus 8 patients out of 24 in the control group. There was a 9-fold advantage in the cumulative probability of recovery from respiratory failure, favoring VIP. 6.1 point difference in the 10-point ordinal scale was seen between VIP treated patients versus those from standard of care, with a 2.6 point improvement in VIP patients from day of ICU admission versus 3.5 decrement in the standard of care group. There's also improvement in radiologic appearance. 4 out of 5 patients who received VIP were successfully decannulated from ECMO versus 3 out of 13 ECMO treated controls. This cohort also included 10 solid organ transplant in the VIP group versus 6 in the control group and 1 liver. 6 kidneys and 1 liver, with survival benefit in the VIP group at day 28 and day 60. This is a patient with double lung transplant who developed severe COVID, critical COVID pneumonia. This is his baseline characteristics with a PF ratio of 146, high flow oxygen, COVID ARDS pattern on CT. After 72 hours from treatment initiation, remarkable improvement in PF ratio and pulmonary infiltrates and oxygenation requirement. Radiologic findings at 6 months after hospital discharge showed remarkable improvement in infiltrates, and patient returned to pre-COVID lung function and functionality based on PFTs and 6-minute walk test. This is a patient who was on ECMO. On the left side, top left, you'll see classic ARDS COVID-related pneumonia. Patient treated with VIP 48 hours after 3rd dose, remarkable improvement in oxygenation as well as ECMO support and pulmonary infiltrates. Patient successfully decannulated and extubated and discharged home. On the imaging on the right side, this is a patient who also had severe COVID, ARDS, critical COVID by FDA criteria, was on ECMO. Evidence of fibrotic lung changes were noted. 1 month later, after treatment with a VIP, showed remarkable improvement. Patient has been decannulated and extubated and discharged home with remarkable improvement in the fibrotic changes. VIP in pregnancy. This is a pregnant woman at 27-week gestation, developed critical COVID pneumonia and was transferred to the ICU with early signs of fetal distress. Could not be transferred to higher level of care and she elected to stay in ICU. She was given VIP. Patient was successfully weaned off oxygen with complete recovery and discharged home on room air 1 week later. She received 3 doses of VIP. No signs of fetal deceleration during therapy. Patient subsequently gave birth full term to an 8-pound newborn. This is another patient who had critical COVID ARDS, was ECMO dependent, was not a transplant candidate after she was found to have, she was highly sensitized with high levels PRA and also morbidly obese. Despite the fact that patient cleared the virus, she was subsequently treated with VIP for 6 days, IV followed by 2 weeks of inhaled. Patient was successfully decannulated off ECMO, became only high flow / BiPAP dependent, became a transplant candidate, was actively listed, accepted for double lung transplant. However, unfortunately, patient during her hospitalization had developed an aspiration event, became septic, intubated, subsequently died after family withdrew care. If you see on the right side, her CAT scan before on the in November 16, before VIP treatment, and after VIP treatment on the right side showed improvement in her pulmonary infiltrates and pneumonitis. This led to the fact that if VIP could be a bridge to transplantation, a 24-year-old man with a critical COVID, ARDS, ECMO-dependent, trached, and on CRRT, patient was not a transplant candidate at that point. Patient was treated with VIP, hemodynamically became stable. Patient was subsequently listed and underwent double lung and kidney transplant. Patient recovered, extubated, went home. And patient on the right side, severely ill patient with critical COVID on the ventilator, also on ECMO, treated with VIP. Patient became clinically stable enough to be trached, became less requiring sedation. Patient now ambulatory, was accepted and currently listed for double lung transplant. Most recent preliminary data from the randomized double-blind clinical trial that involved 196 patients that were randomized into 2-to-1 ratio between VIP plus standard of care versus placebo and standard of care. It showed a median 10-day reduction in length of hospital stay, 18-day reduction in ICU admission, as well as successful recovery from respiratory failure at day 28 and survival at day 28 after controlling for ventilation status and treatment site in favor of VIP. I'm going to share a graph. This is patients with a NIAID score of 2 and patient with NIAID score of 3. These are critical COVID, and as you see, there's a clear advantage at tertiary centers at day 60 on both NIAID 2 and NIAID 3 versus when compared to remdesivir, NIAID 3 and NIAID 2 data. There's no statistical significance between the two groups that received remdesivir. Next step, inhaled RCT has already been launched, and at least 5 centers are included into the randomized clinical trial using inhaled VIP in the moderate to severe illness. Another adaptive trial, Tessico trial, which includes use of an intravenous VIP plus remdesivir versus remdesivir and placebo, but already started. The I-SPY adaptive trial will use inhaled VIP for different levels of COVID. In the pipeline, investigator-initiated trials that involve VIP, non-COVID ARDS, primary graft dysfunction using inhaled form, post-COVID pneumonitis, VIP as a potential bridge to transplant, VIP in the treatment of PH sarcoidosis and checkpoint inhibitor pneumonitis, as well as early ILD, and patients with long-haul COVID pneumonitis ILD. In conclusion, VIP shows a potential therapeutic blocker for SARS-CoV-2 based on in vitro trials, case control trials, as well as in open label studies and most recent randomized double-blind clinical trial. Thank you.
Dr. Youssef, thank you. Fascinating data. Our final speaker for this plenary session is Dr. Arvind Bhimaraj. Dr. Bhimaraj earned his medical degree from Gandhi Medical College and completed his Master's of Public Health at the University of Kansas Medical Center. He completed his residency at Drexel University College of Medicine and his cardiology fellowship at the John H. Stoger Hospital of Cook County, and his advanced heart failure and transplant cardiology fellowship at Cleveland Clinic. He is currently serving as the interim chair and chief of the Division of Heart Failure and is also the medical director of Advanced Heart Failure, Mechanical Assist Devices, and the Heart Transplant Program at Houston Methodist Hospital. His expertise spans the spectrum of heart failure from new onset disease to advanced cardiac failure. He is also the co-director of the Heart Failure Disease Management Service and oversees the quality aspects of care for general heart failure at Houston Methodist Hospital. He is also the co-director of the Heart Failure and Translational Research Laboratory. Please welcome Dr. Bimaraj.
In the words of Helen Keller, no pessimist ever discovered the secret of the stars or sailed to an uncharted land or opened a new doorway for the human spirit. I'm sure every one of you will agree that this pandemic has opened up doorways for the human spirit in an unimaginable world and in unimaginably uncharted areas, especially for the healthcare system. Ladies and gentlemen, good afternoon, and I'm Arvind Bhimaraj, the Interim Division Chief for the Division of Heart Failure and the Medical Director for the Transplant and LVAD program here at Houston Methodist. By now, you would have been exposed to the various aspects of how COVID-19 impacted transplant medicine, and I want to congratulate my colleagues who organized this conference for the breadth of information and the breadth of the topics that we were able to address. There is no doubt that this pandemic made us travel through uncharted waters, and individuals who take care of transplant patients were already dealing with uncharted areas because on a day-to-day basis, the way transplant patients respond to any intervention sometimes can be uncharted. So the combination of an uncharted pandemic with transplant medicine was definitely no fun. But we were grateful and glad to keep up with how things evolved, especially with guidance from national and international committees and organizations, but also institutional support through COVID-19 Response Task Force across the institution, and especially at the level of the transplant center. We had a transplant task force with all of us with various experiences who were able to provide guidance for us to handle this pandemic. The fast pace of evolving recommendations was embodied by the fact that the Infectious Disease Society of America had to create living document guidelines, which were published in April of last year, but were constantly being updated for treatment guidelines in general for COVID-19 patients, not specific for transplantation. And yes, if that picture looks like me, that is my brother who led the guidelines, and I can attest to the amount of effort that went into keeping up a living document. Organ transplants, especially the life-saving organ transplants like heart, lung, and liver, had an impact early on during the pandemic, as you notice in this graph, but very early picked back up to maintain normalcy through the rest of the year, which is reflected in this graph showing the number of transplants done in the United States. In 2020, we actually did more transplants than 2019. And across the regions, if you notice, there are very few regions where transplant volumes came down very slightly. Region 4, which is us, effectively were flat or, if any, slightly increased. Similarly, in our transplant program, this is a graph of number of transplants over monthly over a period of in 2020. You'll notice that early on around March, April, we came down a little bit, but for the rest of the year, we essentially ended up doing 56 heart transplants through the pandemic, our highest ever since our institution has been doing transplants. But of course, the journey was not easy or fun, and this was effectively me in early March of last year with so many questions that we had to answer, ranging from what do we do about patients in the hospital who are waiting for a transplant? What do we do if patients are listed and at home? Do we get them in and take the risk of exposure to the virus? When can we do a transplant if somebody gets a COVID infection? How do we protect patients who recently got transplanted from contracting the virus? Because there's cross-contamination across the system. If a transplant patient gets COVID-19, do we treat them more aggressively? Can we do things beyond what's being protocolized? And of course, COVID-19 donor screening, which had its own regulations, was something that we had to keep an eye on. Effectively, using the guidance of our Transplant Center Task Force, this is effectively what we did at our center, but this is a publication by Xu et al. Showing that in cardiac transplant, and probably all transplant, when you break it down into various processes, we had to adapt. Ranging from listing transplant patients, we had to balance out the risk of infection due to COVID if they come into the hospital versus the risk of not getting a transplant. For inpatients who needed a transplant in cardiogenic shock, it was effectively probably a relatively easy decision in my mind. Organ availability, of course, with donor ORs and travel was an area that we had to deal with, and I'll give you one example where we had to adapt. Of course, transplant episode as such with anesthesia, how to screen patients. For the transplant program, we do have an LVAD program, which is a cardiac replacement for organ failure, had to adapt in various ways. Post-operatively, handling families, patients, education virtually was something that was luckily and effectively managed by adaptation of all the telemedicine technology. And of course, post-discharge management, integrating telehealth, reducing in-person visits and being comfortable with it, cutting down surveillance biopsies to the most effective way has definitely been a paradigm that I think has impacted how we practice transplant medicine for the long term. So across the country, this study looked at effectively what happened for transplant during the early phase of the pandemic for cardiac transplant. And this was published in July of 2020, looking at the changes from the first 3 months of 2020 to March to May, in the next 3 months at that time. And at that time, as noticed in this map on the left side, we see that the rate of COVID infection was highest in the Northeast. And effectively, it made sense. Waitlist inactivations were quite high in that area, but also were significant in the West Coast at that time, who definitely were already were recovering from their first peak. When you look at change in donor recovery, various regions had different changes. Nothing changed at that time in Texas that you notice here in this graph. I think we were still going through our first peak at that time. And of course, change in transplants, most of the country had some effective change during that time, and most of it was mild to a little more significant drop in the number of transplants. The donor procurement part for us especially was challenging to an extent. Our surgeons, our donor procurement staff, with the risk of flying and exposing local donor teams, effectively trying to minimize exposure from across the board. So we had to make some tough choices. So for the first time ever, we did accept a local procurement team to harvest one of our hearts at that time. And very astutely, our chief surgeon, with his detective skills, I think really did some phone calls and found out and assured that the procurement surgeon, in fact, was a very skilled surgeon from a high volume center, which is what made us more comfortable when we're not using this particular paradigm regularly. And that worked out very well, and the patient did well too. Transplanted patients were no exception to get infected, and very early in May, cases were published coming from China where heart transplant patients were infected with COVID-19. This was 2 cases where one patient did okay and one patient did not do okay. And this was a time where there was this discussion about the virus causing more problem versus the immune system. So the perception was maybe immunosuppressed patients should do okay because you're decreasing the inflammatory burden causing the pathology. In any case, as time evolved, we saw that May of 2020 data from the East Coast essentially showed that mortality was about 25%, the survival of 75% in a small cohort of patients post-transplant who got infected. And interestingly, in their cohort, everybody seemed to have gotten hydroxychloroquine very early, which we were not really adapting based on the evidence. Tocilizumab was not given that much. And I want you to remember this kind of a paradigm of treatment framework because we'll show what we did effectively. Similarly, September of last year, data from another center was published by one of our ex-fellows, Dr. Singhvi, showing a similar survival that was reported in the previous study of about 77%, maybe a little better than 75% as time evolved. This graph does not show any treatment, but it reflects on how sick the patients were and what kind of a therapy they got in the context of oxygenation or hospitalization. In our center, through the pandemic, the line up here that's going up and down is essentially the percent positivity rate, which fluctuated based on the pandemic incidence, which makes sense. But the green line down here, where throughout the pandemic, post-transplant COVID deaths remained relatively flat. And I thought it was interesting, and I still don't have a full insight of what, and I'll reflect on our paper from our center where Dr. Yi put all our transplant patients together, all organs including. Heart representation was not very high at that time in November. And in this paper, if you notice, the survival of the patients was quite good. Even though the patients were still hospitalized at the time, the mortality was not high at all. There was only 1 death. And of course, that was actually a heart patient, one of the heart kidneys who had died in the hospital. But when you look at our treatment algorithm that we had adapted, I'm sure this was discussed earlier, there was a quite heavy early utilization of therapy, I would think, at least in my opinion and experience with immune modulation, considering tocilizumab access early in our center. And it's very fascinating where I just looked at these numbers yesterday that our heart transplant program, when you look at 43 patients who were infected, only 4 died. That's a 90.6% survival, much, much higher than what was reported in the previous study. And in fact, the overall all solid organ transplants, it looks like the data I got was about 86% survival, which again is higher than what's been reported nationally. So there might be something to the treatment algorithms and how we evolved. And it's interesting to notice that in the Northeast early on, the data that was published, there was quite a higher utilization of, lesser utilization of tocilizumab early on. And there might be something to this as we learn moving forward. COVID infection in the heart has been a hot topic from very early on. And myocarditis in the context of viral infection is nothing new to our world, but the incidence has been quite low in the past with other viruses. So what happens with SARS-CoV-2 with the heart has been an enigma, kind of an enigma until recently for the lack of models of mouse models. So if you look at mouse models of heart failure and myocarditis, SARS-CoV-2 does not infect the mouse heart because of the receptor distribution in the mouse heart. So innovatively, this is a recent publication. What people had to do is create engineered human heart tissue to study the impact of the SARS-CoV-2 virus on the heart. And what they found is that the virus gets engulfed by the cardiomyocytes through the ACE2 receptor. And these receptors are not present on non-cardiomyocytes. So they're not affecting your endothelial cells in the heart. They're not affecting the other cells within the blood vessels, but primarily impacting the cardiomyocytes. And the inflammatory response you're getting is macrophage mediated, hence leading to increased sarcomere disassembly, cell death, and cytokine production. In our clinical experience, we've seen quite a few of these myocarditis patients come in after COVID infection, some even lagging many months. And what's been fascinating is they're behaving a little differently in at least some patients, where the amount of myocyte damage is less, but the inflammatory component of myocardial dysfunction is quite profound. So we don't see too much of troponin leaks in these patients, but the heart looks quite bad. Now, cardiogenic shock, myocarditis, these were very early recognized during the pandemic, and we had to adapt and come up with a cardiogenic shock protocol specific to COVID patients. And on the other hand, everything looked like COVID. We were completely, I call it as COVID eyes, because whatever happened, we were suspicious it was COVID, to the extent that we published a case report which was misdiagnosed in the community while it was a classic ST elevation MI, and everybody thought it was COVID-19. So this patient came in much sicker than what they should be. It was not COVID myocarditis. It turned out to be run-of-the-mill ST elevation MI. We were luckily able to salvage, do an ECMO, do an Impella, and finally bridge them to an LVAD, which was a good armamentarium that we have access to in certain of these individuals. Leading into the discussions about LVAD as a therapy of cardiac replacement, we also had to adapt effectively for LVAD patients. And for those of you who don't know, LVAD is a mechanical heart which is powered by electricity. And what we had to do is figure out a way to power the patients who were COVID infected, just like all the adaptation of the ventilators were done for this. Our perfusion specialist, our MCS specialist team was able to innovate and do an extended cable so that we can keep the power source outside the room for COVID infected patients. And there's some amount of safety testing that is needed, because you need the power to go to the pump effectively. If you make it too long and you don't transmit the power, you can shut off the pump. So we've been using this since this was published early last year, and then we've been using it safely in most of our VAD patients who have come in with COVID infection. And this report from across the few centers was published literally a few days ago. We're looking at our own cohort of VAD patients and infections, because the hyperthrombotic state that COVID infection causes, does it impact outcomes or not? In our experience, interestingly, it's not been that profound for VADs. Similarly, in this cohort of patients, 40 patients who were included in this multi-center kind of a registry for VADs and COVID, about 20% deaths happen, which is still substantial. And I don't have data from our center, which one of my colleagues is looking into right now. Now, transplanting patients with COVID myocarditis is another frontier which has been broken, again, relatively early in 2020. This was a publication from Korea where a patient had COVID-19 myocarditis, and you see the EKG here. In myocarditis, these patients are deathly lethal very quickly, especially because the conduction system flatlines here. This is the EKG, and then that's the echo not moving at all. And it looks like they were able to salvage this patient with a transplant directly. They don't go into the details of whether they did an ECMO or not. And then in the European experience, this is from France, where they also did a successful heart transplant this year for a fulminant myocarditis. In our experience, we've had fulminant myocarditis because of COVID myocarditis, and luckily Few of them we were able to salvage by mechanical support, where we have access to probably better mechanical support than some of these countries. And the hope is if you catch it and treat it appropriately, that you can reverse them not needing cardiac transplant. But all this experience in the transplant world, I think, has some impact for us while we move forward. And I think some of these lessons that we've learned is, I personally felt that through the pandemic, we somehow figured out ways to get patients out of the hospital and keep them out of the hospital. I'm hoping we can rewire ourselves in making these decisions differently and getting patients out quicker. On top of it, I think the sense of infectious risk probably has become universal and not just for immunosuppressed patients, changing the way we procure organs, as you noticed in our experience, and also the drone delivery of a kidney, which happened last year, is very timely. Is this the future to come? I don't know. There's definitely discussions to have about it. We validated telemedicine platforms across the board, but also in transplant medicine, we were able to get away with a lot of not in-person visits. And where is the threshold? Which kind of patients is something which we will learn as we move forward. And the next paradigm that's being discussed is, can we take organs from patients who are infected, or the donors who are infected? This has been an area of debate, and this was a recent publication in the American Journal of Transplantation, which says, do we just say no, or do we debate about it? So there's evolving understanding. For now, at least we've not been taking too many organs from COVID-infected donors. With that, I would like to thank the organizers for inviting me. And this is my Twitter handle and email. Please feel free to email me if you have any questions. And thank you very much for your attention.
Thank you very much, Dr. Bimraj, for a very interesting presentation. So that concludes our presentations for now. We're going to start with the Q&A session. For our audience members, we can have you log on and ask questions. You've seen it before, but if you want to join by web, you can go to pollev.com, enter DeBakey, or if you join by text, you can text DeBakey to 37607 and text your message, and we'll try to get to as many questions as possible. But we're joined by Dr. Bimraj and Dr. Safdar. Thank you very much for your talks, and we'll start with some of the questions that we've had.
While we're waiting for questions to come up, Dr. Safdar, I have a question. Do you have a feeling for whether one form of oral glucocorticoid systemic therapy post-COVID for a patient who's having, say, progressive fibrocavitary lung disease, do you have a feeling for whether dexamethasone is superior over prednisone, or a duration of treatment, or how do you look at that?
I don't think there have been any head-to-head clinical studies looking at the utility and efficacy of any of those. I think there's a lot of European data looking at dexamethasone. In patients who are admitted to the hospital with acute COVID, we use dexamethasone. But post-COVID, there is some data on utility of using steroids. We use it. We use prednisone just because of ease of use and because of familiarity with the medicine. And I think if a patient with post-COVID progressive fibrotic lung disease, and that is ongoing, I think it would be important to figure out what is the etiology. It is really post-COVID or not. If it's just post-COVID ongoing inflammation, if they have underlying condition, then that should be treated. If they have progressive disease, consider antifibrotic, which could be something to look at, an off-label use. If they are really progressive, then refer them for transplant. And those are the things which are very, very important to see in patients who are having progressive lung disease. And you see that in a minority of patients, thank God, not in majority of patients.
Great, thank you.
We're also joined by Dr. Youssef. I wanted to ask another question of our panelists. We've had a lot of success in getting our transplant patients vaccinated at Houston Methodist. I wanted to see what your thoughts were on the experience in terms of how effective the vaccine has been for our transplant patients. Have you seen differences in the efficacy? Have you seen patients get infected despite being vaccinated? What have you seen in our heart and lung patients?
Well, I mean, as the speakers mentioned earlier, there's a discrepancy among these patients in terms of response to their immune response to the vaccine. We've seen some patients got infected between the first and the second doses. Basically, these patients, we end up putting the vaccination on hold for them. As other speakers, as mentioned earlier, we don't know whether this low immune response to the vaccine, whether protects them long-term from severe illness, but it might not protect them from the infection itself. They might still get infected, but maybe they might not get the severe illness as we've seen in other transplant patients.
Do you have, I'll ask of all of our panelists, do you have a timeline for vaccination of an unvaccinated transplant patient who gets COVID and then recovers and has a seemingly an uneventful recovery from that? Do you have a timeline for vaccination following that infection?
I mean, for transplant patients who got the virus, we typically were waiting about 3 months to vaccinate these patients.
I think that's true for, all general population also. If a patient gets infected with COVID, the usually recommendation is to wait 3 months. One of the interesting points that I noticed in one of the talks was that patients who are on immunosuppressive medicine, especially CellCept, mycophenolate, that was an increased risk factor, and they were less likely to respond to a COVID vaccination, so the titers were lower. So that was an interesting point. I think that needs to be looked into further, because a lot of our patients who are ILD and advanced lung disease, they are on immunosuppressive medications.
I've seen that in my practice as well. Patients on mycophenolate for interstitial lung disease of some type who get COVID, and they usually get a pretty severe case of it.
What's interesting, I've seen also in the general pulmonary patients who are on mycophenolate but not on other drugs, but some of them did have mounted a good immune response to the vaccine. So I think it has to do with the overall immunosuppression that the patient is on, not only just mycophenolate per se. Like if you're doing an ILD patient on immunosuppressant, I think it's different than the solid organ transplant patient. Their immune system, I think, is much more compromised.
George, what I've always wondered, and I think I had asked that question during the vaccine talk, and there was not enough time to address it, but we've been vaccinating transplant patients before COVID. We've never sat and debated on how effective it was. And I almost wonder, is it just the antibody production that we should be looking, but are there memory B cells? And it probably will end up seeing more that the effectiveness might not just die down with the lack of antibodies, because clinically, in the post-transplant patients, at least I've not seen any of the severely clinically infected COVID patients with the vaccine in the past. I don't know if your experience, in between the doses, they got exposed, but after completing a full set of vaccination, despite those patients who had lower antibodies, I don't think they've gotten infected and clinically came back with a bad infection. So it'll be fascinating to see what happens.
Yeah, I think we need more data. Our data on the lung patients, we have, as I mentioned earlier, some patients who got vaccinated and they got infected in between the 2 doses. Some of them really did not get that sick. Others really end up almost going on ECMO. These are like some patients we had to intervene in an unorthodox way. And I mentioned some of these patients in my presentation.
It's interesting that the immune response that the body generates, not just humoral immunity, there's a lot of data suggesting that T-cell immunity may be playing a role in this immune response to vaccination and to the infection. So it would be a nice study to look at who are the patients who are getting these low titers and are protective versus patients who are getting high titers or not getting that much protection and actually ending up getting COVID disease or COVID pneumonia.
Dr. Bhimaraj, do you think we'll be seeing more of the myocarditis post-COVID and looking for those patients in consideration for transplant in the near future?
I think it's inevitable. We of the patients that we've seen, I guess the only difference is we probably have robust enough mechanical support that until the science is clear and if it's an isolated cardiac myocarditis, which is not reversible, we will definitely be faced with those conditions. The 2 case reports that I've seen, they've at least published successful transplant, but I don't know the long-term data. I do think the viral myocarditis surge overall is higher than the past with other viruses. And as I mentioned in my talk, what's fascinating, and we just had an 18-year-old kid recently after 3 months of a COVID infection came in with massive myocarditis. And as I mentioned, it typically, the severity of the illness matches with the troponin leak, suggestive of the cell damage. But in this kid, it's almost like that infant syndrome that we're talking about, where the inflammatory markers were high, the heart was not contracting, but the troponins were not high at all. And we blasted with steroids and immunosuppression, and everything got better, of course, with an ECMO support. So I think this is going to keep happening, and definitely some of the conduction defects are going to be lethal. The appropriate mechanical support and possible need for transplant will be a possibility we have to entertain.
Arvin, also, you see that more in certain patient demographics compared to others in that adult multi-inflammatory syndrome. It's more in certain race, ethnicities as well. And that's really probably to be more, have a higher index of suspicion on these patients compared to others. Definitely there's this racial disparity when it comes to the disease manifestation itself.
That by itself is very interesting. I think it would be a hot topic for research.
Right. Yeah, we've seen it. I mean, it's more in certain ethnicities versus others. I mean, most of the most recent lung transplant that we did are Hispanic, for example.
Yeah, I think in transplant medicine, we've appreciated that for years together. There is a racial difference in how your immune system acts, and in heart transplant, African Americans always have a higher risk of rejection compared to a white race. So I think this sounds like not just an infectious disease, but this is an infectious immune disease. So now you add layers of complexity. So as we learn, you're right. I think the receptor variation, receptor expression, and then immune response definitely will have racial differences.
Well, thank you very much to the panelists and to the speakers for this plenary session. This concludes this session. We'll take a short break and be back with the next plenary session.
Thank you.
Thank you very much.
Thank you.
Thank you.
Good afternoon. My name is Richard Knight. I am the director of the Kidney and Pancreas Transplant Program at Houston Methodist Hospital. I'm delighted to moderate the final and concluding session of COVID-19 and transplant. And I'd like to introduce my co-moderators, Dr. Shetty.
Hi, I'm one of the transplant hepatologists.
And Dr. Okomase.
Sure. Previously introduced, I'm Dr. Okomase, a co-program director for this program and the director of the liver transplant program at Houston Methodist.
Now I'd like to introduce our first speaker, Susan Zelig, who will give a talk on COVID-19 and transplant, the Houston Methodist experience. So Ms. Susan Zelig is the Vice President of Transplant Services at Houston Methodist Hospital. She received her Bachelor of Science degree in nursing from Houston Baptist University and her Master's in Healthcare Administration from the Texas Women's University. Susan has 24 years experience in transplantation in both clinical and administrative roles. Beginning her career in transplantation in 1997, she first served as heart transplant coordinator, and then from 2005 to 2018 she served as director and transplant administrator at Houston Methodist Transplant Center. Since 2018, she served as vice president of transplant services. She plays an integral role in the growth and development of the multi-organ transplant center here at Houston Methodist. She has experience and expertise in transplant cost reporting, regulatory compliance, clinical administrative operations of a large transplant center. Susan leads and facilitates the center's executive steering committee, organ-specific executive councils, transplant quality committee, and organ-specific quality subcommittees. She also serves on Houston Methodist Organ Donor Council and the Medical Advisory Committee of LifeGift. Susan is a member of the AST Transplant Administrators Community of Practice and currently serves as vice chair of the UNOS Transplant Administrators Committee and member of the UNOS Policy Oversight. Again, her talk will be on COVID-19 and transplant, the Houston Methodist experience. Thank you.
Hello and good afternoon. My name is Susan Zelig and I am the Vice President of Transplant Services here at Houston Methodist. And I appreciate the opportunity to give an overview of our transplant and COVID-19 experience here at Houston Methodist. Certainly in the beginning of March, we were bracing for the unknown. We did not know what to expect now 14 months later. And as we began to see cases in early March, our transplant center took action to protect our vulnerable patients. We started with really developing COVID-19 pathways for screening and care of our patients. We addressed the transplant clinic safety procedures, including separating our symptomatic patients in the lobby of our waiting area, determining admission cohorting of our COVID positive patients. Early on, we knew that we wanted to protect our post-transplant patients from those that had infection, and so really separating those patients in the admission areas. And then implementing screening for our transplant events, including deceased donor screening of our recipients who we were bringing in for transplants, and doing asymptomatic testing of the transplant recipients prior to the transplant procedure. By the second week of March, we definitely continued to see activity and we ramped up our actions. We initiated pre-screening for our outpatient visits. We would call the patients at home prior to their appointments and make sure they weren't exhibiting any symptoms of COVID. We implemented a mask for all providers in the clinic, and this was well before PPE was being widely used across the hospital. We increased the sanitation of our waiting room, including wiping down of all chairs multiple times a day, making sure it was safe for patients who were still coming on site. And at this point in time, there weren't restrictions to visitors and patients in the hospital. We developed a fact sheet early on and for our transplant patients, and we distributed that via our EMR. This is a little snippet of that fact sheet. that we distributed. And then moving on, as cases continue to rise, we quickly implemented telemedicine visits for our providers and ancillary staff. This is something that I guess was a positive outcome of this COVID pandemic. It was that we were able to implement telemedicine very quickly, which was something we had been attempting to implement prior to COVID with some difficulty, but we were able to implement that pretty rapidly. And we definitely reduced our outpatient clinics and activities. At the same time, we shifted our workforce to work from home on a rotational basis, leaving about 50% of our staff on site and rotating them to call patients, do follow-ups from home, etc. And this is just showing you that first month we went live really probably late March, early April for our telemedicine virtual visits, and we really ramped those up pretty rapidly in April. This was our data at the end of April, how many visits we had done via video and a telephone. We continue to do telemedicine, and we still continue to do telemedicine today. Certainly at times when activity on site was reduced, we had more telemedicine visits. And then as we began to bring patients back on site, those decreased, but we have maintained that capability currently. Again, the volume of COVID patients began to impact our hospital operations and the mandates from the state regarding elective surgeries. CMS from guidance continued to support transplant surgery as a procedure that should not be postponed during the pandemic. And we had the same recommendations from UNOS, the United Organ Sharing, indicating that we should continue to support transplant surgery during this time period. But as the strain became really difficult on the hospital for beds and supplies, PPE, and blood, we worked together to develop a phased approach to transplantation. We really wanted to prioritize those patients who needed life-saving transplants and could not be postponed during this pandemic. We assessed the prevalence of disease at the donor location. Due to the lack of data we had on donor disease transmission, we wanted to assess if we were traveling to hotspots of infection. We wanted to really reduce that exposure and consider the safety of our procurement team flying into those areas of increased infection. We also implemented real-time checks of blood and resources with each transplant offer during that critical period of time. We would have our on-call staff check in with the blood bank and with the hospital administration to make sure that we were okay proceeding with activity at that moment in time, because things were ever changing really hour by hour and certainly day by day at that point. This is the example of our algorithm of our phased approach. Phase 1 was really focused on reducing living donor activity and those patients who could be deferred till the end of the pandemic wave, which we, as you can see in this document, thought was going to be only 6 to 8 weeks. And could we postpone some patients for transplant services during that time period? So this was the algorithm that we really had at the beginning of the pandemic. Phase 2, which we actually implemented on March 25th, was focused on those urgent cases, patients who were in need of service within 14 days. It may be possible to defer them for a few days, but not for the length of the entire pandemic. And really, again, this kidney population was probably impacted the most by reducing the living donor activity, really focusing on only the high-risk kidney recipients for transplantation, the high-risk, high-MELD, high-status patients for heart and lung, and really reviewing that activity on a case-by-case basis. Phase 3, we implemented on between April 1st and 2nd, and these were really those transplants we felt that were immediately life-threatening, and the need was the greatest, who really could not be deferred. And this further decreased the criteria for which patients we were going to transplant during that period of time. This was a local news story around that time of a kidney patient who had been deferred for living donor transplant. Unfortunately, we couldn't proceed with those cases during that time. And we also wanted to protect the patients who were getting living donor transplant from coming into the hospital and being exposed to potential infection as they were coming in, if we could defer. Thankfully, we did not have to implement phase 4. Phase 4 was anticipated to be a complete halt of all living and deceased donor transplant activity, and really only at the discretion of the medical director could we proceed with the transplant. Thankfully, again, we did not have to implement phase 4. And by about April 16th, we did scale back from our phase 3 restrictions. This was the activity during that phasing period of time. Phase 1, which was somewhat reduced, but pretty much we were still transplanting at full force. We did 36 transplants from March 1st to March 25th. And as you can see, the blue bar represents the number of life gift donors that were here in our local area. And then our 2020 volumes for those first couple of months in 2020. January was slightly a lower month for us under normal circumstances, and February was a really busy month. March, a little bit decreased, but not too much different from where we stood in January. But as you can see that when we implemented phase 2 from March 26th to the 31st, we only did 1 transplant during that time period. And then phase 3 on April 1st, which was for about 2 weeks, we only performed 8 transplants. And so that was a reduction in activity for us during that time period. From April 16th to April 30th, the second half, we did 20 transplants. And when we further reduced the restrictions, you can see in May, we went back to our volume of 58 and continue to proceed transplants the rest of the year. So what other measures did we need to take during the peak of the pandemic and transplanting patients during this time period? And we thought this was going to be the peak because we thought originally it was going to be a short-term process. But we still had some concern about donor transmission and outcomes during the pandemic. Society and the regulatory guidance was limited at that point in time. And so we were really having to just hedge our best, guess on what we should do and how we should proceed during this time. UNOS did provide guidance on outcome and performance measurement that they were assessing, how that was going to be measured. They did recommend donor testing, but recognized that it was limited in certain areas. Fortunately, our local OPO was able to provide that donor testing that we needed to be able to perform transplants. We did initiate an organ donor disclosure consent for our patients, basically stating that we didn't know what the impact of this pandemic was going to be, the risk of COVID-19 on the transplant population, and just letting them know that we're proceeding with our best intent, but we certainly don't have all the information at this time about the impact. And early on, we knew we needed to really gather data and track information on the transplant-specific population. Certainly, there was a lot of data tracking happening within the hospital on COVID-19 patients, but we wanted to focus on what was happening with our transplant population. And we began tracking our patients' testing, their symptoms, the results daily, and then moving on to weekly reporting throughout the pandemic. And we've continued that over these 14 months. We took outpatient reporting through the transplant coordinators when patients were getting testing at outside locations and through drive-thrus, through their PCP. We were gathering that information and recording it. Any outside inpatient hospitalizations, we were gathering that through the transplant coordinator reporting. And we were able to create an EPIC report to pull all of the testing of any patients that were at Houston Methodist entities so that we could drill down on those patients' information. And then our patients who were COVID positive, we were having our coordinators follow up with those patients regularly, at least once a week, to check on their resolution of symptoms, check their status, how they were doing, and really record that activity so we would have some information about how this infection progresses with our transplant population. These are some of the early results, and as you can see, it was very manually tracked as we were still just figuring out how to gather all this information for our population. This was early April. You can see at this point in time, we had about 114 patients that had been tested, 38 of those pre-transplant and 76 of those post-transplant. We had a positivity rate of about 12.1%, and in the post-transplant population, about 13.6%. And so we were really manually tracking these patients, watching their activity, their admission status, et cetera. By early May, about a month later, we had gone up to 312 patients tested. We began testing patients who were asymptomatic for procedures, diagnostics, pre-op testing. And so this was, I guess, diluting the positivity rates a bit, since we weren't just testing symptomatic patients, we were testing asymptomatic patients as well. So our positivity rate was 10.9% in our total population and 10.2% in our post-transplant population. As cases began ramping up in early June, and there were predictions that we were going to have another larger peak in the summertime in July, we really began to say this isn't just a short-term 6 to 8 week event. This is something that we're going to need to really address more long-term. And little did we know that there was going to be several more peaks, and that we were still going to be managing this this far out. But we implemented a more formalized transplant COVID-19 task force to really address the ongoing issues and management of our transplant population. We began to develop protocols on monitoring treatment of patients and post-COVID management, directing our coordinators and staff on testing and management of those patients post-COVID. This is another example of one of the outpatient treatment protocols and how we were going to manage them with therapy and follow-up and an algorithm. This is a slide showing our data from really early March through August at this point in time. We were looking at how many patients we were testing every day and those that were detected as COVID positive. And you can see that little blip of orange in March and April was not nearly anything compared to what we experienced in June and July. And that kind of follows along with what the hospitals were experiencing at the time. But we really began to track this a little bit more readily with our EPIC tools, et cetera, and really watching the trending of that data. This is just another view of that with the positive COVID tests and the 7-day rolling average of positive tests, just another way we were watching how this was trending forward. And then this is the cumulative patients. This is really just a snapshot of July and August of how many patients we had positive by that point in time and what our percent positivity rate was, which was hovering around the 14% range by mid-August. And you can see it had trended up over that time period. We continue to develop more education for our patients to keep them safe before and after their transplant. This is an example of one of the brochures, educational tools that we developed. We began doing more webinars for our patients and for the community physicians, really helping to manage the patient population. During this time, we had when we had limited outpatient activity, we had reduced some of our evaluation services, and we were beginning to work on developing tools that we could manage those patients remotely, doing our education classes virtually, things that we had traditionally done in person here on site. We converted a lot of those to virtual sessions, which was really a great tool for the patients to use, and then for our staff to be able to connect with the patients. So how did we end up in 2020? We actually ended up with a larger volume of transplants than the prior year, despite the couple of months with reduced restrictions or reduced activity in transplant. We continued to have elevated activity towards the end of the year, and we really did not reduce our activity throughout the remainder of the year. The hospital was able to adapt to that volume of patients by opening more ICU beds and more acute care beds, adding resources of nurses and other respiratory therapists, et cetera. And so really, we were able to continue our operations throughout the remainder of the year, which we feel very fortunate that we were able to continue operations. So where are we now? This is a more current trending of activity. We have seen a decrease of, this is a daily number of patients tested, a weekly number of patients tested and the positive cases during that week. It's not a cumulative, just a weekly reporting, and the number of deaths. And we have maintained a fairly low death rate, but we are watching sort of the impact of the vaccine and outcomes post-transplant very carefully. We thankfully are seeing a little bit of decline in the number of positive cases, but we are seeing those patients somewhat early post-transplant having a little bit of difficulty. And then this is really another weekly cumulative trend, one of the more recent data slides. To date, this was actually through April 25th, we have had 2,007 patients tested post-transplant. 326 have been positive. These are unique patients, not the number of tests, with a 16.2% positivity rate. 56 of those patients were less than 1 year post-transplant. We've had 12 deaths in that group. We've had 76 patients test positive in the 1 to 3 year post-transplant period, and 12 of those have expired. And then we've had 194 greater than 3 years post-transplant who have been COVID positive, and 20 deaths in that group, for a total of 44 deaths out of 326 positive patients, for a case fatality rate of 13.5%. And then this is the breakdown of post-transplant COVID-19 cases by organ. You can see that kidney bears the largest brunt of patients who have COVID positive. That's one of our larger proportion of patients in the program. They've had 159, almost a little over 180 cases, but 159 of those still recovering, and 23 who have expired. And then you can see the breakdown with liver and lung and heart following suit. And these follow along the lines of our volumes in the programs, with our multi-organ cases being much smaller. So where next, and what do we need to do from here? We certainly have a lot more to learn from our experience and managing the patients with the outcomes. We have questions about, and I'm sure you've heard today and previous speakers, we have questions about the vaccine management and outcomes for transplant patients. Do they need another booster? Are they responding to the vaccines in the way that we would like them to? So those are certainly questions that we still have, and are we having outcomes post-transplant as a result of that? Really still monitoring the donor disease transmission and how we move forward with that. And then really, what are the long-term outcomes of the post-transplant patients with COVID-19 infection? At least these are some of the really clear questions that we still have yet to answer long-term. And I'm sure there are many more questions raised by everybody during this conference today. But I really appreciate you allowing me to share our experience here at Houston Methodist with COVID-19 and transplant, and I'll be happy to answer questions in the Q&A. Thank you very much.
Thank you, Susan. That was a very clear representation of the Houston Methodist experience in terms of COVID and transplant. It now gives me a great pleasure and honor to introduce the next speaker. Is Dr. Stephanie Yee, is a kidney and pancreas transplant surgeon who received a first degree, undergrad degree at the University of California at Berkeley. She subsequently had a master's in pharmacology at Tulane University and got her medical degree from the University of Buffalo. She then came to Houston, where she did her general surgery residency and abdominal transplant fellowship at the Houston Methodist Hospital. She's a recipient of multiple awards, being awarded the American Board of Medical Specialties 2014 to 2015 Visiting Scholar Award and a one-year research fellowship funded by the American Board of Medical Specialties. She went on further to complete a master's in public health at the University of Texas Health Science Center School of Public Health, where her focus was on health services research. She's published multiple publications on transplant outcomes, including work on COVID-19 and combined organ transplantation. Dr. Yee is currently assistant professor in surgery and holds academic positions with the Texas A&M College of Medicine, the Houston Methodist Outcomes Center, and the Houston Methodist Research Institute. She sits on multiple quality committees at the Houston Methodist Hospital and is active with the AST, American Society of Transplant Surgeons, and she's on the Living Donor Committee of that association. So it gives me pleasure for her to give us a talk titled Approach to Living-Related Renal Transplantation During COVID-19 Pandemic. And Dr. Yee.
Hi, I'm Stephanie Yee. I'm one of the kidney transplant surgeons here at Houston Methodist Hospital. I'd like to thank the course coordinators, Dr. Gaber and Dr. Gobriel, for giving me the opportunity to present to you today. I'll be talking about the approach to living donor kidney transplant during the COVID-19 pandemic. First, I'd like to say I do have some disclosures, although I won't be mentioning any of this during my talk. So in the next 15 minutes or so, I'd like to introduce the impact of COVID-19 on transplantation. I'll review some of our protocols for living donation at Houston Methodist Hospital, and I'll discuss current measures that we are using to reduce the risk of COVID-19 in both donors and recipients. So many of you already know this, but COVID-19, otherwise known as SARS-CoV-2, has infected over 141 million people worldwide, and unfortunately we know this number continues to rise. The US leads the world in the number of cases, and at the time of my preparation for this presentation was about 32 million people. And as you can imagine, this caused major disruptions in not just general surgery or in procedures in the medical field, but in solid organ transplantation. And this is why. So at the start of the pandemic, back in March of 2020, the disease number of progression and the number of reported cases in the US exponentially skyrocketed to the point where the number of deaths as a result from the number of cases was also quite high. We didn't know if whether or not COVID-19, which is related to the Sars virus that we dealt with early in the early 2000s, would have as bad of an impact on solid organ transplant patients. And so as a result, the number of transplants that were performed nationally really plummeted. And that was out of precaution due to the fear of resource utilization and what the potential risk effect for COVID-19 would have on these patients. It became especially evident of the decline in activity in transplant amongst our living donor group. And that was because the living donor side of transplantation was suspended, being that it was a little bit more elective base compared to deceased donor transplants. And so I'm not just talking about kidney, I'm talking primarily about the thoracic transplants and liver transplants, in which there's no other alternative for the patient. And so in select situations and institutionally based, those programs continued on. But if you can imagine, there were quite a few missed opportunities. And so there was a substantial impact for not transplanting patients during this time. The UK estimated that globally or nationally, over 1,600 kidney transplant opportunities were lost during the height of the pandemic. Transplant volumes were down significantly in the US. It was estimated that there was a reduction of about 40%, with kidney having the highest number at 43%. And waitlist deaths also increased substantially at 26%, again with kidney transplantation being the top at 43%. So after some time had passed and some additional modalities were identified for the general population with COVID, there was a lot of discussion on restarting transplantation. We knew we had growing wait lists, we knew we had patients dying on the wait list, and we knew that the risk for mortality, especially in relation to kidney transplantation, was quite high for those on dialysis, especially if they had a living donor that was ready to go. There were many challenges, however, in both the donor and the recipient. In regards to the recipient, we had a lot to learn when it came to COVID-19 and transplantation. In the beginning, we really didn't know how transplant patients would present. We didn't know what kind of symptoms they would have. We didn't know what their laboratory data would show. And that really was because we didn't know what immunosuppression did in terms of modulating the inflammatory response that was brought on by COVID-19. At the time, there were also a bunch of antiviral agents and anti-inflammatory agents that were being used to treat COVID, and we didn't know if that had any impact or side effects on these patients. And then lastly, there was an issue of hospital resource utilization and availability. We didn't want to bring in additional patients that would need that intensive care or the ICU bed or supports, or to reallocate nursing staff or hospital staff that was otherwise treating our packed ICU with COVID-19 patients to shift over and start treating our transplant patients. So a lot of this was uncertain at this time. But what this all really kind of boiled down to was how we were able to assess whether the risk of death on dialysis outweighed the risk of mortality from COVID-19. In regards to the living kidney donor, there were some challenges involved as well, and in some ways I think a little bit of a higher impact. And this is the reason why. When a living donor comes forward, or when a patient comes forward to be a living kidney donor, our job is to ensure that we minimize their risk as much as possible. And that's just not the risk of developing kidney failure or the risk of having an MI during surgery, but really just any risk. Living donor surgery is one of the only surgeries that does not benefit the donor at all. And so it's all about minimizing that risk. So there was a lot of uncertainty at a time when hospitals have shut down elective surgery. And the question is whether or not this is considered an elective surgery. I have to say that a lot of times the answer is yes for the donor, but it's no for the recipient. And so somehow there has to be some kind of compromise between the two. Additionally, there was a lot of uncertainty regarding what would happen with the donor if they were to contract COVID-19 following donation. We know that COVID-19 affects the kidneys. Would there be a problem with post-donation renal dysfunction due to COVID-19? And what about any other post-operative recovery issues if the patient were to contract COVID? We also know that COVID can cause an increase in DVTs, and that certainly could be quite debilitating, if not increase their mortality in a donor. There were also several logistics to safety. For example, did the donor have to self-quarantine prior to donation? What would be the appropriate COVID-19 testing protocol prior to donation? And then as time went on, we were able to open this discussion about vaccination status. And then similar to the challenges for the recipient, there was a question of whether or not this was an appropriate use of resources, not just materially, but with the staff. And so Krista Lentine wrote a paper, which was actually recently published but looked at some of the uncertainty and some of the barriers with restarting kidney transplantation during the pandemic. This is a survey in her paper which they had U.S. transplant centers respond to, and basically it was trying to identify what were some of the barriers prior to starting living donation. As you can see, one of the higher ones is a program concern for donor safety. In fact, that's the number one concern, followed by the recipient safety, and then the patient issues of whether or not they wanted to proceed. The other one, especially in larger institutions, which is the red line on the top of the bar graphs, was the resource utilization issue. Although we shouldn't have to anticipate the use of a respirator for our living donor pairs, that was very much a concern. If something were to happen, would that be available for them? As well as kind of going against any restrictions that may be in place by the hospital or the local government regarding the use or the starting of elective procedures. So we took all this information, we tried to think about our best way of proceeding, and actually here at Methodist we're restarting our living donor program after a brief hiatus back in April of 2020. If you look at the national data, living donation returned to pre-pandemic levels by June of 2020, and so that shows that a lot of centers decided that it might be okay and it might be safe to go ahead and proceed. And I think some of this was seen from our deceased donor population, which proved to be relatively safe in those conditions. And this is interesting because although we restarted living donor kidney transplantation, other procedures were not really allowed to start, and that's not transplant procedures, but other kind of medical or surgical procedures in the hospital. The one interesting thing, though, was that kidney paired exchange or kind of NKR type swaps really decreased during this time period, and that probably was related to the restrictions with travel for these organs. Now, we did face some barriers when we started our program. That included some reluctance from donors who maybe lived out of state, not wanting to come in or unable to come in, or some living donor recipient pairs who just wanted to wait it out for the pandemic to get better. And we also did have our share of some positive COVID-19 tests amongst donors, as well as some donors having COVID-19, so not just testing positive with their PCR and being asymptomatic, but actually having COVID. And then that also applied for some of our recipients as well, and so their cases had to be postponed. So what do we currently do to kind of minimize that risk from COVID? We require a pre-op testing for COVID about 10 to 14 days prior to their surgery, and then we bring them back again the day after their surgery. If the patient had COVID-19 or a positive COVID-19 test, then they had to be asymptomatic for about 28 days and have 2 negative PCR tests. And so this is our way of ensuring that it's not just viral shedding that's still persisting despite them being asymptomatic, but just that we have no question about whether or not there's any return or any subclinical evidence of COVID-19. And so some of the more kind of optimistic or positive highlights of our return to living donation is one of the bigger swaps that we did back in October. This involved 10 patients, 5 kidneys, and 2 days, as the Houston Chronicle put it. Here are some pictures of that really amazing set of days, getting the kidneys and allowing the donors and the recipients to see each other, granted with masks and some social distancing, but trying to kind of find a return back to their lives and continue on with this life-saving procedure. This is a group that published a case report on a living kidney donor that had COVID, recovered, had negative PCR test per their protocol, which is similar to ours, and had a successful kidney donation with a recipient that ended up having good graft function. It's a very interesting paper to read because it sounds very, very familiar to some of our experience here at Methodist. And so I did mention about the vaccination status talk when trying to minimize risk for the donors, and that really happened here as well. So when the vaccines became available, and I'm talking about the mRNA vaccines, Pfizer and Moderna, that became a great selling point in trying to get our donors or pre-donors vaccinated as well so that we can try to minimize their risk for COVID. And this is just some information about the safety and the efficacy of these vaccines in the general population. We know that Pfizer, in their initial clinical trials, had showed a 95% protection with vaccination, appeared to be very effective. Moderna, the same thing, about 94% protection with the vaccination. And then there's now a growing number of papers reporting kind of antibody response from the vaccine in the general population. This was published in the New England Journal showing antibody persistence beyond 6 months or through 6 months after the general population group had their second dose of the COVID vaccine. I am not going to put any information about the vaccine in our solid organ transplant patients, but that will be for another talk. And so even after the end of their surgery, we really implemented preventative measures to make sure that despite patients maybe being vaccinated, that they continue social distancing post-surgery. So that involved mask wearing, self-quarantine, hand washing, and these were very similar to the recommendations that we imposed upon the transplant recipients. Even though living donors are not immunosuppressed and potentially not at higher risk for getting COVID, we wanted to ensure their safety and minimize their risk from any problems related to COVID-19. And so we kind of had them do very similar things. So how did we do when we restarted our program? We did actually really well. Here's kind of an outline of how we did from a volume status in 2020. And despite the pandemic, we came in third for the number of cases, and second in our region because the group that came in first is actually in our region. And this is these are the centers that we compared ourselves to. We came in third against Methodist Specialty out in San Antonio and Mayo Clinic out in Rochester. So I think this is a really great testament to the hospital support in restarting this program, as well as the camaraderie we had amongst the different nephrology groups and the surgeons, as well as the hard work from our coordinators to get all this through. And then we were able to do a good number of swaps. So this isn't necessarily kidney pair donation in the national sense, but in terms of internal swaps, we did about 41 compared to the 48 from 2019. So pretty good considering that we did have to halt the program temporarily in 2020. So in summary, living donation appeared to be a viable means to get people to transplant even despite the pandemic. We did have to tweak a couple of our protocols to ensure the safety for both the recipient and the donor. We really emphasized the importance of social distancing and hygiene measures in both of the groups. And I think some of the success for this was really the strong relationships between the transplant center, the physicians, and the patients in really getting the success of our living donor program going, even during the pandemic. Well, that's all I got for now. Thank you so much for your attention. Happy to take any questions.
Thank you, Dr. Yee, for that wonderful talk. I just want to remind our viewers to send in our questions. You can do so by joining by web. Go to pollev.com, enter debate key, and then respond to the activity. Alternatively, you can also text debate key to 37607 and text in your questions. So it's now my pleasure to introduce our last speaker, Dr. Osama Gaber, who is the current chair of Department of Surgery at Houston Methodist Hospital, the John F. Jr. and Carolyn Bookout Presidential Distinguished Chair, and the founding director of the J.C. Walter Jr. Transplant Center. Dr. Gaber is a professor in surgery at Weill Cornell Medical College. He's also the program director of the Abdominal Multi-Organ Transplantation Fellowship and senior member of the Houston Methodist Research Institute. He earned his medical degree from the Ain Shams University School of Medicine, Cairo, Egypt, and subsequently completed surgical training in general surgery at Boston University Medical Center and a research clinical transplant fellowship at the University of Chicago. He has devoted much of his career to pancreas, liver, and kidney transplantation. Dr. Gaber is author of more than 270 papers, 340 plus abstracts, and numerous book chapters, and has received research funding from several national and local foundations. He founded the Nora's Life Gift Foundation to build Nora's Home in Texas Medical Center, a hospitality house established to provide transplant patients and their families affordable temporary housing where they can find encouragement and support within a family environment. Dr. Gaber is an active member of several major transplant organizations and currently is president-elect for the American Society of Transplant Surgeons and the Texas Transplantation Society. He previously chaired the Texas Governor's Chronic Kidney Task Force and remains committed to this effort. Today, he's governor appointed to the new task force under Texas Governor Greg Abbott. Under his leadership, the Houston Methodist J.C. Walter Jr. Transplant Center quickly rose to be the largest in the state of Texas, one of the top 10 largest in the country. As newly appointed chair of Houston Methodist Department of Surgery, Dr. Gaber is focused on building nationally recognized academic and educational platforms for the department. Today, he'll be talking about system innovations during the COVID-19 pandemic. Over to you, Dr. Gaber.
Good afternoon, and thank you so much for the invitation to speak to this conference. I want to say that it's been an amazing day. The feedback that I've been getting through text and email from all the physicians and the staff that's been attending the conference has been overwhelming of how well the topics were done and presented. So I truly appreciate the efforts of everybody who's participated up to now. I want to say that there are some advantages and disadvantages to being the last speaker in the conference. The advantage, of course, is that you've heard all the other speakers, and so you can modify what you're going to say to fill in the spaces or whatever hasn't been said, or to respond to questions or concerns that have been raised by the audience. That's obvious. The disadvantage, however, is that by the time you come to speak, you realize that there isn't anything you're going to say that somebody else has not said it, particularly when you have such a distinguished list of speakers ahead of time. So what I'm going to try to do actually, and what I tried to do in the last few hours as I was listening to the conference, is to keep modifying my talk, to give you something new that really adds to what you've gotten from this conference. I want to say, I don't know why I can't advance my slides, but let's try again. I want to say that I did use a lot of slides that were provided to me by Dr. Rob Phillips, the CEO of our physician organization. And I think that he's been a very good teacher during the COVID pandemic to all of us about organizational reliability and system improvements that need to be put in a hurry. So what I wanted to talk about is how the COVID pandemic has transformed not all of Houston Methodist, because Dr. Boom and Dr. Sussman touched on that, but how the Transplant Center has evolved into a highly reliable organization, and how it accomplished its missions of keeping the transplant patients safe during the catastrophic event of the COVID pandemic. And despite all the hazard, the tasks, the time constraints, the complex technologies that you heard about throughout the day. The J.C. Walter Jr. Transplant Center really owes its origins to a bunch of giants in American surgery, including, of course, Michael DeBakey, George Noon, Graham Guerrero, and a lot more people that participated in building the Transplant Center. I'm privileged that I was the founding director of the J.C. Walter Jr. Transplant Center. But what we wanted to do is create that type of organization that is highly reliable and can produce care that advances organ failure management, recognizing that this is the biggest problem that is facing patients in the current age, which include amyloidosis, bone marrow transplantation, heart, eyelid, kidney, liver, lung. We specialize in multi-organ transplants because of the closeness by which we work together with pancreas transplants, vascular composite allotransplants, and of course, as you heard from Dr. Bimaraj, ventricular assist devices, which we do in collaboration with the Methodist DeBakey Heart and Vascular Center. This is where we go back to. This is a picture from the I think it was the Chicago Tribune. I'm not sure the exact journal it came out from. It was Associated Press. And it's August 19, August 31st, in which Dr. DeBakey announces the first multi-organ transplant procurement done at Houston Methodist and in the world and the country. This sort of landmark, this sort of innovative spirit is what led us to develop this amazing center that we have today. So what allows us to align our values with the transplant center and the hospital? I think we need to know what our values are. And the Houston Methodist values is something that we all know, but it never hurts to go over them again, because integrity, compassion, accountability, respect, and excellence are really the foundations upon which we build this transplant center. And you cannot, when people keep talking about the success of the transplant center, you cannot really separate the transplant center from the culture in which it grew. So culture is everything. And the right culture allows us to do the right thing, which allows us to develop these highly reliable organizations. So what are the pillars that drive an HRO at Houston Methodist? As I said, number one is the culture. Because without our Houston Methodist culture, the I care values, and the way by which we are all, employees, physicians, everybody, are valued members of a care team that is empowered to really do the care and escalate the response to any crisis that happens. This really affects the quality of care, which is one of the major efforts that we've embarked on at the Transplant Center. The second thing is the correct process, the right process. We know, as Dr. Boom has told us, that we have to be patient-centered, tool-driven, use data and evidence, standardize the care. That's why we spend a lot of time at the Transplant Center creating protocols and processes so that there are no one-offs and nobody gets treated a little bit differently, because then you have chaos. And clearly, we don't take away the ability of people to tailor the treatment to the patient, but it's all within protocol and evidence care. It's equitable, of course, and that all physician and employee, they get and they have what they need to be part of the safety culture. The right setting, of course, and I'm not going to talk about that because it's been discussed throughout the day, the right treatment and the right value. And as a result, this has been our journey with the COVID. When you look at a COVID patient, it's really mind-boggling, right? Mind-boggling, because to take care of a patient like this is a patient that's been prone, and every piece of equipment have been attached so that it can be monitored and or touched from outside of the room. And the patient can be actually mobile and go to get whatever tests or examinations they need to. The complexity of this is just mind-boggling. And so what we have to do is we have to do this without errors. And it's really, again, mind-boggling what without errors means, right? Because if we do 99.9% correct, that's not enough. Because if 99.9% was good enough, the IRS would lose 2 million documents per year, which of course doesn't happen. But that's the 0.1% of the documents that they get. We get 3 major plane crashes every day, which of course doesn't happen, but that's what 0.1% is. We would lose 16,000 letters in the mail every hour. We'd have 37,000 ATM errors per hour. And you see the rest of the numbers. So 99.9% isn't enough. We have to deliver medical care in that very complex scenario that I showed you, really error-free and at 100%. So how did we do this? How did we do what Stephanie, Susan, Dr. Mobley, Dr. George, Dr. Wong, Dr. Bimraj, and everybody who spoke today, how did we get there and do what we've been able to do? So number one, you have to have deference to expertise. You can't just shoot from the hip. You have to get the experts and get their opinion. the operations have to be sensitive. They have to be sensitive, and I'll show you, to both the consumer and to the outcome. The healthcare system has to be learning. Clearly, the Methodist healthcare system is, but achieving that in transplantation is also and has been important. We have to have a preoccupation with preventing failure, because we cannot fail. Because as we said, we have to deliver to the 100%. And if there is a failure, we have to be very reluctant to do workarounds and have whatever solutions, because these don't work. We have to be very reluctant to simplify failures when they occur. And then we have to promote resilience in our staff, in our teams, so that we continue working at this high level of proficiency all the time. So we need to ask the people on the front line, because they are the root of the processes. And when Susan showed you the stages that we proposed for activity, we didn't just, Susan and I, or she didn't just sit by herself and made this. We had a conference with all the physicians that are involved, and we got subject matter experts, infectious diseases, Dr. Drews, Dr. Grimes, and we had, at that time, hospital administration. Everybody was involved in that. So that path that we took was really based on expertise. And this is really complex, but it tells you that this is how the care of the COVID patients was designed in the hospital, from mild to moderate to severe. And this is sort of the platform that we used to design the levels 1, 2, and 3 that Susan talked to you about. The second thing is the sensitivity to operations. We really have to have big picture thinking and understanding the operational complexities that surround taking care of our patients. We have to incorporate impact of cognitive bias. We all come to something like COVID, even though we didn't know the data, but because of our backgrounds, our dealings with the other SARS or the H1N1 flu, or anything else that we've had experience, influenza, which has been a major problem in our patients. We have biases, and we have to incorporate the impact of these biases in what we design. And then we have to identify improvements or opportunities for improvement in workflow and doing better processes so we can take care of our patients. So this is a mixture of what the frontline innovations that were developed for COVID-19 in the hospital, including right here in the transplant program. Because what we came up with is new transplant guidelines for operations. We came up with new protocolized transplant immune suppression protocols. We came up with protocols for vaccination and for storing vaccination data. And we really tried to navigate through, used everything else that the hospital has developed, like mechanical ventilation, the ICU proning, the insulin drip guidelines, everything that the hospital developed, and added what the transplant center needed to perform at the very high level of care that we want to perform in. And of course, when you develop these things, you don't just sit there in a room and you say, okay, I'm going to do them. Here you can see, for example, the development of that intubation and bronchoscopy for COVID positive patients. That was a major concern for the physicians, because this was a very aerosolizing procedure and could lead to infection. Remember, at that time, when we were developing this, we didn't have enough masks. We had no PPE. So the development of that box, from which you see Dr. Masood, the head of our intensive care unit center, is trying to intubate a patient, was a major advance. The other thing, which we had in the clinic, is the personal protective pod. Again, because we didn't have N95s or KN95s at the time, we weren't sure if regular masks were going to be protective enough. This was a way, and this is how we got most of our early COVID specimens from patients. We listened to the voice of the patient and the consumer. Of course, the same person can be a patient when he's seeing us and a consumer when he's trying to pick up some apples. But really, our patients are consumers of healthcare. And their opinion matters because they're very important. And because we have to deliver care that's tailored to them. Otherwise, they won't want to come and get it. And number one, we would lose a chance of serving them. But number two, they would lose the opportunity of getting a high quality care because we couldn't tailor it to them. So that was very important for us. And when Susan talked to you about the living donor and Stephanie talked to you about the living donor, one of the things we did very early on, and I credit the living donor physicians for that, is that Dr. Ibrahim and the coordinator surveyed the patients that were on the waiting list to see what their preferences are. Are they willing to take the unknown risk or risks as described of the COVID-19 at that time versus waiting for the transplant for later? And that's what helped us re-jumpstart our living donor program and get a lot of people transplanted even in the middle of the pandemic. So what happens? The patient said three things to us. They said, help me now. I don't want to wait. Help me now. They said, make it really easy or I'll go elsewhere. I mean, clearly the transplant patients are sort of locked in, but they clearly could get their care elsewhere. And remember me, I'm not just a number. Make sure that the care is personalized to me. So how do we do that? To help them, they didn't want to wait. We couldn't see them in the office. And you saw the beautiful presentation about the virtual visit, the flexibility of the schedule, and then really enabling the patients to digitally access our systems through my chart and the web visits and so forth. It was a tremendous advance to us during the pandemic. We made it easy by removing a whole lot of the barriers for the check-in and follow-up processes that we used to have, and use telephone conversation and web to give patients data and information so they don't have to come back in knowing that everybody wanted to hunker down in place. And then we created clinically efficient workflows where we would screen ahead of time, take questionnaires, do testing when it was available, make sure the patients don't have to wait, change the waiting areas, change the rooms and the conference sites and so forth, so that we would have the ability to see the patients safely. And we wanted to make sure that the patients were not a number, that they were individuals. So we enhanced communication. And I think Susan showed you that, and Stephanie did also, but we really went on what I would call an amazing educational campaign for the patients. We had multiple webinars on Zoom, where we would have 500-600 patients at a time, and we would talk about the virus, what it is, where it came from, and we've had educational things for our physicians and the referring physicians. The idea was to transmit as much information as our system knew to everybody around us so that the patients would know that we're really interested in their care, and so we can prevent also a whole lot of the misinformation. Remember that at those times, people were saying, oh, this is just like a common cold. We have colds every year. Nothing happens. It's the same virus. We really had to dispel that and tell the patients that it's important. And I'm proud of that educational effort because I can't think how bad the number of infections in our post-transplant patients and our pre-transplant patients would have been if we didn't really spend that much time on the education. The data transparency, Susan showed you, every week we would collect all the data about what happened, show it to all the physicians, circulate it to everybody, so we can make decisions. We could make decisions, we want to continue working or stop. Are we going to keep transplanting or stop? This was very important for us. And of course, it was very important for our patients because they knew that we were keeping track of what's happening. I'm not going to relist these because you've heard all of that, but I want to say that one of the most important things we did, besides everything you've heard about from Susan and from Stephanie and from Bemiraj and Wong and Yusuf and Dr. Mobley, our collaboration with Nora's Home is very important. We have a lot of patients that need a place to stay after transplantation. And what we did is we said, because we didn't want to have any infections for our patients for our postoperative period, and the way to prevent that was to offer free screening for the patients that were going to go stay at Nora's Home, because it was a community place where our patients are going to be exposed to each other. And you know, that policy worked. We went through a whole year, almost 15 months now, of our patients being almost 70 or 80% of the people at Nora's Home and not having one infection in that place, which is an amazing feat that talks for how the organization was very sensitive to the complete aspects of the care. And of course, you heard about the COVID task force, which is a leadership group of experts that's really leading the effort to manage that COVID pandemic. Once the vaccine came out, we also used the same technique, which is listening to the voice of the patient. We were very lucky in that our hospital recognized very early on the need of the transplant patients, and we were able to secure prioritization for transplant patients. Actually, after the healthcare workers, then the older patients and the transplant patients were immediately in the second row of vaccination. We also were able to secure prioritization for the living donors because we recognized that the faster we can vaccinate the living donors, the faster we're going to be able to resume living donor transplants. And I have to credit Dr. Gabriel, Dr. Wong, for the sort of brilliant design of a biobank to collect and store samples from our pre-transplant, post-transplant patients. And through the work of the Transplant Research Organization, we actually consented almost 1,000 patients in the 1 week or so that we did vaccinations in to store specimens that are going to become an important asset for us going in the future in terms of research. We made it easy. I have to say that the transplant managers, directors, nurses, staff, the effort to vaccinate the transplant patient was so well coordinated, seamless. We spent a couple of weekend days in the hospital, but we got almost 500-600 patients a day to vaccinate, and every person that wanted to be vaccinated was vaccinated without an incident. That was really an amazing thing. So that's a clinically efficient workflow. And we were one of the first centers in the country to vaccinate their patients. We vaccinated our pre-transplant patients. We vaccinated our living donors. That was an excellent result for us. And I'm sure it's been one of the major reasons why since December, when we started vaccinations, the incidence of our patients that are coming back with lethal COVID infections has decreased very significantly. Now, our healthcare system is a learning healthcare system. That is, you use science, informatics, incentives, culture, all of these things to create a continuous loop of knowing what is happening, modifying the process, coming back with an advanced process as you're going, and continuously learning so that all of our physicians, employees, and the public understand how we're doing this. We also had to have preoccupation with preventing failure. And it didn't matter if the failure was small or large. We vaccinated somebody that was out of order because they sat in the same waiting area for our patients. That was to us, even though it was trivial, so one person got vaccine. But the idea of how the checks and the balances didn't work required a system examination and fixing that failure so that we can prevent it in the future. We practice and practice again and practiced again. So all of our transplant center staff practice what's going to happen when the patients come to be vaccinated, because we knew that the vaccine had a very short half-life. We didn't want to waste it. So when are we going to stop opening new vials? How many people are we going to want to have in line before we can do something like that? All of that was done so that we actually ended up with not wasting any doses of the vaccine, which was an amazing task. And when we had failures, like I told you, we didn't say, oh, that was really simple, don't worry about it. We went after it and we fixed it. I have to credit Julie, Lori, Susan, Deborah, and the other managers for really the work they have done to make sure that this continues to be great. We committed to resilience. Our staff worked tirelessly. We didn't kill anybody, but at the same time, it was continuous hard work, availability. I heard Dr. Boom telling you in the morning he was getting calls at 11 o'clock at night. That was the same thing across the organization. We made sure that the transplant organization worked and worked well, answered all the questions, responded. You know, there were every night, every afternoon, they had a meeting with the Texas Medical Center staff. I think Dr. Boom told you about that. And they changed guidelines and they changed things, and we had to respond to that. And we did that very effectively with extreme safety for our patients. Of course, process improvement became very, very accelerated during the pandemic because we couldn't wait for 3 weeks to have a CMPI. We did that on the go, on the fly through the COVID task force, through the subcommittees of the CMPI, and through personal communication to troubleshoot and fix problems as we went. This all happened because we have a culture of safety. And I think that that's so important to recognize that we couldn't do this without our leadership and culture of safety. And the culture of safety says that everybody in the team trusts everybody else. That trust allows us to report failures, and reporting failures allows us to improve. This is so crucial. That trust is so crucial for the success that we've been able to develop. Nothing was hidden. Transparency was 100%. And people could come and report, and they knew they're going to be taken seriously, that things are going to change because it was all about the patient. I'm not going to go through this, but we all know that there are barriers against the cultures of safety, right? People say they are too busy. We have complex processes, fragmentation of the work, somebody who's hierarchical and just wants to give orders without getting the team involved in what they do. There's always a threat of litigation, the threat of retaliation. But luckily, our teams were so efficient that we didn't have much of that. I think that on top of it all is the role of leadership. When you have Mark Gabriel, Susan Zellix, all the people that I cited throughout my talk, all the program directors, all the managers, all the directors, the director of our floor nursing, the nurses on the floor, the amount of strong leadership that we have is so powerful that I don't think we need to go teach those leaders what to do. They all rose up to the opportunity, to the challenge, and made it happen through the transplantation program. And of course, I couldn't have been more proud than that. And what we told our leaders is lead from wherever you are. We used to say to leaders, wait for permission to lead. We'll tell you when you can actually go take your team and do something. And now, in a transplant center, and of course in the whole hospital, we say lead now from wherever you are, and we will adjust processes as we go through, because the challenge of this pandemic has been so overwhelming that you can't wait, you have to respond. And this is the result. The result is the continued growth in the transplant center. In a pandemic year, we were able to produce more transplants than we've ever done in our history. Amazing leadership from, Mark, Gabriel, Ashish Saharia, the whole liver team, the heart, lung, and the lung team. I'm sure you've taken a bit of a glimpse of the amazing things they had to do and be on the front line, do all of those bronchoscopies and take care of all of these COVID patients and actually transplant them, be some of the leaders of the country in that. That leadership is what led us to that success. 5,500 referrals and almost 700 people listed, 900 people listed on the list during one of the toughest, hardest years in the history of the transplant program. Couldn't have been more proud of the team. So I just want to say thank you for the organizing committee. Thank you for everybody who's persisted till close to 5 o'clock on the meeting. And what a great celebration of the effort of the transplant team in fighting that pandemic. Thank you.
Very good. Thank you very much, Dr. Gaber. We'd like to proceed with a few questions from our viewers. We have one for Susan Zelick. Susan, is Houston Methodist Hospital still doing a screening COVID-19 PCR in the preceding 72 hours of pulmonary function testing and bronchoscopies in the pulmonary lab?
Hi there. Can you hear me okay?
Yep. Yeah.
Great. That is a great question. I know we are still doing some screening testing for diagnostic tests, but I don't know that I have the exact answer for the pulmonary function test lab, but we can certainly follow up on that one.
I had a question for Dr. Yi. I'm wondering if are we requiring our donors to potentially get vaccinated, or aside from just a suggestion?
That's a great question. I think, to my understanding, that is not a requirement. It is also not exactly a requirement for our recipients, although it is strongly encouraged and will be discussed in terms of what will be considered a requirement. But it is highly recommended, and we do review that with each of our donors as they come through for evaluation for donation as well as post-donation.
We ask everybody to be vaccinated. And Stephanie and I spent, a couple of hours in the clinic with the people who refuse to be vaccinated because it's religious, whatever, or they're afraid their DNA is going to get transcribed or something like that. But we haven't canceled anybody that has refused to be vaccinated. So I think it's almost like our general policy in the hospital is you have to be vaccinated to get a transplant unless you can produce evidence that this is just against something that you can't go against. It's been very tough because clearly we're very concerned of putting people, giving them immune suppression, and letting them donate, and then having. Now, after we vaccinated the hospital staff, it became a bit safer to do the donors that refused to be vaccinated because we knew that the risk of nosocomial infections had decreased. And that gave us some confidence that we can do that.
Thanks.
A question for Dr. Osama Geba. Excellent talk, as usual. With COVID, we think we are seeing it coming down with the institution of vaccinations and all the social distancing over the past year. What do you project would be the main system innovations that you predict would happen in the year 2022 for Houston Methodist, and for that matter, transplantation?
I missed, what do I think the innovations?
Would be in future, yeah, after COVID has been conquered, basically.
Well, I don't know that we're going to completely conquer COVID. We're going to have to learn to live with and around it. And I think that's going to be part of the innovation is what do we do? And your speakers today touched on that. Got a second dose, are the antibodies important? So that's all going to be necessary. I think the most important innovations that we've been working on is really this whole concept of, organ donor research, improving the functionality and the survival of organ donors through all sorts of pumps, maybe genetic modification of the organs. And then the long-term, trying to reduce the utilization of immune suppression, try to achieve tolerance through some of the studies that we're doing now. I think there's transplantation is a never-ending innovation sort of field. Maybe Stephanie can add to that if she can think of other things that I've forgotten.
Thank you.
And I think as we get more of the data that has been described during this conference, kind of in real time, we're also trying to think of ways that we can change our protocols, whether that be how we follow up these patients or how we provide the vaccination efforts. I think the vaccine data is in its infancy, and we're hoping to push out our results shortly. But I think that's a huge area of innovation that's going to provide a lot of valuable protection for our donors. I'm sorry, for our recipients, not so much our donors, but also continue the discussion of the importance of vaccination. So I think that's kind of where, in my opinion, the COVID management is heading.
Well, thank you, everyone. I think I speak for all of the panel members that these were 3 terrific talks. I'd like to complete today's program by inviting Dr. Mark Gobriel, who's director of the Transplant Institute, to give some concluding remarks. Dr. Gobriel.
thank you very much, everyone. I mean, this has been a great day from start to finish. I just want to thank everyone who organized the day, all the speakers, all the presenters, and all the effort that went in. We do recognize that we have done a lot, but there's still a lot more to be done. And as we close today, I just want to mention that as the United States is emerging out of the COVID crisis, other countries are still deep in it. So what we learned is going to help us in the future, and we'll have to work more. But kudos to everybody on the Transplant Center. Kudos to all the attendees who stayed with us. And I know there's a large number of people who stayed throughout the day. And all I want to say is thank you. Go and conquer the world, and have a wonderful Saturday. And don't forget, tomorrow is Mother's Day. Enjoy it. Thank you, everyone.